on the chemoprophylaxis, whom, what, when.
And the pointers. Okay. So good morning, friends. Is that okay? The documentation team once gives the okay. So good morning, one and all, and welcome back to the day 2 of GUJPEDICON 2021. And I have been asked, or rather I volunteered to be the stopgap speaker, and yeah, because ઘરના માણસે તો પરિસ્થિતિને એ કરવાની હોય. So because we want to finish the schedule in time, and when we run late, naturally the last part of the conference gets affected. So that is why we, the organizers, have taken the decision. So those who have come with expectation of seeing Amitabh Bachchan and seeing some other actor may get a bit disappointed, but for that we are not having any answer. Anyway, the topic which I am going to discuss is a chemoprophylaxis, to whom, what, when, and when. And in next 25 minutes period, we will be discussing the conditions, when and whom, what we are prescribing as a chemoprophylaxis. So the modern story of antimicrobial started with 1928, when Sir Alexander Fleming discovered the enzyme lysosome, an antibiotic substance from penicillin. This is a famous part of the story, but the unfamous part of the story is that almost 100 years back, a pharmacologist, John Parkington, recommended using the mold for the treatment. The golden era of the antibiotics started with 1940, when the penicillin actually, and then many other derivatives were available at a regular periodic pace for the treatment of various infections. So the antibiotics are the molecules which are most frequently used medications, and most of the time these antimicrobials are used for treatment various bacterial infections, at times for some other microbes, but most of the time it is used for the various bacterial infections. At times they are used in certain prophylaxis. The basic aim of chemoprophylaxis is the provision of antimicrobial agent or agents with the intention of preventing a serious disease or serious illness, prevention of serious outcome of the present illness, or a prevention of a recurrence of infection. So prevention of a serious illness, we know that if somebody is exposed to meningococcal infection, the person is at risk of serious infection. So we offer the chemoprophylaxis to the context. For the prevention of serious outcome of the present illness, a person who is already having rheumatic fever, now when we offer them the chemoprophylaxis for the streptococcal infection, we offer them chemoprophylaxis, primary chemoprophylaxis, to prevent the acute rheumatic fever-like complication. And we provide the secondary chemoprophylaxis to prevent the other complications. Similarly, a patient already having acute rheumatic fever, and when we are providing the chemoprophylaxis for the bacterial endocarditis. So this is the second category where we want to prevent the serious outcome in the present illness. And then there is a prevention of a recurrence of infection. A person who is having, say, underlying urinary tract anatomical malformations, and till the time you are performing the correction of that anatomical malformation, you are providing the chemoprophylaxis to prevent the recurrence of the UTI. So these are the conditions where we provide the chemoprophylaxis. Now, when we provide this, chemoprophylaxis, it ranges from few days to few months or maybe lifelong. Like a child who is having HIV, so to prevent the pneumocystis carinii infection, you will provide the chemoprophylaxis for the lifetime. A child who is born to a tuberculosis positive mother, you are providing chemoprophylaxis for 6 months or a few days, like a person who is exposed to a case of pertussis or a person who is exposed to the case of meningococcal infection. So the duration ranges from few days to months to lifelong. It is again to be offered to prevent the infection in the infection-prone body site. As I said, when there is a congenital malformations in the urinary tract, naturally the child may come with a recurrent UTI. So this site is a infection-prone. So there you are providing chemoprophylaxis. And for a general protection of a vulnerable host, a person who is having, say, asplenia, the person is at risk of infections with pneumococcal organisms. So such cases you will provide the chemoprophylaxis. As I said, the types of chemoprophylaxis ranges short-term, long-term, lifelong. The short-term again few days, few months. Long-term means say 3 months, 6 months, and lifelong. Again, I have already narrated the examples. Now, when we provide this chemoprophylaxis and when we decide about the chemoprophylaxis, we have certain guiding principles based on which we will decide and we will what you call measure the benefits and risks. So the first guiding principle is the risk or severity of the infection should outweigh the risk of side effect from the antimicrobial agent. It should be offered either before the expected period of risk, that is preferable, or as soon as contact with the infected individual, that is the second principle. And it should be given preferably for the shortest necessary period, because we all know that prolonged use of antibiotic will increase the emergence of the drug resistance. And so prescribing this chemoprophylaxis is just like walking on a rope which is tied on both the sides of the bank of a river which is full of the crocodiles. So you have to have a very balanced attitude in prescribing the antimicrobials. Some of the characteristics which are expected from ideal antimicrobial agents are: it should be narrow spectrum, it should be easy to administer, it should be well tolerated, it should have a minimum side effects, and it should be least expensive. Now, with this background, let us see the scenarios where we are using the chemoprophylaxis. So basically, we use the chemoprophylaxis in 4 different scenarios. The first is a prevention of specific disease. The second is a post-exposure prophylaxis. Third is a host-targeted prophylaxis. These 3 are the common conditions where we, the pediatricians, general pediatricians, offer the chemoprophylaxis. And the last condition is a pre-operative chemoprophylaxis, that is a pre-operative prescription of antibiotic to prevent the infection. So that is again, as a pediatrician, we may encounter, but the first 3 conditions we are dealing day in, day out. So I will be discussing in detail the first 3 conditions. So the first is prevention of specific disease or infection. Prevention of rheumatic disease. We all know that streptococcal upper respiratory tract infection is common illness in the younger children between 3 to 8 years. And about 66% of the patient with acute rheumatic fever, they have evidence of upper respiratory tract infection almost several weeks before. And they have even serological evidence also of streptococcal infection. So in these patients, they are at risk of rheumatic disease. And there are 3 different strategies for prevention of rheumatic disease, acute rheumatic fever in the patients with streptococcal upper respiratory tract infection: primordial prevention, primary antibiotic prevention, and secondary antibiotic prevention. So the primary antibiotic prevention, we all know that amoxicillin is the drug of choice, though here we are also mentioning about the penicillin V, but commonly we all use penicillin, that is amoxicillin, and the duration should be total 10 days. Please remember, it should not be 5 days or 7 days, it should be total 7 days, and preferably it should be, if it is used within first week or up to 9th day, it will be effective. So there is no meaning if the patient has turned up to you after 15 days, but when the patient turns to you in the beginning of the illness, when you offer this chemoprophylaxis, it will be effective. Those patients who are not able to take orally, you can use benzathine penicillin, or those allergic to penicillin, you can use erythromycin. For the secondary prevention of rheumatic fever, the commonly used molecule is benzathine penicillin based on the weight of the child, either 6 lakh international unit or 12 lakh international unit every 3 weekly intramuscularly. Those who are allergic to penicillin, again you can use erythromycin 250 milligram twice a day. When there is a debate going on about comparing the penicillin V or IM benzathine in penicillin, the IM benzathine penicillin is better because there is the blood level is higher achieved with the intramuscular injection, and the recurrence rate is less than the oral penicillin. I know the injection benzathine penicillin is bit painful injection, and you need to perform the test dose and all these things, but it is having better clearance, less risk of recurrence, so that is a molecule to be preferred. The question comes, how long should we prescribe? So a patient who is having established carditis or valvular damage, it is to be offered lifelong. The other case is, you will continue this secondary chemoprophylaxis for 5 years after the last attack, or until the patient attains the 25 years of age, whichever is longer. Now then comes the second chemoprophylaxis in cases of rheumatic fever, that is about the bacterial endocarditis. So children with structural heart disease, they are at risk of bacterial endocarditis, and they can have a bacterial endocarditis following spontaneous or a procedure related bacteremia. Please remember, not necessary that the patient is undergoing the procedure and then the patient develops bacteremia. So it can be even spontaneous also. Though there are no randomized controlled trial which are definitely proving the utility of chemoprophylaxis, but still we have been using, and the AHA 2007 guidelines are following. So when to offer the chemoprophylaxis? The chemoprophylaxis is to be offered in all the patients who are having prosthetic cardiac valve or prosthetic material used for the valvular repair. There is a past history of endocarditis, definitely you will use. When there is a cardiac transplant recipient who has developed valvulopathy or a congenital heart disease. So the congenital heart disease is a very big spectrum. So in congenital heart disease, when should we offer? So any congenital heart disease where there is an unrepaired cyanotic CHD with palliative shunts or conduits are there, or completely repaired CHD with prosthetic material or device in the first 6 months. And the third category is a repaired CHD with residual defects. So these are the 3 conditions as per the AHA 2007 guideline. The Working Group of Management of CHD in Children, they recommend chemoprophylaxis for the 3 other conditions, that is bicuspid aortic valve, patients with VSD and PDA. Now the procedures which require chemoprophylaxis are the dental procedures, surgical procedures, which is involving respiratory mucosa, including tonsillectomy, adenectomy, bronchoscopy, endotracheal intubation, and procedure which is involving the infected skin structure. So it's a quite an exhaustive list. There are no clear guidelines about prophylaxis in GIT or GUT procedures. And again, the here commonly used molecule is amoxicillin, 50 milligram 1 hour before if you are using orally, and second dose after 6 hours. Patients who are allergic to amoxicillin, they can be offered erythromycin and clindamycin. Patients who are not able to take orally, you can offer parental ampicillin or clindamycin. But in this case, high risk case, you will go for a second dose of ampicillin after 6 hours of the procedure. Then I think for the UTI, again we have our Indian Society of Pediatric Nephrology consensus statement. for all children who are following treatment with the first UTI in the first year of life until the investigations are complete, UTI with VU reflux, renal scar, until the underlying defect is existing, or children with recurrent febrile UTI. And the prophylaxis we know, so I am not going to the detail of it. The second category of the conditions are the post-exposure prophylaxis, where there is a exposure to some infections which can be life-threatening or which can have a morbidity. So in such cases, we definitely will like to prevent the infection in the context of that person. So the first and most common infection which we all encounter is a pertussis. So the chemoprophylaxis is to be offered to those who are in contact with the index case for more than 4 hours in a day. Now here you have the different molecules which we can use: erythromycin 40 milligram per kilogram per day for 14 days, or a clarithromycin for 7 days, or a azithromycin depending on the age of the child. The duration is 5 days, but depending on the age of the child, you will have a 10 milligram per kilogram per day for 5 days, or 10 milligram loading with follow-up of 5 milligram per day for 2 to 5 days. The second condition, which is very dangerous condition, is a meningococcal infection, and those who are close contacts or a household contact. So any, even the healthcare workers who come in a contact with the patient with a meningococcal infection, their secretions, they are to be offered the chemoprophylaxis 7 days before the onset. Means the time period of exposure is from the time before 7 days of exposure to the illness to the time of the exposure. So suppose patient has come with the meningococcal meningitis today, it has been diagnosed today. Those who have come in the contact with the patient in last 7 days, they are also to be offered because they have the risk. Now here the preferred molecule is rifampicin, and we offer it 4 doses, 10 milligram per kilogram every 12 hourly for 2 days. Or you can use ceftriaxone single intramuscular injection for children less than 12 years, 125 milligram, children more than 12 years, 250 milligram. Or you can use ciprofloxacillin also for the chemoprophylaxis. Again, for diphtheria is a one infection where all asymptomatic household contacts are to be offered. Those who have had an intimate respiratory or habitual physical contact with the patient, again they are also to be offered the chemoprophylaxis, and the options are benzathine penicillin or erythromycin. Though Haemophilus influenza B infection nowadays we are not seeing that commonly, with the immunization with the influenza vaccine is a better strategy for the prevention of influenza in general in the population. But for the context, you can offer the oseltamivir based on the weight of the child. Then we know about the Mycobacterium tuberculosis chemoprophylaxis. If the mother is having drug-sensitive tuberculosis, please remember chemoprophylaxis, isoniazid in 10 milligram per kilogram for 6 months. Okay. Then about the malaria prophylaxis, again this is not recommended for those who are in the malaria endemic region, but the people who are not residing in malaria endemic region and then they are traveling to malaria endemic region, they are to be offered, migrant laborers to be offered, as well as the military personnel are to be, who are exposed to the malaria in a highly endemic area, they are to be offered. Again, the chemoprophylaxis depends on the prevalence of local resistance pattern. So say in certain parts of our country where you have resistance to chloroquine, so if the child is coming and going to stay in the traveling in that area, then you can't use the chloroquine for offering the chemoprophylaxis. So in short, you should have the information whether to use chloroquine, mefloquine, doxycycline, and it should be started 2 weeks before the departure from the point of the origin and should be continued for 4 weeks after returning to the area where the child or the parents are living. The third condition is a host-targeted prophylaxis. I am just seeing how much time I have left. So, we know that persons with asplenia, they are having a high risk, almost 60 times greater risk for getting sepsis as well as fetal sepsis. Risk is 200 times. And we know that 80% of infections are due to the bacteria with a capsular polysaccharide, that is H. influenza and pneumococci. So, as pneumonia. So, in this case, naturally, you will like to offer the chemoprophylaxis to the susceptible host who is having compromised immunity. So, here the drug of choice is penicillin. You can use penicillin V or amoxicillin, 125 milligram twice a daily for children less than 5 years, 250 milligram twice a daily for children more than 5 years. Or you can use benzathine penicillin intramuscularly every 3 weeks. How long to be given? Again, the duration remains controversial, but the current practice is to provide the penicillin prophylaxis indefinitely. Of course, you will definitely provide these children with the vaccine so that vaccine also can contribute in prevention of the infections. The individual who are having immunocompromised conditions, they are at risk of various infections including recurrent bacterial infections, Mycobacterium tuberculosis, recurrent viral infection, but the most important is Pneumocystis carinii infection. And for prevention of PCP, we either can use trimethoprim and sulfamethoxazole, or we can use Depson or pentamidine. But please remember, these are the cases which are to be managed by the specialized trained personnel. So, there are ART centers, and it is always better to refer our such patients for in general holistic management at the ART centers. The last category, as I said, I am just quickly taking through the surgical site infection. Yes, I will be finishing. So, this is mainly dealt by the pediatric surgeons. So, there are studies that WHO conducted studies that has shown that in post-operative infections, based on whether the wound is clean contaminated or contaminated, there is a prevalence of surgical site infection, and that is why we need to offer the chemoprophylaxis. And their major pathogens, again we know, Staph aureus, coagulous negative streptococcus, enterococcus, E. coli, Pseudomonas, the notorious bugs, they are the cause for the post-surgical site infection. Some principles are always to be offered by IV route because the absorption with the oral medicine may be erratic. The third generation cephalosporins, the cefotaxime, ceftriaxone, cefazolin, ceftriaxone, they are the drug of the choice. Penicillin allergy patient, you can use Clinda plus Genta. In a colorectal surgery, again you add the metronidazole. Please don't start too early and don't start too late, because the basic purpose of preventing the infection during the surgical procedure is to cover the bacteremia, and so it is always, there are stipulated guidelines during which if we offer the chemoprophylaxis, there will be a better coverage. So, if the surgery is going to last less than 4 hours, number of doses are only 1, and the dose should be given 1 hour before the incision. If the surgery is going to last for more than 4 hours, or if there are major blood losses are accepted, in that case 2 doses are to be offered, 1 dose 1 hour before the incision and second dose at the mid of the surgery. So friends, what Benjamin Franklin said, an ounce of prevention is worth of pound of cure, and if we offer the chemoprophylaxis in time to the people or to the patient who definitely deserve, as per the indications mentioned in my presentation, it will definitely improve the outcome of the patient. Thank you so much for the opportunity, and thank you SPECT as well as GUJPEDICON organizing committee.
Thank you, sir. for refreshing and updating our knowledge on chemoprophylaxis. Today we are going to cover some conditions that are googly, which we encounter in our day-to-day office practice, that are neonatal endocrinal conditions. For that, I would like to call upon our young and dynamic faculty from Rajkot, Dr. Jhalak Upadhyay. We welcome you, ma'am.
Good morning to one and all. Before I begin, I would like to thank Team SPACT and the organizing committee of GUJPEDICON and AOP Gujarat for giving me this opportunity to be here amongst you. So today I'll be discussing on neonatal endocrine conditions. Though a vast topic, I would like to do justice whatever possible. So today's topic is to highlight some of the common endocrinopathies that we encounter during the practice. And we know that neonates may display clinical signs of an underlying endocrinopathy that may have not been apparent either in utero or at birth. So today what are we going to discuss? Disorders of thyroid gland, glucose homeostasis, calcium homeostasis, disorder of sexual differentiation, and disorders of pituitary. I would like to cover whatever possible in the given time. So a case-based discussion. This is case 1 where we had a 10-week-old neonate with complaint of abdominal distension, constipation, and mother says the child is a very quiet and well-behaved child. So this is a spotter, like what we see here is, yes, hypothyroidism. So look at the periorbital puffiness, protrusion, abdominal distension. So this was missed at birth, and at 10 weeks what we have is primary hypothyroidism, where the free T4 is low and TSH is very high. So any fall of free T4, there will be exponential rise of TSH. If not, then we have to suspect central hypothyroidism, that is secondary or tertiary, where the fall of free T4 will be there, but TSH may not rise exponentially, may be marginally elevated or normal, or could be low also. So this is a case of primary hypothyroidism where the thyroid gland was at the fault. Then we went ahead for the nuclear scan where it revealed thyroid agenesis. As we know, in congenital hypothyroidism, 80 to 85% of kids have dysgenetic gland. That may be agenesis, hypoplasia, ectopic gland. So this is what a normal gland looks like, and this is the patient's absent thyroid gland where we do not visualize the uptake of technetium. So a technetium scan was done and this was proved. What happened on follow-up? Parents were counseled regarding the etiology and lifelong treatment because the gland was absent. The child was started on levothyroxine given as a single morning dose, and then the child improved. But unfortunately, what happened here? As we missed the diagnosis, there was residual neurodevelopment delay, and any delay in the diagnosis of congenital hypothyroidism, it decreases the IQ. So beyond 2 weeks, it decreases the IQ of the child. So in a busy OPD, what are the red flags for diagnosing congenital hypothyroidism? When do we suspect it? When there is a persistent neonatal jaundice beyond 1 week of age, the child has constipation, abdominal distension, the child is quite well behaved, doesn't cry much, is not much fussy, cranky, has delayed milestones, is a short baby, has wide anterior fontanelles, protruding tongue, umbilical hernia, and hoarse cry. Remember, almost 95% of babies do not show any symptoms at birth, so do not wait for symptoms to occur to investigate the child. That is why it is a birthright of every newborn to undergo thyroid screening. So these are the, some of the criteria where incidence is high in India. That is why it should be screened, included in the newborn screening. As we know, some of the countries do T4 and TSH both. India, we usually do TSH for the thyroid screening purpose, and it's very cost effective. Clinically, we know that 95% of kids are normal at birth and they become symptomatic only after 3 to 5 months of age. And if therapy, as we know, it's very effective, simple, and inexpensive. And delay in starting treatment. This is very important. We know that it is a preventable cause of mental retardation, and it causes permanent mental retardation. Each month of delay in treatment can decrease IQ by 5 points after the age of 2 weeks. So that is why it should be the birthright of every child. Now, this is a flow chart which I have taken from ISPE, Indian Society of Pediatric and Adolescent Endocrinology, where if we go online on the site, you will find the guidelines for congenital hypothyroidism. So, heel prick or cord blood, and then what I want to highlight here is how do we interpret once we take the sample. So, this is TSH, this is TSH, this is T4. If TSH is high and T4 is low, what is it? It is hypothyroidism. And what do we do? Treatment should be initiated soon, must before 2 weeks of age. If TSH is normal, T4 is normal, that's normal. Thank you. And when do we treat? So any total T4 or FT4, total T4 below 10 and FT4 below 1.17 nanogram per DL, we have to treat. But if the T4 is normal, what is the range of TSH? When do we treat? So TSH more than 20, less than 2 weeks old child, and if more than 2 week old child, TSH more than 10, we have to treat. So this is the interpretation. More than 20, we have to repeat. If on cord blood or heel prick, if we find it more than 20, we have to repeat. And we repeat what? Venous sample, TSH and T4 both. If T4 low, we have to start treatment. If T4 is normal but TSH is in this range, we have to start treating the child. So how do we treat and how do we monitor? What do? We start tablet levothyroxine, which is quite cheap, and it started at 10 to 15 microgram per kg per day. As a single morning dose is what we give, not in the night or evening. What do? We crush the tablet, ask the mother to take 1 spoon of EBM and then dissolve in it and give it to the child. There should be no leftover. Any other tablets or supplements should be taken after a gap of 3 to 4 hours. We follow up 2 weekly after the starting dose, then later 2 monthly, and depending on the age, we then do it 3 monthly or 6 monthly on the follow-up. What do we target? We target free T4 in the upper normal range and TSH in the normal range. I would take one more slide on hyperthyroidism before I jump to the other system. Hyperthyroidism, it's quite rare in neonates, but infants born to mother with Graves' disease. Why? Because of the transplacental passage of TRAB, that is TSH receptor antibodies. There could be inhibitory or stimulating antibodies. Depending what has passed to the child can have anything. If it is inhibitory, child can have hypothyroidism. If it is stimulatory, child can have hyperthyroidism. So hyperthyroidism in a neonate, that is Graves, it can be because of transplacental passage of TRAB. Also, it could be because of gain of function mutation of the TSH receptor. How do we suspect? In utero, fetal tachycardia when more than 160 per minute in 3rd trimester is suggestive of fetal hypothyroidism, and we have to treat the mother with antithyroid drugs. Neonatal hyperthyroidism, tachycardia is the main feature. What else can the child have? The child can have prematurity, low birth weight, weight loss, failure to thrive, diarrhea, irritability, and thyromegaly may be seen. So how do we treat? It's with methimazole and carbimazole. Going to the next system. Here is a case 2. A baby on 3rd day of life presents with hypoglycemic seizures, and on admission when we did RBS, it was 26 milligram per deciliter. Child was given D10 and then started IV fluid, where later GIR, the glucose infusion rate, was increased to 12 milligram per kg per minute, and child was given injection hydrocodone due to persistent hypoglycemia. Later shifted on oral feeds with addition of dextrose, but still had some asymptomatic hypoglycemic episode, but the child was discharged. That the child is asymptomatic, so we'll discharge the child. So what went wrong here? The first thing, when the GIR is so much, 8 or more than 8, we have to suspect that there is something wrong with the child. The child may have hyperinsulinism. That is why the GIR is required at such a high rate. Without diagnosing, giving only hydrocodone does not help. Adding dextrose to feed never helps. We shouldn't do that. It will otherwise cause rebound again, hypoglycemias. And asymptomatic hypoglycemia, because of the hypoglycemic unawareness due to repeated episodes of hypoglycemia, we shouldn't ignore them. So what happened? First of all, what we like to do is we would like to rule out feeding issue, and then we'll blame mother. Okay, but you have not given the feeding well, that is why child has gone into hypo. So this was LSCS delivered and mother had issues with the secretion, which is very common. So, but even then, so this was attributed to feeding issues, but even then, why we had to suspect that there is something wrong going on? Because the child with RBS of less than 50 after day 1, it warrants further workup, and this baby also had frequent hypos and required a high GIR. So, what was necessary here? What we had to do here in this case of hypoglycemia? Very important, taking a critical sample. What is critical sample? The sample taken when the sugar goes less than 50 milligram per deciliter. So what do? We take 2 samples, one is blood and one is urine. In blood, what we do is blood sugar, beta hydroxybutyrate, that is ketones, free fatty acids, ABG, electrolytes, ammonia lactate, growth hormone, cortisol and insulin. This is what we send. And urine, the urine sample taken at the time of hypo or the first urine taken any time after the hypo episode. So what do we do in urine? We check for ketones and reducing substance. So this will give the clue of what's happening with the child. And then this is how we approach to a child with hypoglycemia after taking critical sample, what's happening. So this is acidosis. If the child on ABG we find that there is acidosis, again there is bifurcation where we have high lactate or high beta hydroxybutyrate, that is ketoacidosis. And then if high lactate, G6Pase, FDPase deficiency, pyruvate carboxylase, ketoacidosis, and it can be normal or ketotic hypoglycemia or GSD. And if no acidosis, what happens is if high free fatty acid level and low beta hydroxybutyrate, it is because of fatty acid oxidation defect. Doing free fatty acid is very costly, so we usually try to not do it. And low free fatty acid, low beta hydroxybutyrate, it is because of hyperinsulinism or panhypopituitarism. So what happened with this child later? This child was then, when the critical sample was taken, was diagnosed to have congenital hyperinsulinism. What happened? Critical sample revealed no ketones, free fatty acid was not done, insulin was very high. Any detectable insulin or insulin more than 2 is high. Child did not respond to diazoxide, so we have 2 drugs, diazoxide or octreotide, but not responsive to diazoxide, so genetic workup is ordered in a child with congenital hyperinsulinism. Child was later shifted to long-acting octreotide, lanreotide every 28 days, but always asked for a history of low sugars or diabetes in parents. So genetics, what did we find? ABCC8, paternally inherited mutation, that shows that there is some focal lesion in the pancreas which needed to be removed so that the child is free of any drugs and free of hypoglycemic episodes. So surgical excision could be done. That is why this genetic report was very important in this child with hypoglycemia. I would like to take one slide on neonatal diabetes, where a genetic workup is must in a child with neonatal diabetes. Why? Because there may be some varieties like transient, which can be okay by 3 to 6 months of age when patient understands this is a miracle and we have cured the child. But because of some mutations, it could be transient or permanent. So there are mutations again in ABCC8 and KCNJ11 where we can give sulfonylurea if the mutation is positive and the child does not require insulin at all. So that is why doing genetics in a case of neonatal diabetes who have been diagnosed before 6 months of age or occasionally before 12 months of age, it's very important to do a genetic workup in such child. So here what do? If genetic is negative, we have to put the child on insulin. We put it with 0.5 unit pen which is available, or we can also dilute the insulin with the diluent given. If no diluent is given, we dilute with normal saline. So now comes a difficult case, not only for pediatricians but also for a pediatric endocrinologist, DSD, disorder of sexual differentiation. So this child, 15-day-old, was reared as a boy and came with complaint of vomiting since last 3 days with breathlessness, not gaining weight and increasing skin pigmentation. On examination, ambiguity was seen. Now we no longer say it as ambiguous genital, we say it as DSD whenever we put the diagnosis. So this is again a spot diagnosis, child is hyperpigmented, look at this, absent scrotum and the phallus is large with only a single opening. Any guesses? CH, yes. So what are the red flags? When do you suspect a DSD in a child? So for apparent looking male, if there is bilateral undescended testes, bifid scrotum or hypospadias with any other abnormal finding like undescended testes or micropenis. Even severe hypospadias like scrotal or penoscrotal, it needs workup. Apparent female looking child, when the child has clitoromegaly, that is more than 0.9 millimeter or 1 centimeter of clitoris, single opening, and inguinal hernia. Now, how do we score them? I wouldn't go much in detail of this. This is external masculinization score, EMS. This is how we do this, and it's easily available in the internet. If apparent looking male infant, we use this, and if female infant, then Prader score. That is how we stage this. From stage 1 to 5, how severely virilized is the child. So we should never be in a hurry to declare the gender of the baby at birth, because it's a very big trauma to the child. Whenever a child is delivered, look at the genitals properly, look for the palpable gonads. Usually, if there are 2 palpable gonads, testes is palpable, it's a male. Most of the time, it's a male, so you can never be wrong. But if absent, we have to do workup. So, virilized female, most commonly it's CAH, congenital adrenal hyperplasia. And CAH, we know it requires urgent referral because of the salt wasting and adrenal crisis, which usually happens after first week of age. So in second week onwards, they'll have this crisis. And under virilized male, they have many reasons. But before undergoing surgery, the child should be referred to get all the workup done, because there is a period called mini puberty. After 4 to 5 weeks of age after birth till 6 months of age, every child undergoes a puberty. That is called mini puberty, and that is the best time to pick up all the disorder of sexual differentiation to do any workup, because the LH, FSH and all the sex hormones will be at a very good level, and picking up the disorders will be very easy in this stage. But what do we remember? That more than 40% of 46XY-DSD, undervirilized male, they remain undiagnosed even after exhaustive workup. They'll also have to undergo genetics and a lot of workup, but they may remain undiagnosed. So this is taken from the textbook, that this can be difficult, undervirilized male. So how do we manage CAH? Initial investigations, 17-hydroxyprogesterone, testo, androstenedione. This is a quite bigger list. DHAS, plasma renin activity, cortisol, and urinary steroid. If at your level, if you just want to do investigations at like the minimal ones, then cortisol, 17-OHP, and testo is important. Then we also do USG abdomen and pelvis to look for adrenals if they are hypertrophied, and also look for Mullerian structures and gonads. That is what we order. And karyotyping is a must. How do we treat? We give Hyzon at 10 to 14 milligram per meter square per day in 3 divided doses. It should be in 3 divided doses, 8 hourly. Fluorocort, so fludrocortisone, some prefer at OD dose or BD dose, anything is fine. And salt should be supplemented till 6 months of age, which should be around 1 gram per day. Genetic counseling is must, because this is autosomal recessive and there is 25% of chance of recurrence. And follow-up, what do we see? Bone age after 2 years, electrolytes, 17-OHP, testo, androstenedione. Height and weight is very important, and we also ask for lethargy or salt craving if the child has any. So how do we approach a child with DSD? Palpable gonads. First we look for palpable gonads. If they are present, we also look for Mullerian structures in USG. If there is Mullerian structures, there is something to do about anti-Mullerian hormone. So we order AMH, and then depending on low or high, dysgenesis or resistance. If palpable gonads are present and Mullerian structures are present, not present, what we do is testo. If it is low, we look for salt status. If the child has salt wasting, these are the investigation. If associated with hypertension, these, and if normal, these. So I won't go much in detail of this. If palpable gonads are absent, Mullerian structures are present, so 17-OHP and deoxycortisol, this suggests of CAH. And what other disorders? Maternal virilization, aromatase deficiency, POR, and if no cause, we have to rule out dysgenetic gonad, so gonadal biopsy is must. So this is how we approach. Yes, I'll finish. Last case, won't go much in detail of this. 2-month-old girl with seizures, was on exclusive breastfeeding. So had seizures, so what do we order? So the routine workup, CBC, SGPT, creatinine, electrolytes, and ABG was done. Everything was normal. When we did a calcium, even RBS was normal, which had to be done. Calcium when done, calcium was low, phosphorus was low, ALP was high, and vitamin D was 3. So in a neonate, when we get a child with hypocalcemia, we also have to look for mother. So what is mother's calcium profile? So this is what was seen, that the calcium was borderline, phosphorus was okay, ALP was fine, vitamin D was low. So what we did? We here have to treat both child and mother. So even treating the mother is also important in a case of hypocalcemia in neonates. So how do neonates present? So subtle, they may have poor feeding, vomiting, and if acute, they may have seizures, apnea, jitteriness, high pitch voice. And otherwise, the signs are CCF, cardiac failure, tachycardia, bulging fontanelle. I won't go much detail into this. So how do we manage? So here, this is very important. We just cannot keep giving boluses. What we do is, we give one bolus of calcium gluconate, 10%, the ampule which is available. We give 2 ml per kg over 10 minutes with ECG monitoring. Later on, we just don't keep giving boluses. After this, we shift them on infusion. And how do we make the infusion? We prepare 1 milligram, 1 ml solution of, so what do we do? 990 milligram of calcium. That is 11 ampules to NS D5 containing solution to provide final volume of 1000 ml. And then what do we do? So 1 mg, 1 ml solution, we start around 0.5 to 1.5 ml per kg per hour. We give it for 10 to 12 hours. After 10 to 12 hours, when we check, the calcium will rise at least by 2. So this is what we do. If you keep giving boluses, child may have hypercalciuria and may not improve. So after giving one bolus, this is what we do, give an infusion. But remember, the sites are very important because calcium can extravasate. Prefer transition to oral as soon as possible. And what are the salts? Calcium carbonate with maximum bioavailability, citrate, lactate, gluconate, and glubionate. So this is a very important chart given in IP, Indian Pediatrics, and anybody can download it, very easily available. How do we treat a case of calcium and vitamin D deficiency? Only after 3 months of age we give sachet. That is 6 sachet weekly, 60,000. Sachet or nano syrups, whatever are available. But before that, what do we do is giving 2,000 units per day for 3 months in less than 3-month-old child, infant. So this is how we treat. After that, it's only 6 doses. Never give injection with vitamin D, 6 lakh IM stat, because now that is out. That was called STOS regimen. It causes hypercalciuria, nephrocalcinosis, so that is out. What we do is giving weekly doses, or if less than 3 months, giving everyday doses. And the calcium doses are also given, so you can refer this. What are the key points in a case of hypocalcemia? Always remember to do calcium profile as a whole, calcium, phosphorus, ALP, because it gives us idea of the etiology, whether it is, if both are low, ALP is high, it's vitamin D deficiency. If both are in opposite direction, calcium low, phosphorus high, look for hypoparathyroidism, parathyroid conditions. When both go opposite, when both are in the same direction, it is related to vitamin D. So doing calcium profile as a whole is important. Do calcium profile in mother simultaneously. Do magnesium level if refractory hypocalcemia or you are suspecting hypoparathyroidism, because only supplementing magnesium can solve the issues. PTH is a very sensitive assay, and remember, it has to be done when the calcium is abnormal, not in the normal level of calcium. Calcium normal and you have sent PTH, that is of no use, just spending money and wasting money. So if the calcium is high or low, only then send the PTH. PTH is very sensitive assay. It has to be collected immediately and sent immediately to the lab to run. And urinary calcium by creatinine ratio and dysmorphic features to be seen if the child has hypoparathyroidism. One more condition, osteopenia of prematurity, where these days we find this a lot because of the preterm.
Excuse me, ma'am, your time is up.
Done. Thank you. So this can be preventable, and that is why this is important. I won't cover hypercalcemia. Thank you so much.
Thank you, ma'am, for your crisp presentation. And now I request you to proceed to the memento corner. And I request Dr. Swati Vinchukar, ma'am, to facilitate her.
So we move on to the next lecture. The topic is a very common condition. Doctor, my child is not eating well. And to enlighten us on this topic, I invite Dr. Parang Mehta. Dr. Parang Bhai is a senior pediatrician from the branch, ex-president of the branch. He has also been the ex-member of the Committee of Immunization and ex-editor of the Bulletin of Infectious Disease chapter. A very soft-spoken person, but highly knowledgeable. He is a troubleshooter for the branch. Whenever there is any problem, he has a solution.
Is it working? Yes. Can I start? Good morning, people. At the beginning, I thank the organizing committee of the GUJPEDICON 2021 for inviting me to be here. And I thank all of you to choosing to be here on a Sunday morning. We have heard a lot about the exotic conference in the exotic program. I have nothing exotic. I have something very, very common. Doctor, my child doesn't eat. It's the most common words heard in a pediatrician's consulting room. The child may have come with pneumonia, with asthma, with severe dehydration, but this is always added on. You know, it becomes background noise for us. Every mother says it. Your wash basin says tup tup, your AC says ghar ghar, and the mother says chokro khato nathi. You know? We become so used to it. Mother says chokro khato nathi, and we say bahut saras ben cash che ke Google Pay. So, but you know, remember the story of the boy who shouted tiger, tiger. The tiger really came and no one paid attention. Sometimes it really happens there is a problem. So when mother says, mera bachcha kuch khata nahi hai, at least have a look at the child. If the child is obese, if the child is overweight or normal weight, you can be assured. But if the child looks thin, he looks like he has lost weight recently, if your growth chart shows that there is growth faltering, then you should pay attention. So keep an open mind and always maintain a growth chart. So here are the organic causes. And since everyone is a pediatrician here, I don't need to discuss this. What we'll be discussing today is non-responsive feeding, selective eaters, and the topic you have all been waiting for, ARFID. So, responsive feeding is something that is taught to mothers in many countries in the world, but is never taught to us. Responsive feeding means you respond to the child. The child will communicate feelings of hunger and satiety, a younger child non-verbally, an older child verbally, and the mother should respond to it. We always tell our mothers, when ki chokro rade tyare breastfeeding apo. But actually mothers learn, how to anticipate the child's hunger. Before the child starts crying, he's sucking his thumb, he's putting his fist into his mouth, moving his head vigorously side to side, making chewing movements, smacking movements. The mother knows he's hungry. He will start crying in a minute, so she starts feeding before that. And when the child is full, he goes to sleep. You cannot force feed when you are breastfeeding. But the same thing does not happen when you start semi-solid feeding. The mother doesn't respond to hunger, all right. But our mothers do not respond to satiety. When she gives 10 spoons and the child takes it, but at the 11th spoon when the child turns his face away, she doesn't accept that signal. She wants to feed it. I have to finish this much. Yesterday he ate this much, today he is eating less. My neighbor's child eats this much. Mari dirani nu chokro atlo jado che. And of course the most common, atlu bachelu che hu kya mukwani. So she goes on forcing the child. So our advice should be provide appropriate and nutritious food and maintain an appropriate feeding environment. See, the eating experience should be pleasant for the child. The mother should talk to the child, laugh with him, sing to him, read to him, and not do other things. Don't feed with one hand and watch TV, or don't be scrolling your phone with the other hand. The child should enjoy the eating experience, then he will continue to like to eat. So the advantage of responsive feeding is development of healthy eating behavior. The child learns to eat when he is hungry, and he learns to stop when he is not hungry. See, 30 years ago, our consulting rooms used to be full of protein, energy, malnutrition. Today, we are full of obesity. Because children are not learning how to stop. They eat all day. Khatat jai. They don't know when they are full because mothers are used to force feeding. Development of self-regulation and self-control of food intake. These children, if responsive feeding helps them to maintain ideal growth standards, optimal nutrient intake, and long-term regulation of weight. So this is Satter's division of responsibility in feeding. Parents decide the what, where, and when food is to be offered. But the child will decide whether or not food is eaten and how much food is to be eaten. This is what is the ideal. But our parents don't accept this. I'm going to decide what he will eat, where he will eat, how much he will eat, which school he will go, which extra classes he will go, lagan konathi karshe, huj nakki karwano na. So this is known as authoritarian feeding, authoritarian behavior. Forceful and restrictive, they hold the child down on the floor and stuff food into his mouth. So, then you get these complaints, the mother complains कि मैं कटोरा लेके आती हूँ और ये उब के चालू करता है. वाटको જોઈને રડવા માંડે છે, ભાગી જાય છે. That is bound to happen. You have made the whole eating experience so unpleasant for him that he doesn't want to eat. And he starts crying, being distracted. So this is known as non-responsive feeding, not waiting for hunger. Now that happens, if the mother has to go to work at 9 a.m., she will feed the child at 8:30. That is not bad. What is bad is ignoring satiety. When the child signals that I am full, the mother doesn't stop. She goes on forcing him to eat. The reasons are anxiety about growth and weight gain. They want a child that is healthy and fat. There is pressure from family. Every visiting family member says, "Bachcha bahut weak hai, tamaro chokro ketlo kamjor che." So she responds by overfeeding the child. And child doesn't learn to control his own eating. So management here to realize that there's nothing wrong with the child. It's the family that has to be treated, and it's very difficult. You have to convince them that force feeding is harmful. And it depends on who has come to you. If the two ladies have come and you tell them don't force feed, you will have two blank faces because the mother is doing it and the grandmother has taught her to do it. But on the other hand, if the father and mother has come, you will get an outburst from the father, हाँ ये ऐसा ही करती है. बच्चा एक कप दूध पीता है, दूसरा ले आती है कि एक इसने अपने आप पी लिया, एक मैं पिला देती हूँ. And it's very tempting for us to join in the mother bashing, but we shouldn't do it. Realize that maintaining that child's good health is a partnership between us and the mother. So you have to tell her gently. Don't tell her, don't force him. What you tell her is कि हमेशा इसको बिठा के खिलाओ. When he's sitting up, you can't force feed him. So sitting up feeding is the best. Once the child, as it is, we recommend complementary feeding only after 6 months. By then, most children have learned to sit. Feed him sitting and stop feeding when he turns his face away. But I will also tell you that this established pattern is very hard to break. See, when they complain to you, they have been force feeding the child for 3 months or 6 months and the child is used to not eating. He has become so averse to the eating experience, he doesn't want to eat. So when they stop force feeding, the child stops eating. And there is no mother on earth who can tolerate her child not eating for 12 hours or 14 hours. By evening, she will be doing the same thing, putting him on the floor. Kaink to jaye chhe ne pet ma. So what we need to do is anticipatory guidance. When the child comes to you for your 4-month or 6-month vaccination visit or any other illness, you have to teach them that next month you have to start semi-solid feeding, and this is how you do it. Get the child to sit up. If he can sit up on his own, fine, or sitting with support. Feed him by spoon. These are the things you have to give him, these semi-solids, how to do it, and how to stop as soon as he gives signals of satiety. So how and when to introduce food? New food policy. Give one food every day, 3 times a day for a week till he gets used to that food. Next week, start one new food. And introduce almost everything you want to give him by the time the child is 12 to 15 months old. Because after that, children become fussy and don't accept new things. Never, never, never force feed. Hunger is good, especially for older children. If a child comes hungry to the dining table, he's been hungry for half an hour before lunch, it's not bad. There's nothing wrong with it. It's normal. So growth, weight gain and appetite reduce after the first year. We know that in the first year, a child goes from 3 to 10 kg, puts on 200% weight. Second year, he grows from 10 to 12. That's 20% weight. His appetite is going to be reduced. And appetite is not the same every day and meal to meal. It is going to be variable. Second issue today is selective and picky eaters. Up to half of preschool children and up to quarter of older children have picky eating. They eat less, they are very selective, there is very little variety in their food. And just because this behavior is common doesn't mean it's good. It's a harmful behavior. It is associated with impairment in emotional, physical, and social domains. These parents don't want to go to parties and functions because their child embarrasses them. They avoid party, they can't travel because he eats only 1 or 2 things that his mother has to cook. So they can't go on pravas, they have to stay home all the time. And 63% of parents reported that doctors don't pay attention. Cash check hai, Google Pay. So what is selective picky eating? Most children have very strong food preferences and they avoid 3 of the 6 food groups. Meats, vegetables and fruit. These 3 food groups they don't want. They want to eat only dairy and cereals and other things, mostly carbohydrates. So they need special meals to be cooked for them. The whole family is eating one meal, for them something special has to be cooked. They eat inadequately, they have a lot of micronutrient deficiencies, And the important, there is no one definition. There are multiple definitions of picky eating, but almost all of them include this, that there is a disturbance in the parent-child relationship. Because these children are not 9 or 12 months old. These are 4-year-old child, 6-month-old child. When they act like this, parents are very angry about it. So there are 3 grades of this. Grade 0, no food aversion or only common aversion. The mother, suppose the parents are cooking about 20 vegetables in the home around the year, and he eats 18, the mother complains, ringan ne adakto nathi ne turiya nathi khato. That's not abnormal. That's not picky eating. Everyone is entitled to have some likes and dislikes. Grade 1, out of 20, he eats 6 things only, but when one of those 6 things are available, he eats a good proper meal. And grade 2 is severe. He wants paratha and tomato sauce every day only. That's the only thing he eats. That is severe grade. And we all must have known a few kids like that. Strawberry jam ne puri જોઈએ એને રોજ. So this begins when solids are introduced, especially if you introduce them late. The child may have medical, anatomical or developmental issue. Later on in life, they turn out to have psychological problems. The child prefers carbohydrates. He avoids entire food groups, usually vegetables, meats and fruits. He eats mostly dairy and cereals. They often have anxiety, OCD and ASD, and many meal times are marked by conflict because parents are always trying to get him to eat more things. These are the associations that happen with severe picky eating. These are with moderate, and you will notice only one of them is with the child, 2 are with the parents. So typical, what I described is severe case. Typical selective eating starts around the age of 15, 18 months and resolves by age 5 years. Now these children have a few favorite foods, but they accept others also, and they're a little fussy if their favorite food is not given to them. They have a preference for carbohydrate, but they eat quite well, and it's not really bad. Their growth is good. They grow at about the 50th percentile. Fruit and vegetable consumption is low in picky eaters. But even children whose parents describe them as normal, they don't really like fruits and vegetables. Most children don't want to eat fruits and vegetables. So it's not very different, and they are less likely to be overweight. Food neophobia, the child believes कि पहली बार तो कोई वस्तु खावानी नहीं. So it's very difficult to introduce them to new foods. They reject a lot of food based on taste, color, smell or texture, and this usually happens in the second year, which is why we recommend that introduce everything in the first year itself. When he's young, before he learns to be fussy, introduce him to all kinds of foods. So parents should insist a little. And it's not just enough to put food on the table. You must tell them that the child must eat it, chew it and swallow it. Give it at least 8 to 10 times. Even after 10 times eating, he doesn't like it, leave it. Because children must learn to eat a variety, but it's not necessary to like every food. There's very little quality research on management, but it needs behavioral management. Encourage the child, rewards and cost of defiance. Child should be told, if you eat this, I'll take you out to the park. If you don't eat this, you will not get to watch TV today. That's not bad parenting. That's good parenting, to encourage by a system of costs and reward. It can be a prolonged study, and the entire family has to win. If mother says you won't get sweet dish, and the father takes him out for a triple Sunday, it doesn't work. Diagnostic and Statistical Manual of Mental Disorders, 5th edition came out in 2013. And these are the 6 eating disorders. 5 of them are found mostly in teenagers and older people. But ARFID, Avoidant Restrictive Food Intake Disorder, newly described. These children have very strong likes and dislikes, and mostly dislikes. They like very few things. And they are so determined about it. If they go to a camp and they don't like it, they will skip lunch, they will skip dinner, they will faint with hunger, but they won't eat the food available. Now, these children often have a lot of nutrient deficiencies, and they need supplements to be normal. They don't have body image issues. They are not trying to remain slim. They don't have anorexia nervosa. They don't have any medical or mental health disorder, and there is no shortage of food in the home. But they just avoid, and they are restrictive. So there are no evidence-based treatment recommendations as yet. It's a new kid on the block. You need an individualized treatment plans. What factors are driving the distress? You need a psychologist, a psychiatrist, a behavioral therapy. Have a multidisciplinary team, because treatment is not very successful and you can all point fingers at each other. Some general thoughts. Grazing is for cows. You know, cows eat all day and when they are not eating, they are chewing, they are ruminating. In our homes, children are also eating all day. He sits down to watch TV and a plate of snacks will appear. He sits down to do homework, a plate of snacks will appear. Mother is constantly in the kitchen making snacks. She's like a snack ATM, always dispensing snacks. When they go out for even half an hour, she takes a bag of snacks. Hunger attack may happen. And if the child doesn't feel hungry, she still feeds ki banavi ne lavi chun to khavdai dun. So she is giving snacks all the time, and the child is never hungry. Because of that, meal times suffer. Meal times is when a normal healthy diet is served. Snacks are usually unhealthy. So meal hygiene is important. Children should come hungry to the table. They should have 3 meals a day. Younger children can have 1 or 2 snacks. Older children do well with only 3 meals a day. Don't let them have sweets and juice all day because these are empty calories. There are no nutrients, just carbohydrates. So restrict the snacks and juices. Very often there are big Tetra packs kept in the fridge of these juices and shakes, and they are mostly sugar. There is very little actual nutrition in them. Snacks may be invisible because some elders in the family are hiding them and giving them or taking them out or giving them money. If you give money to a child, it's almost certain he will go and eat something junk. Introducing food is easier before 18 months, and easy is relative. See, every child is different. Some children like to eat new foods, they are happy to try. Some children just won't eat them and things become very ugly in the home. But it's best to try in the early months. Always take a careful food history. Mothers do exaggerate, kuch khata nahi hai. But you always think, kuch khata nahi, to how is he alive? And how is he flourishing so much? His weight is, is at the 75th percentile. So take a careful food history. You may find that his calorie intake is normal, but he is taking a very imbalanced diet. High calorie, nutrient poor food are often preferred. Ask what is his favorite food? Potato chips. So you have to guide them to give a proper balanced diet so all the nutrients are represented. Involve the child in cooking, sometimes that works. Rewards and incentives, as I said, if you don't eat your vegetables, you won't get this sweet dish. Some outing or activity that he likes. Offer enough choices, and the mother should not be obsessed with badhu khavu joiye. A child is not a dustbin. You can't put everything into it. Some things he will like, some things he will not like, so don't be forceful. Don't make him eat everything that you like. Young children have food preferences. They won't like everything. And after 12 months, growth slows. So the appetite and food intake will also reduce. What he wanted, in the first year of life, he was always hungry. In the second year, he will not want to eat so much. So mother should not think that is abnormal. It's to be expected. Growth chart is not a report card. Mother should not feel that growth nathi, weight nathi vattu, so something is wrong with me, or mane koi thapko malse. She should not be worried about that. Thank you. Weight gain is not a performance state. If the child becomes fat, mother will not get a medal. That also she should know. Steady growth at the 25th percentile is quite normal. Every child doesn't have to be at the 100th or 75th percentile. As long as the growth is steady, even along the 25th percentile, it's quite normal. And appetite varies from day to day and meal to meal. So we should not take bad eating lightly, always. We always say that as he grows older, he will grow out of it, and it happens in 9 cases out of 10. But some children remain picky eaters to adulthood also. They never eat a proper well-nourishing diet, and they never eat a balanced diet. They are always having micronutrient deficiencies, anemias, vitamin deficiencies because of their imbalanced diet. So we should pay attention to it and guide parents how to convince them to eat a proper diet. Rewards and non-compliance costs are not bad strategies. See, mothers, even when you tell them to do it, they feel guilty about it. How can I punish my child? Or how can I punish my child every day? But that is, you have to convince them that this is good parenting. What you are doing today will benefit your child in the future. His life will be healthier and better. Correcting poor eating is a long-term project, and parents should be prepared and have our support in form of guidance. What to feed, how to feed, when to start, how to convince him to eat a healthy meal. Thank you very much for listening to me.
Thank you, Parang Bhai, for an interesting lecture, that also in the time frame. I would request you to visit our memento corner on the opposite side of the stage. I would request Dr. Chetan Bhai to present payment to Dr. Parang Bhai. So coming to the next lecture, again on a very common complaint, recurrent abdominal pain. And to deliver the talk, I invite Dr. Neelam Mohan. Dr. Neelam Mohan is a renowned pediatric gastroenterologist and hepatologist of the country. She is working at Medanta Medicity, Gurgaon. She is the recipient of the prestigious Dr. B.C. Roy Award. She is a popular faculty at various national and international conferences, popular at Surat as well. She has been the guest speaker in all the major events of Surat, all the state and national conference since last decade.
Good morning, everybody. It's been really a pleasure to be back in Gujarat after the real big COVID session, and I think what I enjoyed last evening was truly commendable because the unity that there was in that dance, I think, spoke a lot. A city which does not drink and yet dances so much. तो इसका मतलब बेचारा अमिताभ बच्चन सही बोला कि अगर क्या दारू में नशा होता तो नाचती बोतल तो बेचारे अल्कोहल को बदनाम मत करो ये तो लोग ही बदनाम है So with that I start and I'm happy to share that 2021 the distinguished National Board Examination Teachers Award was given to me and I'm humbled because teaching was always very close to me and I think it was really nice to get it from national boards for last so many years. And the Forbes magazine this time called me among the powerful women performers in India. So doctors ki jai ho. And I believe a lot in women empowerment. I believe each man and each woman should support other women. And that's the way to progress in India. Because for generations, women have not got the position. Even in a family, it's always the man who dominates, and it's time when we need to support them. So first of all, the topic that was given to me is recurrent abdominal pain, and I would like to start by saying the title is thrown into a dustbin now. We like to use the word chronic abdominal pain because that is a better definition that we've taken and we don't talk about RAP. So I was very happy. I did not tell the organizers to change the title because I wanted to take this as an opportunity to address this issue that we call it chronic abdominal pain, which is intermittent or constant, functional or organic, which is there for 1 or 2 months. And that's why we call it chronic and is seen in 2 to 3% of the condition. So that 3, what we used to talk is no more talked about. And what is functional? Functional is when I am not able to find any anatomic, biochemical, metabolic, inflammatory, immunological or neoplastic. I repeat, functional is when I do not find any anatomic, biochemical, metabolic, inflammatory, immunological or neoplastic. So that is when I call functional. And I remember giving this lecture in the first in Pedicon in Hyderabad. I don't know, it was more than 10, 15 years back when people were all over and sitting on the floors, etc. When I gave my first talk on that. And I believed at that time I said that I disagree that this is so much functional, 20, 30%. It is our ignorance. Because there is a cause for everything. Just because I don't know, I call it functional. Just because I don't know, I call it cryptogenic. So your cryptogenic may be 40%, mine may be 10% because maybe I do more genes. So that is what, first of all, get into this, that parent is right, child is right, even if it is psychosomatic. Isn't that important? That was a stressor or a psycho. So do not think that functional matlab kuch bhi nahi hai, chalta hai. So that impression I want you to get out of the mind. But having said that, since it is a small component, I will go ahead with the way the Rome criteria define it. And my first case I will talk like a typical Rome criteria gastroenterologist. But I believe that there is lack of understanding in us, and soon we will be, whether it is the gut microbiota, whether it is the nerves, whether it is that. When I was an MBBS student, I remember a patient telling me, मेरे सर पे गैस चढ़ जाती है, and I used to, in Telugu, I did it from Usmania Medical College, and I used to think, साला पागल हो गया, पीठ की गैस सर पे चढ़ती है, इसको तो psychologist के पास भेजो. Like a student, I used to think like that. But actually he was wrong, right, and we didn't know that the nerves are connecting, and he was saying sar pe gas chadti, and I was laughing. So that's what is ignorant. So let me see, be alert. Now a child who presents to you with whatever periumbilical pain, 7 months, so I am taking the whole history, type of the pain, where is the pain, how frequent, kitna frequent, kab hota hai, din mein hota hai, raat mein hota hai, kidhar radiate hota hai, कैसे आराम आता है, कैसे बढ़ता है, कुछ डायरिया है, कॉन्स्टिपेशन है, ब्लड है, फीवर है, वेट लॉस है, जॉन्डिस है, रैश है, क्या दवाई खाए, किससे आराम आया? Is that the history? Am I complete? Yes or no? That was a complete history? Yes, no, don't know. Please participate. No. Yes. No. Why no? What was wrong in that history? Okay, so you are nearly there. I did not take any personal history, any family history, any past history. So very important to take personal, family and past history, because that is going to help me. So that was the message. Whatever personal could be, family, घर में कौन है, क्या लड़ाई है, स्कूल में क्या, friends, all that is personal history. Sexual abuse, lifestyle, participation, extracurricular activities, what happens, stressors, teenager, parents IBD or parents IBS and functional. So this is very important. So does the site of pain tell me, is it organic or functional? Yes or no? Yes. Maybe. Because if this is the quarter, now these two I agree with you is more likely functional. But if it is in the right side, I think hepatobiliary, I think renal, I think appendicular or terminal ileum or colitis or typhlitis, maybe ovarian, so maybe pancreas. So maybe because these areas could be functional and in the center could be organic too. So yes, sometime it just tells me that it can't be organic, because when I have here or here, it can't be functional. It's more likely organic. So that is what it helps me with. So we took all this history and then we found out there were a lot of issues in the school, and parents were both working but nothing otherwise. They were good parents who were giving time, but sometimes you need to become friends at that age, and for whatever reasons, this was something which the child was upset with. And so this I examine. You have been taught, Gujarat Pedicon always keeps saying growth chart, weight, height, general examination, head to toe. Don't forget a parental examination and quick examination of all systems. Am I right or wrong? Yes. Somebody said what? नहीं करना, क्यों? Right. You're right. मतलब मुझे और आपको परेक्टल कर दे दर्द के लिए तो बुरा लगेगा यार. So मतलब मगर अगर दुश्मन का है तो बिल्कुल परेक्टम आजा कोलोन भी करती हूँ. So that is the way. Gone are the days when our teachers used to tell us complete examination includes a parental examination. So I want to tell you they were wrong. Do a perianal examination. Perianal examination is very important. Fissure देखो. I had a child, मैं कभी सोच भी नहीं सकती थी. He was from Haryana. Lower middle class जो भी आया था, and school से was in a hostel, and the entire anus was spatulous in a 9-10 years old boy. Couldn't have dreamt, but it was a sexual abuse. And I could just make out that the child is very quiet, but itna nahi samajh aa raha tha. So second sitting and all, I was just trying to understand and get. So we called the teacher because he was brought from. So it is very important to do a peri. I is very important. Per ke badle peri bana do. And yes, in the COVID era, parectal up or chale gaya. I'm being honest, we do more X-ray if you're thinking of a fecal loading dekhne ke liye, rather than getting to a parectal. So I've switched over to X-rays sometimes because I don't want to put a finger in COVID era. So that was also one message. Now, quickly I will rattle because you all know, kab aapko red flag hona chahiye? Involuntary weight loss, unexplained fever, GI bleed, अब ऊपर से bleed, नीचे से bleed, joint pain, skin rag, growth failure, delayed puberty, vomitings, bilious vomiting, significant vomiting, chronic diarrhea, genitourinary symptoms, palpable lump. So all this cannot be functional. It has to be organic. When you examine, sick looking, my child was quiet, the other one. This is sick looking child, pallor, edema, clubbing, poor growth. When I said poor growth, obviously you need to check the height of the parents. If you have small Guju parents, and then you can't expect Amitabh Bachchan out of them. So please take the height of the mother and the father. Very important to decide that. Then examination, entire thing, local, rebound, guarding, rigidity, doing, distension, ascites, palpation, perianal disease, anything which is abnormal cannot be functional. So basic test, yes, you can do hemogram, stool routine, urine routine, ultrasound. Now my next question to you is, this ultrasound showed 1.1 centimeter into 0.5 lymph nodes. What is the advantage of ultrasound? Would you like to do ultrasound in everybody? No, यहाँ तो पूरा गुजराती नो है. रेडियोलॉजिस्ट को लाओ भाई, बिल्कुल अच्छे दोस्त नहीं है, पूरे बेकार है, अल्ट्रा कुछ पता ही नहीं रहे. तो so I think the answer should be maybe, because there are times when you want to do, because it's a Plandora. I've just told you chronic abdominal pain 7 महीने से है. भगवान ना करे उसको कोई रसोली है, you think वो दिगंत को माफ करेगा? दूसरे को बोलेगा मैं 7 महीने से जा रहा था, एक अल्ट्रासाउंड भी नहीं किया अपनी बीवी के साथ ताकि मेरे को एक मालूम हो जाता. सो मेरे हिसाब से इन अ कंट्री लाइक इंडिया वेयर सिंपल है, नॉन इन्वेसिव है, पेनलेस है, रेडिएशन नहीं है, रेडियोलॉजिस्ट भरे हुए है, सस्ता है, कोई मेरे को यूके के जैसे अपॉइंटमेंट, यूएसए के जैसे अपॉइंटमेंट नहीं चाहिए, गली में या घर के अंदर भी कोई मिल जाती है तो मैं तो शायद करा ही लूँ. I believe in that. How much you पटाओ your ultrasonologist, rate 1500 लेगा तो मैं भी स्मार्ट हूँ. छोटा बच्चा है तो अपर एब्डोमेन लिखो, अपर में पूरा आधा रेट में पूरा देख लेगा. So that all you also examine and do it, because abdomen is sometimes full. So that strategies you can use with your radiologist. And then right upper abdomen वो बोल किडनी कैसी दिख रही थी. So then he is stuck. So disadvantage is ये जो मेरे को दिख गया, जो सब जने नहीं बोले, बिल्कुल सही बोले, डिसएडवांटेज. अब उसको 1 into 0.5 मिला, क्या करूं मैं? So that is the disadvantage sometimes you get. For that, what do you need? You need Neelam Mohan. थोड़ा सा एक रेफरल देखे कि पूछ ले कि कुछ है तो नहीं. So that sort of a thing. No red flag signs and atypical symptoms. But the answer is this, that actually करने पे कुछ red flag signs नहीं है, तो दिगंत साहब सही थे. 1% yield है. But if the thing is going long and there is concern, no harm depending on your setting that you want to do. Or any time when there is some atypical thoda bhi mil gaya, so the pickup rate is 10% from some study I quoted. So इस बच्चे में अब मैं सीटी करूं, एंडोस्कोपी करूं, दोनों करूं, कुछ नहीं करूं, चलो मान गए. सो एंडोस्कोपी कब करना? अब अगर उसको डिस्फेजिया थी या वॉमिटिंग थी या डायरिया था या ग्रोथ रिटार्डेशन थी या एपिगैस्ट्रिक पेन था, बट आपने थोड़ी देर पीपीआई दिया और रिस्पॉन्ड किया लेकिन फिर आ रहा, यू कांट कीप गिविंग पीपीआई ऑल द टाइम. The prescriptions what you all do is also not very right. Transient, yes, short term you give, fair enough. But if he comes back, then you, or celiac serology is positive, or कोई भी inflammatory markers, अक्कल blood आ गया, या CRP raised था, या inflammatory, something you find very interesting. As I speak to you, 3 years old boy was admitted 4 days back. He saw me once in OPD around 2 months back or 1.5 months back, and I remember writing him that we will do an ultrasound in this thing and X-ray kara tha constipation, and we may plan a endoscopy. But doctor shopping, he went to 3-4 and all that stuff, and was admitted 3 days back. And I did a Thursday ke din an endoscopy. I haven't seen such bad duodenal ulcers, 4 duodenal ulcers in duodenum ke D2 mein. So is duodenal ulcers in children common? No. 3 years old. What should I think? Clue, uska CRP was 220. I will do. तो कल करूंगी मैं inflammatory के लिए. I will do a colonoscopy and I will do a CT to look for that. But I did a fecal calprotectin and that report came last evening as positive. I was here जब वो report आया, and I said okay, prepare him for Monday. But I'm just saying, 3 years old boy. So I'm thinking Crohn's disease, but I will send a CMVB भेज दूंगी and immunity and all that stuff देख लूंगी anyway. And biopsies ले ली for that. TB in duodenum. It's the least site in the entire GI system. मतलब कि जब आता तो हम केस रिपोर्ट लिखते हैं, duodenal TB की केस रिपोर्ट लिखते हैं, wrote first in GRH a case report, एक बच्चा in last 30 years. You don't get duodenum में TB, you usually get Crohn's disease. So now अब ये आ जाता है, parents, मेरे को टेस्ट चाहिए, मेरे को टेस्ट नहीं चाहिए. She loves school and has many friends, maybe उसके दिमाग में कुछ problem है. I hope डॉक्टर के बारे में he or she finds something, hope he or she doesn't find. So there is a total, parents total confused है और doctors भी equally confused है. Functional है कि organic है कि ये Rome criteria क्या था, वो Rome criteria को पढ़ो, इतना Rome criteria कुछ भी नहीं है, I'll just talk about it. So model time wasting, मैं तो psychologist नहीं हूँ, कुछ opinion ले लियो. Because we don't have time, sometimes we send to a trained psychologist. Not that we don't understand, but in our busy practice we cannot. So in our case, I agree, none of the above was there. We talked to the patient and the patient got okay. So now I will talk a Rome criteria जो बोली. What is this Rome criteria? थोड़े से changes आ गए children में, but it is too theoretical. Just understand the basic and I just put one slide. अगर आपको dyspeptic symptom है, डेकार, वो dyspeptic दर्द, gas, that's called dyspepsia. Migraine is, I'll take one slide. IBS is constipation, diarrhea, mixed or unclassified. And dyspepsia could be खाने के बाद postprandial or epigastric. इसमें food map diet. Functional abdominal pain not otherwise specified. इसको बोलते हैं हम pain के साथ कुछ भी नहीं. No dyspepsia, no migraine, no vomiting, no IBS, no diarrhea, no constipation. So this is what you are thinking this child. Functional abdominal pain not otherwise specified. But इसके लिए you can make a positive diagnosis, not a diagnosis, good history, physical examination, complete. और ये बोलना भूल जाओ कि that it is malingering this or बहुत सारे testing and then, but important, identify stressors, address them, set realistic goal, involve psychologist in difficult cases. Because जैसे मैंने बोला, वो जो मेरे को MBBS में सिखाया था वो गलत नहीं था, मैं गलत थी, उसकी nerve system मैं समझ नहीं पाई थी. Remember before an exam, always I used to get, just before entering the exam I would want to go to the loo. What was that? Definitely a stress, and I used to start hiccups because मेरे को ये था कि I should top in the class, I should top in. So there was so much of stress कि that 2 marks भी मेरे नहीं जाना, I should be the, so that stress was too much and I would have hiccups, I would have diarrhea. So it was definitely, it does matter. So all this you do and do. क्यों होता है? This is the way. आपकी gut motility की कोई issue हो सकती है जिससे बच्चे को दर्द हुआ, और ये हम अब functional बोल रहे हैं. हो सकता है कि I'm speaking now more than a decade back. भगवान करे अगर मैं 70s तक जाऊं, अभी तो मैं 32 हूं, तो and my son is just 29. तो then I will talk about gut motility. There is so much of that which needs to be done. So sometimes these children come to you with a complete test, but all that was needed was a good history. This was an episodic with history of migraine in the mother. And so this fits into an abdominal migraine. You should find the trigger factors and food map, Google it, ye diet de dena, and you give brufen or triptans and treat, and 30% will go on as adults with headaches. Avoid CC, chocolate chicks, citrus, Chinese, and all that stuff, stress, constipation. But having said that, beyond my scope to talk about organic, everything that you can think about, चाहे वो hematologist हो, चाहे वो rheumatologist हो, चाहे वो metabolic हो, चाहे वो, they need me because everything is in the abdomen. But we have facilities to do manometry, which I'm telling is motility or pH metry and all that. Sometimes you find this red flag signs and then I just want to give you do an endoscopy, you find scalloping. You know biopsy will reveal you celiac disease. You find perianal examination, something tag. So you do a colon, that's Crohn's disease. Just a tag, nothing else. Based on the tag, you should be smart that yes, this could be Crohn's disease. Lymph node, do an EUS, give a biopsy. Don't empirically start ATT if you can know what it is, because you will know what is gene expert and rifampicin resistance, so you can do that. This child pain, what is this diagnosis? Anybody? ग्रैनुलोमा तो पैथोलॉजिस्ट के साथ है, बहुत दोस्त है पैथोलॉजिस्ट. ये क्या दिख रहा है? क्या पूरे नोड्यूल से मेरे लाइफ का भी 4-5 केसेस है. फेमिलियल एडिनोपैथिस पॉलिपोसिस जो आप पढ़ते, मैंने पर्स जिगर का आपको फोटो नहीं दिखाया, लिप्स का. लिप दिखाती तो आप पहचान लेते, मैंने वो दिखा. So that is how I'll end up by saying chronic abdominal pain. So what I wanted to say is it does help you to have a complete. It is a long, defined as intermittent or constant, lasting 1 to 2 months, maybe functional or organic. Functional is in the absence of anatomic, biochemical, metabolic, inflammatory, immunologic, or neoplastic. It's a positive diagnosis also, but a good history examination. Basic tests, CBC, SR, urine routine, plus minus ultrasound, because that's what I think, plus minus, you decide how duration is going. Red flag symptoms and signs must be looked for each patient in CAP. And as I mentioned, perianal examination is a must to pick up things. In presence of red flag symptom, investigate accordingly, and referring for a second opinion may be rewarding and appreciated. Thank you for inviting me over.
Thank you, madam, for the lucid presentation. I would request Dr. Rakesh Desai to present memento to Dr. Neelam Mohan, ma'am. Madam, on that side. So friends, now we can have questions for the past 4 lectures. Dr. Digant Sastry, Dr. Jalak Upadhyay, Dr. Parang Mehta, and Dr. Neelam Mohan, ma'am. The house is open for questions.
So I have 2 questions. First question for Dr. Parang, sir. Sir, as we have talked about eating habits and how to raise a child with proper behavior and food habits. So still the Gujarat being a first in anemia, how can we rectify that thing in routine day practice, or how we advise our patients that we should not have a first rank in anemia as far as the Gujarat is concerned?
Anemia is easy to avoid if they are eating a full 6-group diet. But as you know, a lot of our population is vegetarian, which vegetarian diet as such is deficient in iron. And even though people who describe themselves as non-vegetarian eat non-vegetarian food only once or twice a week. So most of our diet is vegetarian and we have very little iron in our diet. Now it's very difficult to get children to eat iron. The iron-containing foods like spinach and chandalia and bathua, they are very, very unpopular vegetables. So for children, you actually need to give supplements to prevent anemia. Indian government has tried all kinds of things. Once upon a time, they came up with a product called ferro salt. This was 20 years ago. They tried to put iron into salt. But you know, already iodine in salt had become so unpopular, people were fighting against it, then they did not do it. But mothers were being given iron-containing pills, regular supplements. Women were being advised to take, especially in the reproductive age group. So without supplements, it's difficult to prevent iron deficiency anemia.
Sir, one comment regarding iron. Even in the veg, even in those who are eating veg, many of my patients' parents, they do prefer to give egg. The only reason is the egg contains a good amount of iron, boiled egg. So that is a good rich in iron. I'm just telling because they have been giving egg just for the sake of the improvement in the iron content in the food.
All right.
And
That's nice to know.
second thing, other important thing, even some of the these dry fruits like dates, anjeer, these are very good source of iron. These are very good source of iron. So I usually ask them to give 3 or 4 food items: egg, khajur, anjeer, and gourd. That is jaggery.
Yeah.
So there are 4 items which are very good source of iron.
Gourd is really good for iron. Yes. But of course, the population that can afford anjeer and dates are not usually iron deficient.
Thank you, sir.
See, at the same time, I think I have a comment in relation to what you said. Apart from the vegetarian food content, the food preparation style, again, that itself is also affecting the content of the, whatever content is there in the food, the frying and all these things also going to affect. So basically, not just the food items which are less in the iron content, but your method of preparation also is going to affect the iron supplement, means iron source from the food item which child consumes.
So the take-home message is ghee gourd roti always rocks. Always tell your parents कि भाई घी गोड़ वाली रोटली तो खावी ज पड़े, and if they have options of giving egg, then the egg is one of a better option. So, question or your comment?
Please take more questions. No comments, please. Only questions.
One more question to actually Dr. Neelam ma'am. Ma'am, what is this care about this ranitidine? Because we are using ranitidine upfront, and this NDMA content is oncogenic content. And being oncologists, we don't prefer giving this pantoprazole or our proton pump inhibitor because they interact a lot with all these chemotherapy drugs.
Right. So let me say, it's a very good question. Thank you for asking. I mean, if you wouldn't have asked, we wouldn't have covered that part. That the paper who had talked about, sir, I want to address you eye-to-eye contact, please. So the paper who had actually talked about this, they withdrew it because the amount of dose that you think will be needed is beyond your imagination and my imagination. So that paper was withdrawn, and it is no more, I mean, the FDA has sort of cleared it that it is not related. So that's how ranitidine is now back even in Indian market. In between it had gone. So that is good news that, but yes, it was useful for us all to get alert. There are advantages and disadvantages of ranitidine. Ranitidine is good for short term. जैसे आप कभी एंटीबायोटिक के साथ कुछ दे देते हो तो शॉर्ट टर्म के लिए ठीक है, या आप कभी सडनली रात में मैंने कुछ हैवी खा लिया and I'm getting dyspepsia. So once in a while you want to take even with or without food, that way also there. And but allergic component kuch hai, so because it's an H2 receptor, it's good. But the disadvantage is if you are a known reflux patient and you need it long term, then it gives rise to tachyphylaxis. Tachyphylaxis we all know. So beyond 3-4 weeks, 6 weeks, it may not be so effective. So that's with the ranitidine. Thank you for that.
One, Vishal, please.
We'll take at the end of the session.
Absolute. I wrote ऊपर मेरे को time नहीं दिए लोग घंटी 18 मिनट में बजाए.
Only 1 minute.
Right. So basically, yes, when we talk about, I didn't even put the slide, thank you के बाद रखी थी foot map slide because it's very difficult to rattle the entire FOD map slide. But it tells you, for example, in fruits, there are some fruits which give rise to more gas as compared to other fruits. So orange, kiwi, grapes, banana are allowed. Apple, pear, watermelon are not allowed. So that's called a food map diet. So ginger is allowed, garlic, onions not allowed. So this food map diet, if you put it, you will get it. So you have to see, and in that lactose is avoided. So you can take lactose free and you cannot take lactose free. So the stressors when I talked about migraine, तो उसमें मैंने C बोला. So C was cheese, and I also had Coke to tell the parents. Cheese हो गया, Coke हो गया. So Chinese में basically that salt, Ajinomoto or that MSG salt. These are stressors which give rise to chocolates, coffees. They trigger more migraine-like. So basically, migraine is in the head, and for gastroenterologists, it's an abdominal migraine. So it's an abdominal migraine. So just like headaches can be precipitated by dhoop, so fasting. So like that, I get headache and then I realized, oops, khaya nahi. So you realize that you've not eaten when God gives you an alert or whatever. So a lot of people get headaches, they can't fast and all. So similarly with children, and I was just telling ma'am, yahi baat kar rahi thi, ki that to treat it, it's like a lifestyle change. Lifestyle change means, sahi time khao, sahi time so, ye nahi. So that's how. Dawai mein kitna time do? You'll have to address the lifestyle basically. Medicine is to tide over. Suppose there's constipation. So you were right, you treated constipation. Then he comes to Neelam, I make migraine. So I will tell the patient, wo sahi tha. Constipation was a precipitating or a stress factor. So that's what it is.
Yeah, I have one question for Dr. Jalak. Madam, you talked about a child with a hypocalcemia who was diagnosed with severe vitamin D deficiency. Now we usually give vitamin D supplement. Is there any role of active form of vitamin D like rocalcitrol initially to be given followed by this? And second thing, how much time it takes for that vitamin D level to go upwards to mitigate that effect of vitamin D deficiency?
Okay, so rocalcitrol, which is the active form of vitamin D, or alpha calcitrol or rocalcitrol, what we say. So that is, we only give to buy time. So if I want to shift the child from IV calcium to oral, and as I said, we give bolus first and then the infusion. And then when I want to shift it to oral as soon as possible, I give treatment doses of calcium and vitamin D deficiency. So I give vitamin D if newborn 2000 units per day and active form only for 3 days. Because I know this is vitamin D deficiency, I give it for 3 days in OD or BD doses depending how severe is the hypocalcemia. But after 3 days I have to stop. Because when I give rocalcitrol, it will immediately increase the calcium levels. But vitamin D, it takes time. So that is why the therapy is, it's like weekly therapy, or if you're giving 2000 units, it is for 3 months. So what I am doing is I am only giving rocalcitrol to increase calcium, whereas vitamin D will take time to get normalized. So otherwise rocalcitrol should be given in children with hypoparathyroidism. That is must. But if vitamin D deficiency, there is no role of rocalcitrol. It's only in the acute stage where I give for 2 to 3 days just to buy time. Thank you.
Thank you all the speakers. So now we move on to the next session. You can please, we are short of time. You can take the questions in the lunch time. Thank you.
We quickly move to the next session. We welcome Dr. Bakul Parekh sir from Mumbai. He will be delivering a lecture on identifying the sick child and management of septic shock. Dr. Bakul Parekh was a national past president IAP 2020, and we, at the comfort of our home, we enjoy so many DIAP online activities. The credit goes to Dr. Bakul sir. Over to you, sir.
So thank you very much. First of all, I'll thank the organizers and SPEC to give me this opportunity to discuss on pediatric septic shock, a condition which we face quite often in our practice, but sometimes we miss the bus. As to how to diagnose a sick child or who needs treatment, I'd like to give one example. A child has come in the evening to your OPD, seen by your RMO, for an abscess on the leg, 2-year-old child. He was crying excessively, was having very high fever, and there was an abscess. So he gives an antibiotic. He feels that crying and irritability is because of pain. So he gives some analgesic and antipyretic. Along with antibiotic, he sends the child home and told him, okay, you come tomorrow or day after tomorrow if he doesn't improve. And next day morning, child comes, he's dead. When asked, he said, no, child was quite okay, but I don't know why he died. So he probably missed something. That was a case of maybe a severe sepsis where you get few hours and then he went into an compensated shock at home, but child was brought in the morning thinking that, okay, the treatment is going on, and that bus was missed. And that's how we missed that child who otherwise would have survived if you had intervened in time. So you get few hours when there is sepsis, you get few minutes if there is compensated shock, and you hardly get some time when there is uncompensated shock. So you have to be vigilant and record your vitals and pulse oximetry and maybe your pulse pressure to take you and diagnose the shock in time. So my talk today will be based on the recommendations given by SCCM as surviving sepsis guidelines in 2020. And there, let me tell you that they are not trying to give you standard treatment guidelines or algorithms, but they are the best practices which you should follow in your practice. And that will help you in tackling the case of septic shock very easily. So why pediatric shock is an urgency? Because presentation can be subtle. There can be tachycardia, tachypnea. It may be easily misinterpreted in neonates and children. An opportunity for rapid intervention correction may be lost if you miss the tachycardia and tachypnea in an ill-appearing child, which can be otherwise have many differential diagnoses, and so can exist without hypotension. So this point should be kept in mind. So if you look at this compensated, decompensated, and irreversible, so if you have missed the severe sepsis, you will go into compensation. If compensated shock is missed, then it will lead to cellular hypoxia, decrease in your systemic vascular resistance and myocardial contractility, and that will lead to decrease in cardiac output, and which will lead to irreversible tissue and organ damage and ultimately death. So definitely is defined as severe infection leading to cardiovascular dysfunction. Any shock, they have similar presentation, but when there is septic shock, you will have either cardiovascular dysfunction, where you might have required treatment to treat hypotension, or maybe you might have given vasoactive medication or imperfusion, and then it is septic shock. So what will make you suspect septic shock? Let's look at this child. 3-year-old female arrives at triage with heart rate of 180, respiratory rate of 35, and looks tired. Has had URTI symptoms for past couple of days. In ICU, we are called in emergency department to reassess. And the first assessment says heart rate was 180, he was quite tired, open eyes, moderate respiratory distress, capillary fill time 4 seconds. So what do you do? So let's look at the clinical measures which fits in. Child has fever, child has increased heart rate, child has increased respiratory rate, and there is definitely altered mental state. And there was definitely increase or decrease in capillary fill time. So this tells you that child is in shock. Now we have to differentiate between cold and warm shock to manage your therapy. And why you are worried? Because this pediatric shock, there is very common, 5 to 30% of pediatric patients with sepsis will develop this shock. And mortality rate is about 20 to 30%, and in some countries maybe 50% if you are not managing well. So the guideline says that you systematic screening for timely recognition, bundle treatment, and protocol or guideline-based management makes you improve your therapy, your speed, and your reliability of cure. So you should always have a bundle treatment. And lactate. Lactates do not be used to classify severe shock as mild shock or compensated or uncompensated shock, but it should be used to manage your shock. So lactate level more than 2 to 4 millimoles will definitely make you more perfect in assessing your clinical status and perfusion. And what is the difference between cold shock and warm shock? If you look at warm shock, there is tachycardia, warm. But if you look at the common things, more mental status is altered and urine is having decreased urine output. But all other things like blushing, flush, bounding pulse, warm may not lead you to suspect shock. So we have to be very careful about looking at pulse pressure, wide or narrow pulse pressure, and that will help you in identifying cold shock or warm shock. So how will you manage this child? Early recognition is always important in any condition. Early and appropriate antimicrobials. Like in a child with septic shock, you have to give antibiotics within 1 hour, which is uncompensated. But if it is severe sepsis, you have a time of 3 hours. So that bundle treatment depends upon the condition of the child. If he is in shock, you have to start antibiotics within 1 hour for better results. And then early and aggressive therapy to restore balance between oxygen delivery and oxygen demand by doing fluid therapy. So early and goal-directed therapy is very important. And what you should be doing, use IV fluids, vasoactive infusions, oxygen to restore balance between oxygen delivery and demand. And your goal should be to bring down the capillary time to less than 2 seconds, urine output more than 1 milliliter per kilogram per hour in a younger child, normal pulses, improved mental status, decreased lactate and base deficit, and perfusion pressures appropriate for age. And if you are in an ICU and you have got better facilities, you will also look at resolving the lactic acidemia, SVO2 of more than 70, and reduce the base balance. So at 0 minutes, you recognize the status, diagnose that suspect the shock. 5 minutes, you will give fluids in 20 ml per kg of isotonic or colloid, depending upon what you are dealing with, and antimicrobials correcting hypoglycemia and hypocalcemia. And at 15 minutes, if you decide whether it is fluid responsive shock or fluid refractory shock, and you will observe in PICU. Now, this is algorithm. Now, let's dissect. Now, what the guideline says, use trends in blood lactate levels in addition to clinical assessment to guide your resuscitation. Need to use interosseous line if you don't get IV lines after 2 attempts. Don't waste your time. And you may need 2 lines because if one line fails, your second line will be helpful. And obtain blood cultures before initiating antimicrobial therapy that we know. And with septic shock, start antimicrobial therapy within 1 hour. But without shock, you can have time up to 3 hours before you start antibiotic. And you should decelerate if your antibiotic sensitivity is available. And if there is no pathogen, you should be brave enough to narrow down your antibiotics depending on the clinical need, or you may stop the antibiotics. And without immunocompromised condition, you should not use multiple empiric broad spectrum antibiotics. You can use one antibiotic which has broad spectrum, but don't use multiple for synergistic action if there is no immunocompromise. But if there is an immunocompromised child or nosocomial infection, you may be allowed to use multiple empiric antibiotic therapies in septic shock. Then, of course, you should remove the intravascular access devices. You know that your sepsis in ICUs will be either ascending because of urinary catheterization or central lines. So you should be able to remove those sources and replace after you get the vascular access beforehand. And in intensive care, if the child is in intensive care with shock, you are allowed to give 40 to 60 ml per kg in bolus in first 1 hour and discontinue if there is an overload. But in our hospital, where there is no intensive care facility, you may be on the lower side. That is a 40 ml per kg bolus fluid in terms of 10 to 20 ml per kg for the initial fluids, or 1 hour along with titration and looking at overload. So ICU, you may go a little bit overboard, but in your own clinic, you should be more careful. Don't give more, 10 to 20, so roughly 40 ml in 1 hour rather than 60 ml in 1 hour. And what fluid you should use? Balanced buffered crystalloids. Till now we used to say 0.9% normal saline or ringer lactate, but now the new guideline says ringer lactate. Buffered or balanced crystalloids are always better to avoid hyperchloremia, because that is again causing damage. And you should be having targeting of mid-anterior pressure between 50th and 50th percentile. There are formulas which you keep in your ICU or as a chart and for the RMOs to see. And no starches and gelatin to be used. If you want to use colloid, no starches, no gelatin, because it causes hemoglobin coagulopathies. Use albumin if required. And use advanced hemodynamic variables when available, in addition to bedside clinical variables to guide your resuscitation perfectly. Though in our clinics, we may not be looking at SVO2 or other things, in invasive blood pressure, but if possible, you should do it. At 15 minutes now, let's see if there is fluid refractory shock. What we advise, establish central venous line, because you have to titrate your adrenaline from 0.1 microgram to 3 microgram per kilo per hour. So that per minute, sorry. So that requires your central line, but of course peripheral access is possible till that level. And you will look at cold or warm shock and try to look at mean arterial pressure and your SVC. And if they don't respond, we label it as catecholaminergic resistant. Now what the guideline says, use epinephrine and norepinephrine rather than dopamine. Maybe you can use in diluted form through peripheral lines. You can add about 250 milligram in 200 ml fluid and then give slowly in peripheral line, you are allowed. And if they don't respond, you may add vasopressin if there is a warm shock. And if there is a cold shock, you may add milrinone, that is inodilators, if there is still hypoperfusion. Intubation is indicated in children with fluid refractory catecholamine resistant septic shock without respiratory failure. Mind you, usually in septic shock or any shock, We avoid giving mechanical ventilation, but it increases the abdominal pressure and your input, cardiac input, and thereby they decrease the cardiac output. But in this situation, when there is catecholamine resistant shock, you are allowed to do ventilation, but there you will prefer your NIV more than anything else. So let's look at what are the guidelines they're telling. And here, of course, you will give hydrocodone if there are suggestions of adrenal insufficiency in terms of fulminant infection and your adrenal insufficiency criteria. But if there is no risk, don't give hydrocodone. But again, it worsens the condition at times. So in normal blood pressure, cold shock, SVC more, less than 70, then the other situation can be low blood pressure and cold shock with SVC less than 70, and there can be low blood pressure with warm shock. So here, your vasodilator will come in picture when there is catecholamine resistance, and otherwise your low blood pressure with cold shock you will give adrenaline, and with warm shock you will give noradrenaline, or at times vasopressin, and later on of course ECMO. So what our guideline says, trial of non-invasive mechanical ventilation in children with ARDS is useful. Use high PEEP and prone positioning, that is very useful. No routine use of nitrous oxide, and use nitrous oxide as a rescue therapy for all other oxygen strategies fail, and no preference for high frequency ventilation even with severe PARDS or refractory hypoxia. There is no need to you to have high frequency ventilation. Use neuromuscular blockade in severe ARDS and insulin therapy. You till now we used to say you maintain a sugar level below 140, but now they say below 180 is okay. And target normal calcium if there is hypocalcemia, especially your ionic calcium, along with your vasoactive infusion support. And what about hydrocodone? If child is at risk of adrenal insufficiency and remains in shock with purpura fulminans or congenital adrenal hypoplasia or recent steroid exposure or hypothalamic pituitary abnormality, you are supposed to give hydrocodone. But in ICU, when in doubt, of course, we always give hydrocodone when you are stuck to the wall. And a preference to commence early enteral nutrition, gastric, not the pyloric, but gastric in nutrition with a stepwise person increasing your nutrition goals as required. And there is no need to supplement with lipid emulsions specialized in with septic shock, and no routine measurement of gastric acid volumes are required. And there is no routine use of prokinetic agents like H2 blockers, and no RBC transfusions if your hemoglobin is 7 and child is stable. But if child is unstable, you can go up to 10 grams of hemoglobin by giving PCV, but don't give it as a routine. No plasma exchange without thrombocytopenia is associated multi-organ failure. So no need to give plasma exchange very regularly. And no prophylactic platelets in a non-bleeding child, just because child is bleeding, having thrombocytopenia. No bleeding, no thrombocytes. No prophylactic plasma in a non-bleeding child with coagulation abnormal. So these are a few points which you should keep in mind because they are bound to add to fuel to the fire. Yes, for renal therapy, replacement therapy, when there is fluid overload and your diuretics have failed, and if they are unresponsive to your fluid restriction, you are supposed to give renal replacement therapy in terms of peritoneal dialysis. Venovenous ECMO in ARDS with refractory hypoxemia, and your veno-arterial ECMO if refractory to all other treatments. So usually it is venovenous and not veno-arterial. And no routine use of IV gamma globulins in a case of septic, and no routine use of stress ulcer prophylaxis except for in those who are with high risk. And no routine deep vein prophylaxis. So all these have been suggested in Surviving Sepsis Guidelines 2020. And activated protein, initially it was very popular, but there is risk of serious hemorrhage. So again, use is not very much in program. So look at a case study. A 16-year-old patient admitted today with query appendicitis, collapses in the room, and you are called to evaluate him in the pediatric ward. Now there is tachycardia, there is tachypnea, temperature is 101, blood pressure is 70/20, and SpO2 is 96 on a non-rebreather face mask. He is barely responsive to your verbal commands, skins are flushed and distal pulses are bounding, lungs are clear without retractions, unremarkable precordium and abdomen, no urine output for 8 hours in the ward. So you know that you are dealing with a case of warm shock. So we know the diagnosis, and what should be your usual treatment plan? Very typical presence of septic shock, may progress to a moribund state if you are late within hours. So prompt fluid resistance should precede your other attempts of airway control. And of course, this without wasting time. So it's basically a teamwork. So one side you are giving fluid, the other side you are maintaining the airway. So, but fluid should be given preference. Dopamine is the usually first vasoactive infusion ordered in our clinic, but nowadays we say that it should be adrenaline. And because child is hypotensive and having low diastolic pressures, norepinephrine may be a good choice in this case because it's a case of warm shock. If it was cold shock, then of course epinephrine and later on milrinone. So at 0 hours, oxygen was started by face mask, 6 liters per minute. 2 large bore peripheral kidneys were inserted in this patient, and VBG, blood culture, CBC, and glucose were obtained, and 2 boluses of normal saline. Though nowadays they say is ringer lactate, 20 ml per kg fast because in ICU, and there is no change in hemodynamic status after all this treatment. So what next? Should I give one more fluid bolus? These are the questions in our mind. Or should we give colloid or crystalloid? We have already given 2 boluses. Then should I start dopamine or dopamine because dopamine has failed? Can I give dopamine via peripheral line or should I put central line now? Or what site for central line is preferred in this scenario? And can we use norepinephrine as an initial agent because it's a warm shock? So yes, one more fluid bolus crystalloid, 20 ml per kg was given because crystalloids are very easily available and cheap. Colloid will increase the oncotic pressure retained in the intravascular compartment. There is an advantage, but then it's very costly and not very easily available, especially albumin will be very costly. Because if you use others, gelatin or starch, you can end up with coagulopathy, reactions and so on. So use of crystalloid is probably more reasonable in pediatric septic shock. So, and child was started on dopamine, the dose was increased to 10 microgram per kilogram per minute and given through peripheral lines till now because it was diluted by 250 milligram adding in 200 ml. And epinephrine was thought of by giving 0.1 to 0.2 milligram per kg per minute. And if we had to titrate to say 3, then of course central line was a must. And here, because it was warm shock, norepinephrine was prepared, though dopamine was the initial agent. So patient was connected to multi-channel monitor. His general condition deteriorated. GCS scale went to 8, and he was sick, looking pale, though febrile. Heart rate was 148 per minute regular. Capillary fill time was still 2 seconds. And respiratory 28 per minute, mild intercostal retractions were present, and NIBP was showing 60-30-40 in right upper limb, and saturation 98% after those 2 boluses. Rectal temperature was 38, and peripheral was 35, so difference of 3 degrees centigrade. ECG saw sinus tachycardia, and per abdomen there was tenderness in right iliac fossa, so probably the diagnosis suggests appendicitis, maybe with decompensated warm septic shock. So next section, patient was intubated in view of deteriorating GCS. We know that if it is 8 and below, we have to intubate. A bolus of 10 ml per kg was again given. Antibiotic was started with relevant investigations. And right, you should put your central line comfortably in child in an internal jugular vein or right radial artery. Other subclavian artery is very difficult to intubate at times. So should I increase now dopamine to 20 microgram because they are not responded, or should I add norepinephrine because it is warm shock? Here we added norepinephrine 0.1 microgram per kg per minute through peripheral lines again. And after 20 minutes to 1 hour, now because there is a line inside, so 90-30, 34/50 was IBP, and ABG came to 7.34 with PCO2 of 30.53. And oxygen was very good, and bicarbonate was 18.7 with base excess of 8.2, saturation 99.4, and lactate 4.8 millimoles. So now what is the plan? Norepinephrine was I2 0.3 because now we have central line. And at the end of 1 hour, feeble pulses, cold extremities, prolonged CFT, temperature difference of 7 degrees now. And blood pressure is also falling down. Urine output is less than 0.5. SCCO2 55, though we want more than 70. Lactate was 4, which is again high. CVP was 12, and no pulmonary care. So there is no overload at present. Possibility of cardiac dysfunction or cold septic shock. Now it was considered. So what can help us to know whether it is cardiac dysfunction or cold shock? So chest X-ray, echo, your end diastolic left ventricular and IVC distance between superior venica collapse. So now distensibility index of IVC or collapsibility index is very important. Your collapsibility will be in your non-ventilated and distensibility in your ventilated child. So if it is more than 50%, then you know that child can still respond to fluids. But if it is less than 50%, you have to take further steps. So no pulse pressure variation was there, no positive response to a PLR, and X-ray was inconclusive, echo was delayed. So what drug to start and what other intervention would like to do? So 2D echo, left ventricular ejection was 35% with global left ventricular hypokinesia, and epinephrine was now started, 0.1 microgram per kilogram per minute. Other alternatives which were considered was dobutamine, but now the guidelines says epinephrine, and we checked the hemoglobin which was less than 7. So blood was transfused. Now what is the role of hydrocodone at this stage? Yes, we can give because you don't know what you are dealing with and what dose you will give. 2 milligram per kilogram is a loading dose followed by 50 milligram per square meter every 6 hourly. Sometimes people take cortisol samples, but it is not a must and give a continuous infusion. Now at 4 hours, heart rate was 148 per minute, periphery, core temperature was 36.8, skin temperature 33. And so there is still a difference of 3. And your 150, 58, 60, so blood pressure with capillary time of 3 seconds is from 4. And urinary output is 2.5 ml per kg per hour, so it has improved. ABG again has shown improvement, but lactate is 4.5 and SVO2 is still low, that is 61%. So how we achieve the targets and what should be our next plan? Maybe partially responded, bedside USG may help because USG is becoming a now almost state of routine practice in our ICUs to know the distensibility as well as look at the lung USG to know whether there are A lines or B lines. If there are B lines, you know that there is overload. If A lines, that is a dry lung and you can still give further fluids. And urgent pediatric surgery or consultation was taken because we are worried about appendicitis, and then investigations were advised. So here hemoglobin was 7.8. Prothrombin time, INR was 2.05, APTT was 64, and your BUN creatine again were on rise, your calcium was 6.8, and total protein albumin was on the lower side. So blood transfusion and calcium were given. Again, heart rate improved, regular, all peripheral pulses were palpable, core temperature was good. Then CFT was less than 3 seconds, CVP was 8. So now USG guided abdominal drain was inserted, sample sent for analysis, drain was the focus. And at 24 hours now everything is settling down. And now we have to plan the tapering. So epinephrine should be the one which should be tapered first. So whatever you have added last should taper first, like any other condition. Then ventilation was weaned off after 72 hours. Dopamine was continued in view of myocardial dysfunction, tapered on next 5 days, and steroids were tapered, and repeat 2D echoes or improved contractility. So this is how we manage septic shock in hospital if you take steps at the right time. And supportive therapy is very important in terms of hydrocortisone, early antibiotics, blood culture to find out the source, and you should control the source by removing those catheters if required. Glycemic control below 180. Nutrition, mainly the gastric nutrition, and in a stepwise increase to reach the nutritional criteria and guidelines, and reassessment at every stage and change the therapy accordingly. So assess, reassess, very important. So it's like driving a car with manual gears rather than your automatic gears, and then if you are present and monitoring very cleanly, you will be able to get the results. So key points here will be rapid recognition of shock is essential. Hypotension is a late finding, regardless of type of shock. Initial management of ABCs with particular attention, rapid fluid resuscitation, early antibiotics, more conservative fluids in cardiogenic shocks, and monitor electrolytes and glucose levels closely and intervene when necessary. So most important point in new guidelines is your mechanical ventilation should be avoided. Give more preference to high PEEP and proning. In fluids, you will use ringer lactate over normal saline 0.9. Steroids should be used sparingly, hydrocortisone, and your sugar level should be maintained below 180 rather than below 140. And try to use more of adrenaline and epinephrine depending on your warm shock or cold shock. And then your electrolytes and other management will help you. Thank you very much.
Thank you so much for your marathon and crisp presentation. Now I request you to proceed to the memento corner on the left side of the desk. I request Dr. Ketan Shah sir to present a memento to Dr. Bakul sir.
So we move on to the next lecture. The topic is pertaining to pediatric dermatology, itches and scratches. And to deliver the talk, I invite Dr. M.S. Kumar. Dr. M.S. Kumar is a senior consultant and head of the department at Apollo Hospital, Kochi. He has been the Honorary Secretary General in 2018-19, and he is the President-elect 2021.
Respected seniors, academicians, teachers, and beloved friends. A great Sunday morning here after the dazzling show, the dazzling cultural night we had yesterday, and my heart goes out for the great Spactians and the IAPNs of Gujarat, who made it a great evening. And I must echo Dr. Neelam's sentiments here, because some tonic was, without a tonic, how can it happen? And I believe the camaraderie and you enjoy, that's a great tonic which gets such evenings wonderful. Well, friends, I'll be taking you through a show where it's a itchy and scratchy show. This is actually a term which is a fictional animated television series from the Simpsons series in the United States, which was running and which has taken the US children by storm in the 2 decades back, where the blue mouse is there, the itchy one that frequently and violently maims the black cat. So itch and scratch, they go together, and that somehow we try to maim each other, but still it keeps on going. So it's a persistent fight between the itch and scratch. So this one of the atopic dermatitis is one of the most common relapsing skin diseases seen in infancy and childhood. It's the most common and relapsing. So in age-wise, as you all know, it's mostly 60% fall in the first year of life. It's the infants who are the most vulnerable group, but still maybe 85 to 90% for 5 years, and another 10% continues into the adulthood. And you see, if you see the pathogenesis, there is the acid mantle of the skin. It's a healthy skin barrier. The filaggrin is a component which maintains the cell integrity and the barrier function. So the barrier is basically formed by something called as acid mantle. The term itself denotes that the pH of the skin is something in the acid range, the 5.5. So there is a delicate matrix system formed by the lipids from the oil glands in the skin. Skin has got oil glands and the lipids emanating from the set glands with the amino acids from the set, and they form, along with the microbiome on the skin surface, they form a delicate matrix. And this matrix is what is called as an acid mantle, and this acid mantle protects the skin from use the barrier function. So expression of filaggrin and ceramide that decreases in skin in children with atopic dermatitis, and that leads on to what is called as a barrier dysfunction. So this barrier dysfunction opens up the pathogenesis of atopic dermatitis. And you can see the defective skin barrier, the itching, scratching happens, then it goes down to the sensory nerve endings are stimulated, the itching happens, and then itching again goes on to scratching. So this is a vicious cycle, and it keeps on happening. And then there's a polarized adaptive responses keep on happening. The TH2 responses will be there, the IgE will be there, staph colonization will happen again, dry skin will be there. So this is something like this is how this condition becomes a chronic relapsing skin condition. Nobody wins. The itch is there, the scratch is there, it keeps on fighting, and the child is disturbed. So that's the story of atopic dermatitis. And atopic dermatitis, as you see, this is the only atopy which continues all through, right from the birth, or maybe in the infancy, the early neonatal days, the eczema is there. Whereas the food allergy sets in a little later, the rhinitis sets in a little later, asthma. So this is the famous allergic march which was coined in the 1980s itself. What's important is is that the skin is the one structure which is involved all through the show. So atopic dermatitis, it starts from infancy itself, runs through the whole adulthood. The clinical features, basically there should be 3 clinical features to call it as atopic dermatitis. One is the itching. Itching should be there. The dryness or the cirrhosis should be there, and the skin lesions will be there, the natural sequelae of itching and dryness. So the itch scratch cycle keeps on going. The itch is there, the scratch is there, the damaged skin, and the release of inflammatory mediators. The itch that rashes, and then itch will initiate the rash, and the pro-inflammatory mediators are released. It keeps on continuous as a vicious cycle. The 3 phases are one of the infantile phase, which the children, and then the childhood and the adult. Each has got its own morphological peculiarity. What we see mostly in our practice are the infantile phase. And infantile phase is birth to 2 years. The most important is the sparing of the napkin, perioral and periorbital tissue. The sparing, I mean the napkin area is spared, the perioral area is spared, and periorbital area is spared. So what is left behind is the cheeks. So that's how you see the infantile atopic dermatitis in the cheeks only. A child who has got lesions on the cheeks, which is something itching is there, and it is frequently relapsing, mostly you are going to end up with atopic dermatitis, or that is the infantile phase of atopic dermatitis. On the contrary, you can see a childhood phase where you can see in the flexures, 2 to 12 years, more of neck axilla. This is called the dirty black neck sign. Dirty black neck sign. You can see the necks are involved, the flexures are involved, wrist angle. So this is in the childhood phase. And if you go further, the adult phase, you can get the lichenification. The lichenified lesions, mostly in the flexures are there, the excoriated plaques are there, and this is the adult phase. So we have got the infantile phase where the cheeks are mainly involved, the childhood phase where the flexures are involved, and the lichenified lesions in the adulthood. So that the morphology and distribution of lesions is important in the age-wise distribution is there. So diagnosis-wise, there is mostly clinical, as I mentioned, is mostly the history, morphology, and distribution of lesions. What about the history? This is the important criteria laid by Hanifin and Rajka in the dermatology, and this is being followed even now. This is what you see, there are 4 major components are there. One is the pruritus, second is the typical morphology or distribution of lesions. As I said, the flexural in adults, you go for the flexural lichenification. If it's a child, it's in the extensor area, and if it's a facial involvement in infants. And it should be a chronically relapsing condition. Another important aspect is personal or family history of atopy. So if you have got any of these 3 major criteria, where you have got a pruritus is there, or a chronic relapsing condition, family history of atopy is there, or a personal history of atopy is there, you are justified. And well, we have got a lot of minor criteria. These minor criteria may be a pityriasis alba, maybe a cradle cap. So you see pityriasis alba is there. This is not by itself cannot be called atopic dermatitis, but a child with the family history of atopy, a child with pityriasis alba, which is frequently relapsing, still it may be included in atopic dermatitis, or more so, children with atopic dermatitis are prone to have pityriasis alba lesions more frequently. Palmar hyperlinearity is another one which is commonly associated. Well, this is again another minor criteria only. Another minor criteria is cradle cap. Cradle cap is seen more in children with atopic. Basically what happens is the barrier dysfunction is there. Skin barrier is damaged. It's there. The acid mantle is damaged. So you can have any organism, anything can that infiltrate and produce the lesions. So cradle cap, anything can occur. Juvenile plantar dermatosis. Secondary infections are so common in atopic dermatitis. So these are all minor criteria which can be along with the major 4 criteria. And add on to that, you see more of insect-bite hypersensitivity, IBR lesions, recurrent bacterial and viral infections, even herpes, even HFMD. As I said, the acid mantle disturbance will produce the children more vulnerable and prone for this any type of insults on the skin. Diagnostics test, well, if you have got nothing much to offer, you ask for any allergy condition, IgE, specific IgE, eosinophils, nothing is important here. No specific biomarkers are recommended. Monitoring IgE is not recommended. Atopy patch is not. It's only history, morphology of distributions, and age. Differential diagnosis, well, mostly we may go for atopic dermatitis, but we must be wary of certain conditions. If there is a very persistent, poor response to optimal therapy, we may have to think about these conditions. There may be a chronic dermatitis, seborrheic dermatitis can present, psoriasis has to be ruled out. You must be some biscot aldrich, there may be some zinc deficiency can be there, immunological, or it can be even histiocytosis is another situation which can present something similar to it, or even scabies or dermatophytes can be there. So these are all AD mimics. Well, mostly as clinicians, we all are very sure about atopic dermatitis. We cannot miss it. Family history of atopy, chronic relapsing condition, an infant with these lesions. So treatment-wise, this is the most important aspect, and this is what we need to stress upon. What we see is basically it's a moisturization, moisturization, moisturization. That is a basic, the pillar on which the treatment is built up. So antipruritics, antibiotics, they don't have any role or even the minimal role only. So it's mostly moisturization. So regards this, first of all, you have to tell the parent that patient education, it's not patient education, it is therapeutic patient education. You must tell them where we aim at or what is our target or what the optimal skin care. It is not the treatment, it is the skin care where we aim at. Emphasize the chronic nature and relapses at the first shot itself. Well, there are many concerns on the parent side. Clothing, bathing, food, or what to do or what not to do. We come to the treatment side later, the pharmacological management. Initially, the parents are more worried about what can I give? Is it due to any food? Is it due to any cloth? Is it due to any soap which I use? So what? The cotton, if it is there, you avoid cotton. Synthetic, use cotton inside. Avoid tight-fitting dresses. These are all advice to the parents. Bathing is another important aspect where most parents will keep on pestering you. Bathing is there once a day or even is sufficient. Lukewarm water is one recommended, not more than 5 minutes. These are all recommendations, may be optimal, but it can vary as per the prevalence. It may be a very cold country or very cold climate, you can make it different. Avoid bubble baths, and most important, what about soaps? or can they be used or not used, or which soap to be used? Which soap? Basically, the dictum is avoid alkaline soaps. Because we are dealing with the acid mantle of the skin. We understand that the pathology is the disruption of the acid mantle. We don't want to disturb that mantle, and we need to protect that. So avoid alkaline soaps. And as I mentioned, the pH of the skin is something like 5.5. So we need to use soaps with something in this range, between 5 and 6, the pH 5 and 6. The skin pH, neutral pH of the skin is 5.5, and this neutral pH has to be maintained. And soaps which fall in the range of slightly acidic pH has to be the best ones for a child with atopic dermatitis. This is very bad, and what we see is mostly alkaline soaps, because they are ones which make the skin brighter. Like you saw all these soaps which contain surfactants and acidic materials, they make the skin brighter, but they have to be avoided. So minimum soaps, especially to avoid strong scrubbing soaps and avoid perfumed soaps. They are called synthets are there. That synthetic detergent soaps are there, which like the teddy bar and other soaps, which it's not fair to mention the names in the platform. So neutral to low pH, hypoallergenic soaps are available, non-irritant. In fact, the synthets, the synthetic detergents are the ones which are, well, they are quite costly, but they are the ones which are preferred for children with atopic dermatitis. Food, as they go to do something with these children, empirical food restriction is not recommended in any patient. Empirical food restriction. If you feel that some food is definitely giving some sort of disturbance to a child, some sort of the flare-up is there due to a particular food, avoid it. That is pertinent to or relevant to any allergic situation, even for asthma, even for allergic rhinitis. If you have got any food which is you feel as the culprit, avoid it. Same say the food can be avoided unless if there is a personal experience with that food. Otherwise, there is no mean in restricting food items. Okay, then the management is basically falls into two types: the reactive management, the proactive approach. Reactive ones are one when the flare-ups are there, because as you said, basically the condition is a chronically relapsing flare-ups are there. So the proactive ones comes with the flare-ups, and reactive ones management is there. So reactive management is what you see basically when the topical corticosteroids or topical calcineurin inhibitors, and the proactive ones are the intermittent TCIs. I'll come to it one by one. But before that, we need to look at the moisturizers. What about the moisturizers? Having said about moisturizers, it has to got a lot of optimal use of moisturizers have to be shared with the parents. Regular use, it should be mild and moderate, replace water from the skin and seal the stratum corneum. There are different types of moisturizers. But this is interesting to note that even I had this information maybe 2 years back only when I went through this preparation. We have got occlusive agents which reduce moisture loss. We all think about occlusive agents, moisturizers, just a barrier only. No, there is not much more to do. There are humiactants. They attract water from the environment and make the skin more magnetic-like, and emollients are there. They add hydration additionally. So there are certain items which make an occlusive layer, certain items which attract water from the environment, and there are certain items which add some extra hydration. So emollients add extra hydration, humiactants absorb water from the environment, and occlusive agents are there. Examples are quoted below. Glycerin and other agents fall under humiactants, whereas lipids and oils and other aloe, they fall under shea butter, they fall under emollients. So there are three categories of moisturizers. This is very important understanding regarding, and when we share with the parents, they're quite happy about these moisturizers. Then just to be used, this is very important, within 3 minutes of bathing or wash before the skin becomes dry. Wet application is the rule, wet application. What happens is the mother will dry and make it completely dry the child and then put it on the coat and apply the moisturizer. That should not be there. In the bathroom itself, the moisturizer should be applied. When the skin is wet, moisturizer, because you have to retain a layer of moisture over the skin. Once it is made dry, the purpose is lost 50%. So you advise the parent to use the moisturizer within 3 minutes of, and liberally and frequently, twice a day, but the important constraint is the cost. Even yesterday I bought, before traveling here, I bought a Moisturex. It costs around 375 rupees. So it's not that easy to, 100 ml pack is enough for maximum for 2 or 3 days. So it's quite costly, but if you use it regularly, that saves a lot of steroids. That's a regular use of moisturizer has got steroid sparing effects. This is what you must share with you, convey to the parents, because steroid sparing effects of moisturizers are there, reduces the frequency of acute episode, but the moisturizer has to be used within 3 minutes, liberally, twice daily, when the child is still wet. There are a lot of studies to this effect. There is something called a wet wrap therapy. I just put for your information only. That this is for extreme cases where there is the moisturizer can be applied. So tubular bandage can be applied above it. Now, having seen about moisturizers, the actual therapeutic agent which we are using is one is the topical corticosteroids. And as you all are aware about it, there are 7 classes of corticosteroids depending upon their potency. This is a one group which is called clobetasol and metabetazone, which come under the super potent group. Super potent group are the clobetasol, metabetazone. Second is the group 2, the mometasone furanate, the yellow cone and other groups becomes the second. They also are super potent. But come down, this is the one which I would prefer you to use. That is hydrocortisone. We hear about hydrocortisone, we feel that hydrocortisone is some injection. We are little apprehensive about hydrocortisone always. But this is a best drug, 0.15%, 0.1% hydrocortisone is the best one. And above that, if you want to use, you can use desanide, and if you want to use furamate. So what are the drugs recommended? Steroids that can be safely used are in infants, hydrocortisone, desanide, and fluticasone. Fluticasone, of course, can come under group 4, but this is the third choice. First choice, hydrocortisone only, and if at all you want to go, desanide next. But for children above 2 years, mometasone is recommended. Mometasone is still be used below 2 years, but that's an off-label recommendation. How much? This is also important. Parent doesn't know how much to use it. This is what is called the fingertip unit, FTU. One fingertip unit is for an adult, not the child. If you take it from here, spread it up to your first, the creases is there, and spread it here. This will be sufficient to use for the spread of, when you keep both your arms together, it is sufficient enough to accommodate both the palms. So this is some area. So this gives you an idea about how much moisturizer to. So fingertip unit coming to this area can be used. So you understand now for a child of 1 year how much surface area is there and how much you may need to use. And that should be used for 2 weeks and review. Hydrocortisone and desanide may be used for up to 4 weeks. And when desired results are achieved after 2 weeks, step down. So that gives a lot of steroid sparing effect. Moisturizers appropriately used. Then topical calcineurin inhibitors are another one. So having seen TCS, that are topical corticosteroids, where we want to use hydrocortisone, we want to use desanide. Now we come to the second line drug, TCI, TCS and TCI. TCI is approved since 2002. Tacrolimus is the one which has been used regularly, and pimecrolimus is there. It is recommended above 6 months only, but even dermatologists and pediatricians, we have to use it sometimes maybe below children below 2 years also. Safety of TCIs have been under the scanner for quite a long time, but now it has been very clear that the TCIs are quite safe. Most common side effect is some amount of skin burning can be there. They do not increase the risk of bacterial infections, and malignancy risk is no convincing evidence is there. So I have been using it because still, thank you. Up till 3 years back, I have never used TCIs, but for the last 2 or 3 years, I have been using my tacrolimus, and I believe most of you can use. Don't refer a patient to the dermatologist just for the sake that it does not respond to hydrocortisone. If you do it properly, you can, even tacrolimus is also very safe and can be used appropriately. Antihistamines, they don't have much role, just that they can make the child a little drowsy and then they don't keep on itching. So this is the one algorithm here. This is actually from the Journal of Dermatology 2019. You see the first line, moisturizers and emollients here, TCS and TCI again. And then the second line, severe canard or short course steroids. But all said and done, it has to be maintained. This is important. First line drug, second line cyclosporin, third line azathioprine. Whatever you use, you have to maintain because it is going to be there for maybe for 1 or 2 years. So you have to weaken TCS, maybe twice a week in the Saturday and Sunday. This is a recommendation for the better parental understanding. This has to be done. Maintenance therapy has to be done. Weaken TCS, for if at all, whatever drug you are using, maybe 2 weeks or 4 weeks, hydrocortisone, child response, but you have to maintain the child on a weakened TCS. Systemic therapy, systemic corticosteroids, cyclosporin, these are all just for the completion's sake. Azathioprine. And the take home, basically, atopic dermatitis is the most common chronic relapsing skin condition. It's the entry point of allergic march, as you have seen, and it continues beyond any time. Morphology and distribution is unique. The infantile, childhood, and adult phase have different physical distribution. Moisturizers for the mainstay, how to use the moisturizers, that has been translated to the parents well. Topical corticosteroids, most important anti-inflammatory agents in atopic dermatitis. And TCI is very useful along with TCS. Patient and parent education, extremely important. Severe AD is very rare. Believe me, my friends, severe atopic dermatitis, which is not responding to topical hydrocortisone or topical steroids, is very, very rare, less than 1%. So 99% responds to your moisturizers and topical corticosteroids. And majority of cases can be, this is my carry-home message. Please try to manage the cases on your own. The moment you see and realize that it's atopic dermatitis, don't share with the pediatrician, because the child is growing up, it is going to be an allergic child, atopic child, this child is going to have allergic rhinitis, asthma maybe in the future. This is your patient. You try to treat it. And I am now treating 99% of the patients of atopic dermatitis with myself, which I used to refer maybe 3 or 4 years back. Because now I am very confident that I can use hydrocortisone, I can use tachycardia, and I can have a proper patient education, moisturizers, so many are there. And only thing, moisturizers are really expensive. You must convince the parents to use it liberally and adequately. So if I can convince all of you to treat the atopic dermatitis cases on your own and not referring to at the first shot itself to a dermatologist, my purpose is served. Thank you very much for the patient hearing, and once again, congratulations to SPACT and AFP Gujarat for the wonderful show and academics here today. And thanks for meeting me here. Thank you.
Thank you, Dr. Ramesh Kumar, for the very informative speech. I would request you to please visit our memento corner on the opposite side of the stage. I request our senior pediatrician, Dr. Dinesh Bhai Patel, to present memento to Dr. Ramesh Kumar. Before we move on to the next session, we have our GMC observer today, Dr. Rajnikant Patel. He is the assistant professor at SMIMER Pediatric Department. I would request Dr. Kamlesh Bhai Parekh to present, to felicitate Dr. Rajnikant Patel.
Now quickly moving to the session 3. Session 3 is comprised of 3 lectures in a row. The very first its lecture is on tailored PCV. What difference does it make? And I would like to call upon Dr. Baldev Prajapati sir from Ahmedabad to deliver a lecture. Dr. Baldev Prajapati sir is a professor and head of the department, GCS Ahmedabad. We have heard him many a times. He delivers more than 1500 of lectures till date. We welcome you, sir.
Now it's a time to say good afternoon. Friends, topic allotted to me is pneumococcal conjugated vaccines in our country. Actually, what we should know. And I'm sure that with the availability of the multiple products, this is a big question to the practicing pediatricians. I will try to address with some scientific evidences. We know that at present we have 3 conjugated pneumococcal vaccines. All of you are aware of it. That PCV13 with single conjugated protein, that is CRM. PCV10, old one from GSK, different conjugated proteins they have tried to use with a different concentration of these antigens, and recently available PCV10 from Serum Institute of India. And smartly or intelligently they have tried to omit this serotype 4, 18C and 3 from the PCV13 to make it 10. With some evidences of the scientific facts and to provide this relevant product to us. You know that any product is available, vaccine particularly when the pediatrician, the very first question, should I use this vaccine? And for that we'll have to know this epidemiology of an area. With that we know that these are the points which if we check it, I think SCP is known group to this August gathering. Another study is by Basis, and third is by Dr. Josna and her group, where they reviewed about 7 to 10 articles available with the recent evidences. Friends, if you check the ASIF study, which is regarding the invasive pneumococcal disease in children less than 5 years of age, surveillance study, they study for almost 4.5 to 5 years from different centers of our country, that means representing almost every state, 18 hospitals and institutions, laboratory confirmed, culture isolated in the different laboratories, and 361 patients were culture positive. What I mean to say, that fairly good scientific pattern or methodology of the study. And what did it show? The high incidence of the invasive pneumococcal disease in our country, which I will be the interest of the pediatricians to know, that 5 serotypes, that is 14, 1, 5, 19F, and 6B. And of course, 6A and 19A has been found in this group very significant, almost 10% cases. And if you go for this together, I think it becomes the substantial serotypes present relevant to our country. If you see which are having the low incidence, probably which may be of our low, I will say less interest, and they are the 4, 18C, which less than 1%. And even 3, hardly they got it. One more study, I think the same thing they have put over here in the form of some other format, which already I talked to you. But if we go for the another study, which is called by the basis, they also studied less than 5 years of children, significant, I will say, period of about 1.5 years, together of 10 centers, different states. Again, what I mean to say that represented by almost the country of India. And they've got some 22 serotypes positive cases, isolated either from the CSF or blood or some pleural fluid. Again, what they showed, that most common serotypes were 14, 5, 19A, 6B, and 19F. And together, if you put together, that it represents a significant percentage prevalent in our country. And one more review by Josna, which I was quoting, that almost 7 different studies they reviewed scientifically. And what points they derived? That prevalence of 19A was significant along with the 6A. The point is, you cannot neglect 19A and 6A, because they are the very significant, and all of us know that very virulent, antibiotic resistant, creating more problems, even high mortality. So I think presentation of these serotypes in any product is desirable, relevant to our country. As I was talking, the initial top 10 serotypes was prevalent in more than 73% incidence in our country. And as they have mentioned, that smartly they tried to include in this present product by the Serum Institute of India. Again, 19A and 16A contributed very significantly. Friends, I think if we look at the scientific evidences for the general pediatrician to know that I should have the product where common serotypes are included, especially 19A and 6A, I think which we cannot include. And somehow, that's why I said that smartly, intelligently, probably with the advice of their scientists, they have come up with this new product, which is probably quite nearer to the scientific recommendation as per this epidemiology of this country. As I was talking, that the low prevalence particularly, they found, and they tried to omit so that the better product with the good effect and still probably low cost they can prepare, and I think that points they have observed in this particular product. Again, the same thing which I was talking, again to re-emphasize that 6A and 19A has to be there. and particularly PCV13, which they have gone for that. Almost same effect is found in this product also. I think one more point, friends. If we check regarding our recent even publication by ACVIP of India also, what we are talking, I think, yesterday also, and so frequently since so many years we are talking, that some serotype is there, antigen is there, and some cross protection you are getting, and we are considering safely, or I will say remaining the false secure, that we are protected from that serotype also. Please, friend, check the science of vaccinology, even Plotkin. And the same thing, they have prepared our group of ACVIP, that now we'll have to forget the principle of cross protection. Probably may not be that much useful. To some extent, yes. But any antigen, directly whatever it works, and the quality and quantity of the antibodies available by its action by the immune system in the body cannot be compared with the cross protection. And therefore, I think in that principle, we may not give the much weightage. And therefore, in short, we'll have to check in the product that whatever the antigen is desirable is present in that particular this product or not. If it is not there, just, I will say, argument of cross protection is not, I will say, scientifically acceptable. All of you know, even this our experience of COVID also, that just development of disease, not necessarily he is remaining protected for a long time. He needs a vaccination, particularly with this, I will say, antigen, or particularly with this even variant of this particular organism. So I think that's the second principle which as a scientist we should know. The same thing as I was talking, they have put in this Pneumocil 10 product. If you go for the comparison of these invasive pneumococcal serotypes and coverage, I think fairly good convincing that quite appropriate as epidemiologically relevant to India. Next point, how well does this new PCV10, which I was talking from the Serum Institute, compare with existing pneumococcal, other products? And we know that next question always, that not only the presence of antigen, but how they are working in the body. And for that reason, we are talking of this immunogenicity, efficacy, and effectiveness. And then we compare, even suppose multiple products are available, that how the different products are working, and from that how you can go for your choice. I think that point, if we just check it, different clinical trials, I will not take you much in the details, even for the want of time, but just to highlight these principles. You know that mainly for the conjugated pneumococcal vaccines, we are talking two aspects for its effect. One is this immunogenicity, that is the presence of antibody, and that more than 0.35 microgram per ml. Again, I think all of us know this gathering, that just even presence of or concentration of the antibodies not equivalent to this protection. And for this conjugated pneumococcal vaccine, the desirable point is OPA, that is opsonophagocytic activity. Probably that parameter is more reliable to see or to check its effect for prevention of this disease. From this point of view, different trials have been done. If I take to the direct point, the percentage of the post-primary serotypes responder that I was talking of IgG more than 0.35 microgram per ml, and you can check it, that which is a substantial or also significantly high when you are going for this comparison of this old one, PCV10, and this new one. Even if you check this, which we were talking of this cross protection, that if you see the other products, 6A or 19A, definitely significantly it is high. And the Pneumocil IgG is in short showing the superiority with this presence of the antigen of 6A and 19A. That's the point which I wanted to show with these slides. Not only with this, I will say just after the 3 primary doses, but as a whole, if you check this geometric mean titer, which is, I will say, desirable for the long-term protection, has also been found significant with this new product, PCV10, that is the Pneumocil. What I was talking about the option of phagocytic activity, which is more reliable parameter to check this action of any conjugated pneumococcal vaccine. And if you check over here, again, if you compare these two products, and if you check regarding this option of phagocytic activity of these products, somehow it has been found better with this new PCV10. So friends, with the post-primary OPA titers, with the particular serotypes 1, 5, 6A, 6B, and 19A, and even 23F were significantly higher for this new product. And in short, it conveyed the exact scientific parameter for its better protection. And I think that's desirable for the practicing pediatrician. The same following the post-booster even OPA titer, we can check with this, compare these two products, and which is quite, I will say, uncomparable high with these newer products. Same with the post-booster. OPA, even the GMT titers were also significantly higher with this new product, particularly with these serotypes of 6B, 7F, and 23F. Persistent of IgG1 response, and if you compare these two products, again, the proportion of the IgG responders were higher with this newer PCV10 group for 5 and 8, which are the very common serotypes which already we checked in this our present studies. Same, I will say, with this persistence of IgG for the GMT titer also, and they found again for the group for 6, the most common serotypes, that is 1, 5, 6B, 7F, 14, and 23F, as well as for the serotypes 6A and 19A. That means almost every antigen, if you go for checking the OPA activity, has been found quite superior in this newer PCV10 compared to the old preparation, which probably in the market since several years. Again, following this proportion of the OPA responders was higher in this, especially with these serotypes 1, 6A, 6B, and 19A. I think if I don't take you for this, all the presentations and all this data, in short, if I bring the points of summary to you, that equivalence were demonstrated for the 3 lots of the pneumocil. Lot-to-lot equivalence was confirmed. And based on both the seroresponse rates and the GMC, the overall non-inferiority of the immune response to this preparation, newer PCV10, compared to this old PCV was confirmed quite high. And pneumocil did not interfere with the EPI vaccine with the other vaccines. That means you can give very safely. And of course, all of us are familiar. We have the experience that safety point of view, there is no problem with any of these products. Again, the robust APOA response was found. If you now compare with this PCV13, which we consider that having the more antigens compared to all these PCV10 products, and if you go for the comparison, that for the serotypes 1, 5, 7F, 9V, 14, 19A, 19F, and 23, almost every antigen, the percentage response was almost 100%, which was higher than the even PCV13. So in short, not only with the old product of the PCV10, but the new PCV10 is more comparable, not just comparable. I had to be, to some extent, it has been established some superiority to PCV13 also. That will be, I would say, interest of the general pediatrician to know. And if you check it again, with the PCV13 also, quite superiority has been decided. Friends, we know that if any vaccine is available to us for the practitioner, that the very first, is it epidemiologically relevant? Is it immunologically competent? It is really economically viable and socio-culturally acceptable. I think these are the points which scientifically we would like to check. And as per this discussion, even WHO also agreed, and they got this pre-qualification later somewhere in 2019. That means, in short, WHO also approved this international PDF part. This is a recommendation of the ACVP, We know, which I was talking, that direct antigen's presence is desirable. That's the science. And it's a very appropriate, this pneumocil, I will say, second PCV10. The only thing that regarding the schedule, 3+1, which has been recommended, the only thing at the government, they accepted 2+1, and I think from the public health point of view, also it is desirable for, but our private practice, I think we should follow 3 primary plus 1, there's a booster dose. That's a schedule which I think all of us are knowing and we are following. In short, consideration of the pneumococcal conjugate vaccine as a product choice, WHO has also told. I think these are the just point, maybe some of the points repetition. But I think in the nutshell, if I just convey to you what I was talking, that epidemiologically relevant, immunologically quite competent, economical point of view, on the contrary, quite, I will say, desirable or helpful, and safety point of view, no issue. And of course, all of us know that since yesterday, in the different topics of the discussion, we found that the pneumococcal vaccine, yes, it should be there in our daily practice. And I think this is the group of the practitioner. So my message, that no child should be missed. Probably even government has also been convinced for the public health, and therefore they have adopted even the national schedule also. And with that, if you go for the choice in the private practice, I think with this epidemiologically relevant and effect point of view and cost point of view, I'm sure that this may be their choice. Probably I'm not standing over here just to promote this product, but sure, the scientific or evidence-based points which are there with me, I have tried to convey to you, and I think it's open for you to think and to decide. I think most of the points have been covered. Take-home message, all of you know that India needs PCV with 6 AN and 19. I think this is beyond doubt. If you check any science, they say that yes, 6A and 19A. If you see even the 19A, by chance if it develops to the child, either the pneumonia or empyema or even the bacterial meningitis, almost no antibiotic is working, that resistant. And virulency point of view, almost fatal. And if that antigen is available to me in the product, I'm sure that as a wise practitioner, that will be of my choice. PCV13 and Indian PCV10 have the similar coverage almost. Probably they found that the 418C and 3, if you go for this epidemiology, and if you try to even drop from this product, there is no great loss. Compared to that, probably more benefits, probably the scientists got it, and with that recommendation, they came with this newer PCV. And friends, Indian PCV10 offers top 10 serotypes in our country, which probably scientifically desirable and quite affordable price. I think that is a major factor which is playing the role. Comparable to immunogenicity and safety, already we have discussed. And one more, I will say, very open and loud message to all of us. Every child of this country should receive this conjugated pneumococcal vaccine. And especially, not I will say just academically or scientifically, but law point of view, high-risk child should not be missed with the pneumococcal vaccine, if at all, and suppose by chance child suffers and child dies, in the court of law, nobody will be there to protect us. So I think this is a very important point which every pediatrician should know it. With that, thank you very much, friends, for giving me this opportunity. Once again, my word of gratitude to the organizers for giving this opportunity to interact with all of you. Thank you. Thanks a lot.
Thank you, sir, for your strong take-home message. With this, the house is open for question and answer session. You may ask question to Dr. Bakul Parekh, sir, Dr. Ramesh Kumar, sir, and Dr. Baldev, sir. Any questions?
Hello. Sir, excellent lecture. And I have to ask, like every child should receive the pneumococcal vaccine. But the pneumocil is not advised about the 2 year of age. So the child who has received a partial vaccination of pneumocil below the 2 year, and if we have to complete the complete vaccination, so if child receive partial vaccination below 2 and comes after 2 year of age, what is the recommendation? Is there any data that we have to use another brand, and how's the?
I think to the best of my knowledge, at present we don't have the data, and all of us know that whenever any new product comes, we'll have to give some time, we'll have to wait, and I think we'll have to derive the data to come to the conclusion. Of course, this is your most practical, I would say, question to all the practicing friends, but at present we don't have this exact solution. It's very certain that beyond 2 years at present, this product is not recommended for the use, definitely.
It's because of lack of data. Otherwise, it's a conjugated vaccine,
Yes,
and there is no
That's
harm
why
in
I
giving.
say that we'll have to wait for some time till the data is available, and it is recommended beyond that 2 years of age. Yeah. I think.
Suppose the child has taken only 2 vaccines in a period of 2 years, and the child is coming after 2 years, so can we complete the immunization schedule by this polysaccharide vaccine?
I think all of you know that how much your purpose is served. If you ask this question, sure you will get the answer. By giving this again polysaccharide vaccine, which is in more serotypes, but how much is protection, for how much time, and whether it is desirable or not. The point is our purpose is not going to be served. Except in the high-risk children, where already have covered this conjugated pneumococcal vaccine as per the schedule, and for more protection, if you go for this polysaccharide vaccine, yes, but not at the cost of this conjugated vaccine. Your purpose is not going to be served. Yes, PCV13 can be, yeah. All of you know that even there are certain places where PCV13 is the only answer. And that also as a practitioner will have to know. That even beyond these 2 years, high-risk children, in the adults, right? So many some other places are there that at present, this is the only product scientifically which we can use. This is especially for this, I will say, general initial recommendation, what commonly we are using this pneumococcal vaccine. And of course, even for the high-risk, immunocompromised, adults, so many places, and that's the only answer. Yes, Darshan. Okay.
They are giving the 2 doses of the pneumocil. So is there any data that how much protection it gives?
Sorry, can you?
Yeah, but they are giving the 2 doses at the primary dose, and then at the third dose later on.
I think all of us know for the general pediatric, we should not have the confusion. Since many years we are discussing not only for pneumococcal, any vaccine. Decision for the individual practice or schedule, and the schedule for the public may be the different. Reason is, for the public recommendation, they go for the large scale. That by that particular schedule, suppose here if you are talking of 2+1, and if you go for the achievement and saving 1 dose and coverage and cost and every logistics points, I think, which we are discussing for this COVID vaccine also, that we'll have to keep in mind. And for that public recommendation, I think that's fairly good and we'll have to accept. But suppose the child comes to me in my private practice, I'll go for 3 primary and 1 booster. At the same time, if somebody is asking that the government is giving 2+, in my own college we are getting the free and we are giving. It's absolutely scientific, and that we should follow when the patient is not able to manage 3+1.
Excuse me, I have a question for Dr. Ramesh sir.
Can I just add on and reiterate what Dr. Baldev Prajapati has said, because we have all been part of the immunization committee also over the years, and as well as part of the government policies and the public health also. So we have to wear different hats at what we are addressing. So it's very clear that as a public health thing, we follow what the government has part of its policy, because it has taken into larger perspective a lot of things. But as far as the individual practice is concerned, we just ensure what IAP has recommended as per its policy, because even in that a lot of homework is done, a lot of review is done. So individual practice is a little different and public health is a little different. We are not critics of anybody. There the purpose is different, here the purpose is different, here the beneficiary is different, there the beneficiaries are different. So we are very clear about it. Thank you.
Thanks to all the speakers. We proceed for the next lecture. The topic is Infant and Young Child Nutrition, Potholes in Practice. And to deliver the talk, I invite Dr. Ketan Bharadwaj. Dr. Ketan is a senior pediatrician of the branch, ex-president of the branch. He is the president of IYCF chapter of IAP, Central IAP, and also Human Milk Banking Association. Author of many books, chapters, publications, guidelines, and whatnot. An exhaustive list of accomplishments. We fondly call him KGB. So, Dr. Ketan.
Thank you, Samir, for kind words. I am thankful to the organizers for giving me this opportunity. Being sandwiched between a lecture of vaccines and a lecture on emergency practices, I will prove that IYCF is both. You all know the breast milk is the first, or the colostrum is the first vaccine. And at the end of this lecture, you will be convinced that there is a definite provision that we have to treat breastfeeding failure as an emergency also. Friends, I will start with the paradox of a thirsty fish. I have a thirsty fish in me that can never find enough of what it's thirsty for. India is largest producer of so many food articles in the world, but still has got 14% undernourished population. No matter how strong and good car we go with, ultimately the potholes decide where we will land. We already had started with so many good cars, but there are so many potholes which never allows us to reach our target in time. And this is what is seen in NFHS 4 versus NFHS 5 data, that early initiation or introduction of semi-solid complementary foods or adequate diet or anemia is concerned, we are still very poor. The only thing in green is exclusive breastfeeding rates, and it is definitely heartening. Let us go to India, our own Gujarat, because this is AOP Gujarat's conference. Exclusive breastfeeding rates are improving. And here you can see more and more districts are covered in exclusive breastfeeding as compared to NFHS 4. When before 3-4 in 2017, when I was quoted in one of the Times of India that we can achieve exclusive breastfeeding rates more than 75% in our private practice, and that was a small data, and people laughed at me, and many seniors, they did not had trust in me. But now the NFHS data tells that we are there up to 65% in exclusive breastfeeding, and still there is a lot of scope. So, but then apart from that, everything is in red. Wasting, Gujarat is bad. Stunting, we have not improved anywhere. Anemia, we are worsening. Minimum acceptable diet, we are at a very poor statistics of about 5.9% children only get an adequate diet with proper frequency and diversity. So we are very bad in that. So ultimately, what is the outcome? That very fast increase in stunting is happening at this period between 6 months and 24 months. So that India alone is responsible for 1/3 of global burden of the low birth weight babies. Even after excluding the 66% of infants in the country who are not weighed at the birth. And here we have crossed China, nothing to be appreciated. Why? Why we are seeing so many problems, though we all know all these things? Knowledge, information, it is now there with almost all the healthcare workers. Maybe the older ones practicing may not be having it, but newer ones are having. But skills are lacking. It is an art, and it takes efforts and time to learn. And I will come to it later on also. Similarly, I will come to the attitude and motivation of ourselves. And funding and updation is needed. Every year, 26 million children are added and every year thousands of nurses and doctors are added every year. But skill support is lacking. If a CS undergone woman is not able to latch her baby by simply knowing that she can do it theoretically, unless she is guided by somebody skilled, it is a failure. Telling a family that their baby in NICU needs breast milk and then having nobody in the hospital who knows to help the colostrum expression results in the family members thinking that mother doesn't have any milk. So we need to have skill support. What about our attitudes? May it be nursing staff, pediatrician, obstetricians, family members, policy makers, everybody. We are all MBAs. Mane badhu avde chhe. Because of that, I do not need training or updation. And this is I'm finding with everybody. हरम में सब नंगे हैं, हमको सब में मालूम है हम क्या कर रहे हैं. Many of us, they tell that this is a PSM topic and it is very dry topic. It is for family members, it is a natural process. It doesn't need any support, and so something like supporting breastfeeding is a new thing for them also, and they don't go in for it. And the mothers, they know it instinctively. But now WHO has declared that all mothers need skilled support, all mothers. And family members, they take that pain is a routine thing, and ultimately they don't attend it, and women, they present with breast failure secondary to abscesses. And ultimately, ये सब बच्चे की बातें हैं, इसमें मेरा क्या has been the attitude for everybody, including policy makers. Regarding policy makers, I will tell you that we are losing 4,300 crores annually by not breastfeeding properly, with 13% of under 5 deaths, millions of diarrhea, pneumonia, obesity, cancers, and type 2 diabetes. But India lacks an official budget plan for action on breastfeeding or IOCF in particular. Budget estimates, they go into the nutrition budgets. But then nutrition budget has also gone low by 1,000 crores in this year. And we all take pride in it that we are promoting nutrition. I many times think that formulas flourish but not IYCF. Why? Is it because that breastfeeding is free of cost? મફતમાં મળે છે એટલે એની કિંમત નથી. It is there really. It is much more complex than we think. We had been thinking this statement I am making after working for IVCF for last decade or more. It is really complex, and it is more difficult to achieve success in this field even after putting a lot of efforts as compared to it may be in intensive care or whatever it may be in the pediatrics. So that is one more most important thing is counseling is an art. It takes time to learn, and practice also takes time. And there are changing belief systems in the different cultures. Youngsters, they are coming with different belief systems. A lot of chunk of working mothers is there now. C-sections are increasing. Formula industry is penetrating everywhere. So with all this in mind, and very easy breastfeeding failures are there and difficult to manage them, now the early feeding issue should be taken as emergency, because in ECD we had in SED topic we had seen that there are permanent problems with achieving the maximal potential in cognition. And if breastfeeding is proper, you can achieve it very well. Every minute you lose after the first hour, the risk of death increases in the newborn. We all know it. Gujarat has gone low from NFHS 5 insofar as early initiation of breastfeeding is concerned. This is because there are a lot of outdated practices in health facilities, especially the separation of mother and the baby at birth. There is no support or guidance, practically nil. There may be some in the cities, but in villages and everywhere, the things are dismal. And in that scenario, C-sections are increasing. And still prelactals are there, now modern prelactals of milk feeds. It has been seen that early initiation can improve whenever there is increase in the institutional deliveries more than 20%. So what is about Gujarat? Institutional, you can see the second row. The institutional birth in public facilities increased by more than 33%. But our early initiations are very less. So in view of 94.3% institutional deliveries, the first hour breastfeeding rates are 37.8. Why? We all are responsible. And more of the staff which is not trained and not tuned to a routine to help the mothers. We know there are a lot of factors in C-section that can hamper the breastfeeding success. And one interesting fact is that scheduled C-sections have more delays in breastfeeding versus failed vaginals. This is a new finding. So facilitation of immediate skin-to-skin contact is even more in C-sections. It is feasible to breastfeed the baby right on the OT table. It needs pre-planning, it needs staff to be trained, and more of change of mindset that yes, it can be done, and it is very important. The first day colostrum is most important, and the first hour the baby is most alert, and that is the foundation for the success of the breastfeeding. Again, see Gujarat. See the last row. The C-sections in public facilities are increased by 22% as compared to NFHS 4. And in private, it is increased by 15.8. So again, public facilities has to give more importance, or rather more efforts. It has been seen that wherever there is milk feeds, initial milk feeds as supplement, the early initiations and exclusive breastfeeding rates are low as compared to where there are non-milk feeds, say like water or sugar, watery, jaggery, honey, etc. And that, of course, as compared to breast milk only. So early supplementation with formula should be started with a good counseling, and we don't do counseling about what are the consequences of giving early formulas. We may give it, no problem. We find indications to give formulas in first 3 days. But we never counsel that this may end up with failure of the breastfeeding. Similarly, artificial nipples and pacifiers we use day in and day out. And we don't support practically positioning and latching by sitting by the side of the mother. Here we include everybody. It is not me and you. So why initial support is crucial for breastfeeding support? Here we know that once first 3 days before the lactogenesis 2 starts, there is almost no milk. And this is the period when lack of confidence sets in with problems of infant latching or suckling, and lack of individualized encouragement which is needed for all the mothers, and skilled support that is needed in the mothers, and all the problems they start. Here you can see that if the first 3 days are managed properly with early, exclusive and effective breastfeeding, here effective is because of skilled support. You can go on to the first graph, the upper graph, to optimal feeding. But if you don't, then here the rows they separate very early about suboptimal breastfeeding, and infant is in the maternity home during this first 3, 4, 5 days. And obstetricians and maternity staff have got maximum influence on them. So everybody has got their own stack to fulfill. Now pediatricians, they take stage after 3 days or in NICU. So in the OPD, the first indication for the need of skilled support should be asking about urine output, stool colors. Nobody asked about stool color on 3rd, 4th, 5th day. Nobody calculates the percentage of weight loss that has occurred from the birth weight. And even nobody asked the pain, about the pain, history of pain in the breast for the mother. Especially the mothers, they are shying with males pediatricians, but then you should practically ask. And all mothers in NICU needs very special counseling about maintaining her confidence and maintaining the breast milk output both, and that we all are lacking. Antenatal counseling is practically not done anywhere, but it has got a great advantage in success of breastfeeding. We should now do something about it. All mothers should be taught hand expression. All mothers, irrespective of whatever other factors are there, so that she can at least manage the early engorgement, which is the commonest cause of breastfeeding failure. Zero separation. Early initiation with early uninterrupted skin-to-skin contact. So we are doing rooming in, but practically bedding in is not done, which means that the baby should be at the side of the mother, getting continuous fragrance or smell of the mother, and mother should be looking to the baby for all hunger cues. That is, and babies in cradles, they don't get this advantage, the mother-child diet. Now, we need to have wider beds for it. We don't have those wider beds where both can sleep. So the relatives, they keep the child in their lap. So there should be something about it. The early, uninterrupted means that we should, theoretically, we should not do any gastric lavage, washing, weighing, vitamin K, anything. The child should be directly placed on the mother's chest. And we should not swaddle the infant for it. But that does give a very good result so far as success of breastfeeding and success of neonatal outcomes also. And even success of having the baby crying less and the nursing staff getting disturbed because of that and starting that formula feed. But then we don't give much attention to it, and ultimately this is most important so far as cognitive reciprocity between mother and child is concerned. Bedding in, I told you that baby cries 10 times less and mother sleeps better if you do a good bedding in. Working women, all of the working women, they have got a preset mindset that they have to discontinue breastfeeding, and they very early start bottle feeding and everything. The whole family has got that mindset. It is difficult to change. It is our responsibility. And more added to it that nobody knows that even the working woman can manage her express breast milk and can give exclusive breast milk by increasing the output. And once when you tell, they just look at you as if you are telling something Greek and Hebrew. And added to that, nobody perceives that 6 months leave can be availed as a right of the woman. And also as a right of that feeding woman, they have got to demand a good crash. If I have got time at the end, I will tell you a small incident. IMS industry, I have kept it purposefully blank. A lot of things can be told about IMS industry. The main thing is that as pediatricians also, as doctors also, it is extremely difficult to perceive the nuances of IMS influence on long-term outcomes. It is very difficult. It is very easy to say that we are not promoting, but it is very difficult. Complementary feeding status is even worse. Now it is pediatricians' game only. We cannot blame the obstetricians. And what we had seen in the initial slides is that the stunting starts after starting complementary feeding. So spending 15 minutes, say, at influenza vaccine or 6 months visit would be very worth of it. We have to use all the LPAC principles we had been taught in ECD workshop. Keep flip cards. Write it on the back of your files. And start with leafy vegetables. And we often fail for iron deficiency because we don't start with leafy vegetables. Prescribe iron. There are many interventions at hospital levels that can be done. Most important is follow-up at 48 to 72 hours. And breastfeeding education support interventions, they are successful. In curriculum, everything comes because પાકે ઘડે કાટલા નહીં ચડે. જે senior nurses હોય તે નહીં સમજે, senior doctors भी નહીં સમજે. And undergraduates, not only medical, it should be nursing, nutrition, pharmacy, administration, everything should have it. Quality improvement initiatives should be taken in the hospitals. It definitely increases after the 4th week, the outcomes. You should have special nurse in the labor room and staff in the postnatal ward for it. Combination of all the intervention at the level of hospital, it may be health systems, policies, they would work. And at the last, no matter how long we have traveled in the wrong direction, you can always turn around. The past was ugly, the present is bad, but I'm sure future is good. ख्वाहिशों से नहीं गिरते फूल झोली में, कर्म की साख को हिलाना होगा. कुछ नहीं होगा कोसने से अंधेरे को. If we play blame game or whatever it may be, अपने हिस्से का दिया खुद ही जलाना होगा. Thank you very much.
Thank you, sir. Now, quickly moving to the next session. The topic is sudden deterioration of the admitted child. And for that, I would like to call upon Dr. Mahesh Mohite, sir, from Mumbai. Sir, the topic itself gives a sudden solid jerk to us as pediatricians sitting over here wondering what would be happening to our respective hospitals. So please enlighten us.
Good afternoon, friends. First of all, I thank Gujarat Pediatric Association and SPACT for giving me this opportunity to be in front of you for this all-important annual conference. The topic I'm given is something which is close to our heart. One single incidence of a mishap in your hospital with parents subsequently behaving ugly, then the media trial which goes on, followed by the paraphernalia, if that goes to any conclusion through court, I believe takes 5 years out of your life. The person becomes 5 years older with one incidence. So this is something which all of us are extremely scared of. If you take a heart rate profile of a pediatrician in first 10, subsequent 10 and last 10, I am 30 years old in the practice. So your heart rate in first 10 year average is in the range of 120 to 130. If you are on the right path, it may go down to 100 to 110. And if you are lucky enough, you may reach to around 70 to 80 in last 10 years, which should be the way it should be. And that's what this particular thing says. The stress of medical, we always talk about stress of a medical profession. What does it mean? It's an unpredictable progress, unpredictable outcome, and unpredictable relatives. I suppose the last part is very important today. How do we de-stress ourselves? By predicting the catastrophe, which will come not only by knowledge, but with a lot of experience which you need to gather every day. Counseling the relatives about possible complications or deterioration. Looking for earlier signs of deterioration and stopping the progress as early as possible. And if you don't have facility, this last part is extremely important. Transfer to suitable unit before the deterioration. As soon as you sense it and you know that you don't have facility for maybe PICU, tertiary care, ventilation, better transfer it in time. Who knows, he may be all right within the next few days. And I'm sure every major city now has a good tertiary care unit to support this. And once the patient is being transferred to that unit, even if he dies, they know that everything has been tried. If it is in a level 1 unit where there is no facility, perhaps that's how the patients have their logical repercussions. So early deterioration cannot be anticipated, but we need to be prepared at every moment for that deterioration. A common case, when you're asked about the unexpected deterioration, I'm sure if 10 people are asked, 10 pediatricians, 8 of them will see anaphylaxis. That's what happened in our case. 2-year-old child operated for recurrent interception. Second time he was operated. Post-op day 3 at 11 p.m. I was doing a scopy in my OT and the nurse came running. Sir, this child has becoming severe stridor, difficulty in breathing. And the history was he had just exited about 15 minutes prior to that ceftriaxone. My PG has already given adrenaline, taken him to the PICU. He required some short duration CPR, but fortunately with adrenaline given in time, he gradually stabilized and rest treatment monitored. We are fortunate to get him out, but you can imagine, and I'm sure those who have seen the anaphylaxis can sense the tachycardia which the doctor develops more than the patient. Another case, which can be a bomb, 6-year-old boy admitted for PUOs for last 2 weeks. Initially, he had some altered sensorium, so CSF was done, 30 cells, 80 lymphocytes, sugar protein all right. He had counts of neutrophilic. His phase reactants were high, CRP was 56. Day 15, he came to us at around after 2 weeks of treatment outside. And in the morning, this child was in his neurological status. The neurologist also was monitoring. The neurologist saw the child at 10 o'clock and he said everything is fine. As a routine follow-up, his counts were sent in the morning and these were the follow-ups, 16,000 with a neutrophilic count. Within 2 hours at 11 a.m., there was hyperpyrexia episode of 106, lasted for almost 2 hours, leading to shock. Apnea, was intubated, shock was revived with bolus of NS and adrenaline, but the child left to brain death within next 2 hours. We just could not do anything. This is a lab after the incidents, hardly about 2 hours, and you could see the previous morning's count, which was normal, or the same morning count, which was normal, And this is a story at 1 p.m. within 3 to 4 hours. Counts were 8,000, neutrophilic 82, platelets had dropped down to 30, ferritin was sent 16,000. This is how a macrophage activation of a rheumatological disorder can move to, and literally you can lose a child. Now, can you anticipate them? It's difficult to explain the catastrophe to non-medical relatives. You can imagine this child was doing well in the routine recovery room, and within 4 hours his death. So first and foremost is maintain best relation with the patient and pray you are not unfortunate. Don't put any adverse comment before when he's all right also, because all those comments are recalled when the catastrophe happens, and then it's very difficult for you to defend. So first take home of this talk. You cannot anticipate certain emergencies, but can only be prepared for such emergencies. When I say prepare means you develop a good relation bonding with the patient, any patient, because anything can go wrong at any point of time. Another case, 3-year-old dengue shock. Day 1, hypotensive shock he was received. As a dengue shock protocol, fluids were started, his NS1 was positive, counts were 3,200, plats were 22,000. He progressed to leaking, so needs NS boluses, albumin was given, desaturates, he is to be taken onto ventilator, urine monitoring more than 1 ml per kg per hour at this time. Father was paramedic and knew the platelet count 20,000 and asked repeatedly whether child needs platelet. But the rational pediatrician refused on the WHO grounds. He said, I mean, dengue mein nahi dete hai, unless there is frank bleeding, nahi dete. 22,000 doesn't matter. My IIP colleagues tell me that 10,000 ke piche niche dena, nahi to nahi dena. After 2 hours, child convulses suddenly. Loraz, phenytoin is given. Parameters repeated. At this time, his plats are 6,000. Blood sugar is 230. Rest is okay. Scan done, and he had a massive intraparenchymal cerebral bleed. Child succumbs in next 2 hours. Was it safe? These are all live stories, true stories. These are not fabricated. Could that be predicted? Perhaps the rule number 2, guidelines are not law. We need to take collective safest decision at right time in a given. So here is a deteriorating child going into shock, intubation. Here perhaps 15, 20,000, those who are working in the ICU, Nirmal sir or my friend Himanshu, they will believe. This is a point where rules, guidelines are at one place, safety is different place. You cannot predict how next moment it will go down. This child may require lines, something. So sometimes we have to push it early. So in a given patient, take the safest decision in the best interest of the child's life. Another case, 6-month baby admitted for pneumonia with sepsis, developed septic shock in next 8 hours. Fluid boluses, titration of intravascular volume, adrenaline infusion, stabilized. This child came in the afternoon, and the whole story happened at night between 10 to morning 6. So one echo was done in the case of refractory shock, was all right. At night, shock progresses and becomes refractory, non-responding, all those adrenaline, vasopressin being started, sugars, calcium, electrolytes are normal. A repeat echo at 5 o'clock we did in-house, showed a massive pericardial effusion. At 12 o'clock echo was done, was bang normal. At 2 o'clock was bang normal. 5 o'clock, massive pericardial effusion, refractory shock. What I want to put it here, can this be anticipated? Take home, sudden deterioration has no timing. Be prepared always. And be, especially those who are working in the ICU, should be really, this dynamics keeps changing. Certain things you can anticipate, certain things you just can't. One can definitely think of possible related link in a given case. Here I knew it's a pericardial effusion. I knew it's a septic shock. It's progressing, becoming refractory. So what else? Volume, fluid, inotropes, and then it's an obstructive shock. Think of that and then move in that direction. My teacher, Dr. Ambedkar, used to put this an analogy always, acute, subacute, and chronic as far as onset, duration, progress. And when he always used to say acute is vascular, undervascular, hemorrhage, embolism, thrombosis, vasculitis, vasospasm. Metabolic, all the electrolytes and metabolic parameters. Toxins, allergic, anaphylaxis, immune-related, or mechanical. All 4 cases which I told you are fitting into this analogy. One with the intracranial bleed is hemorrhage. Anaphylaxis, I already told you, macrophage activation, tamponades, obstructive shock. So that's how the thing will have. Subacute is infection, chronic is mass and degeneration. So the acute or hyperacute conditions in above list are the ones which can come as sudden unexpected deterioration in the word. And this approach may help to reach the diagnosis early, and you may be able to save the child if you follow this approach. A 6-month baby boy posted for TA release, tendo Achilles release for CTV under ketamine and midas. Near end of the procedure, baby desaturated to saturation of 45%. Intubated, 100% oxygen, good anesthetist taking care of everything. Child was put onto ventilator because it's not just coming out with this. X-ray was normal and then we didn't have echo. This is almost 15, 20 years ago. Cardiologist was summoned from Mumbai, came after 4 hours and it was a phylostatology. What I want to put here, we checked the notes once again and pre-op saturations in this child were 90 to 93, which was totally overlooked. Normal dikh raha hai, right? American Academy of Pediatric Guidelines says every newborn after 24 hours, 4-link saturation has to be taken and it has to be above 95% after 24 hours. If it is discrepancy or they are all less than 95%, subject this child to echo. That's a guideline. And lesson, follow the norms meticulously. So when you are taking any patient, go through systematically. This child could have been picked up and before the surgery. 92 saturation is not normal saturation. We have learned about it in the COVID basically. Now every layman also knows that below 95 has to be alerted, but we as a pediatrician may not be. Another child, preterm 1.3 kg, 31. He was HMD, ensure, CPAP was given. On day 3, had a ductus, was revived. Day 5 suddenly deteriorated in spite of all this thing. Now ductus is closed, but it becomes hypotensive, dusky all. Bolus NS, adrenaline infusion, 0.1 mic, everything. Re-examination, doubtful clitoral hypertrophy. Now preterm baby 32 weeker, to know that clitoral hypertrophy is very difficult and common practice, baby comes to the NICU, the nurse will wrap the genital part and you rarely see the genital part. So now that lesson gave us to us that one good thorough examination has to be done by the senior consultant. Next day I go, I see new 2-3 babies, I'll open every part of the baby and check it, otherwise I'm going to miss this. This child was 17 OHP, strongly positive, 200, we lost this child after 48 hours because there was a reperfusion injury. Lesson learned, thorough clinical examination and periodic examination subsequently give clue to the cases. Dr. Baldev Prajapati, Rajiv Shah sir, they are all our teachers and they will tell us what is the meaning of this clinical examination. So don't miss subtle markers or signs. Subclinical status epilepticus is something which is commonly overlooked. You get a status epilepticus child, you give Loraz, status dropped, and then everybody is happy. Seizure is not there. After 6 hours, you realize this child is still not moving. Why is not moving? Somebody checks the blood pressure, it's 160 by 140. Is hypertensive and NSAID already seizuring is brain death. That's how it goes off. So, rule, status epilepticus, if he stops, within 1 hour he has to start moving. If not, then go evaluate further. Do an EEG, bedside EEG, say whether it's subclinically seizuring. So all those things are very important. Full-term normal delivery, meconium aspiration syndrome, transport to level 1 care without ventilation facility. So peripheral gynecologist puts it to local pediatrician who don't have ventilation facility. Call received after 36 hours from the level 1 center to us to pick up this child when the saturation was 60%. 10 liters or 2 was being given. अरे इसको शायद ventilation लग सकता है 24 घंटे के बाद. I'm sure many of you must have experienced this kind of a scenario. Transport team asked for, is this sudden deterioration? This is delayed transfer and not the acute deterioration. This should have been anticipated. This baby who is transferred from meconium level 1 is probably not the place for him. Even he can try for some time, but if it doesn't respond within 4 to 6 hours, he should be in a place where ventilation is available. So unit in charge must know the limit of his unit and refer timely to appropriate unit. That's what is the take home number 6. Now can we prevent? So prevention and handling the situation. Once it happens, what are you going to do? We can prevent or handle it. So preparedness, early detection and prevention, response to sudden deterioration and counseling. These are the 4 important aspects of this. Let's go through one by one. Slightly, I think you can read it. So define, you need to have a unit protocols. Code Blue, I'm sure all of you who are NABH accredited must be knowing this. So Code Blue is very important. So mobilization of appropriate manpower experts, resuscitation team to rush to the location, whether it is ICU or wherever. Anyone free in the hospital and can be of help to the emergency should rush to the situation. That's very important. In a smaller unit, 20 bedded, there are 30 staff. There will be a limited number of staff in the PI. So those who are free in the ward should rush to the situation. Defining the place for management in case of such event, preferably a pre-equipped place. So there should be all crash trolley, everything should be ready. Usually ICU is a place for such kind of scenario. If not, then at least some emergency place. Better to allow at least one sensible relative in during resuscitation. It's very important. They must know what we are doing. They must know what interventions are being taken. Somebody should be there. He should witness what we are doing there. Otherwise, suddenly बोलेंगे serious हो गया, ये मर गया, नहीं चलता है. They will not be taking it in a good mood. So these are the things we should have: crash trolley, the emergency medications, though in the peripheral place, at least this basic CPR kit, there are adequate volumes, if there's oxygen concentrator, these things should be there. So basic prerequisite equipment ready to use all the times in such event is a key to successful intervention in acute unexpected deterioration. There should be area allocated if something happens unexpectedly where the paper should be taken and shift immediately there. Early detection of deterioration. So there are clear certain studies have been done, something called as bedside pediatric early warning sign. There are 2-3 studies, and these are kind of guidelines they have developed, BPEWs. A score of 7 clinical bedside. Now this is available on net. I will not waste much of time. I just have 2 minutes left. So this is available on the net. You can go through these kind of charts which are available. This is what we have done to our nursing staff and to PGs. On the first 2-3 visits, new PGs will be trained to make this pediatric early warning sign chart. And they are given clear guidelines. If the chart is this, number is this, you should inform whether you are right or wrong. And that's how they should be picked up. So these can be done, and this is kind of a response system to these early warning signs. If the score goes below 7, that's to be informed, and then you can get this PEWS score. It's available on the net. What are the advantages of pediatric early warning sign? Easy to use by paramedical staff, gives objectivity to gut feeling or sixth sense. Trends are very reliable. Score-based interventions can be decided. Interdisciplinary communication can be validated here, and detection of criticality. So these are definitely very useful in our, especially those who are having non-trained, non-qualified staff. This kind of a score can be utilized. And it's well validated by various studies, whether, I mean, there are published studies on this early warning signs to be used in the ward. So pediatric early warning system, this is a BMJ publication, which is also validated there. And they said that it can be used in a peripheral small centers. It's also to use in the nursing staff as well. So pediatric and neonatal early warning signs are well established and studied, and whole team of medical and paramedical staff should be trained in those early warning sign detection. To handle the catastrophe, simulation and protocol, this can be done. At least 8 to 10 common emergencies, you can conduct a simulation session with your nursing staff. Define protocol for management of such events. The first, so anaphylaxis, any reaction, any sudden collapse, sudden seizure, what to do. We keep doing it in our unit regularly. The first responder, the second responder, the third responder, and rest of the team. So that's how it should be done. You can make a protocol. Even the national protocol can be done. Incoming president was there here, Dr. Ramesh Kumar. He can take up sort of a protocol, kind of a module can be generated for the simulation in the sudden deterioration. Code blue team mobilization, modifying the protocol suitable to your team, and regular periodic training update. Now, whenever you go for this kind of module, it takes into consideration as if everything is ideal, everything is available. It's not. We should design this kind of protocol for level 1 unit, in the periphery, at the taluka place, at district place, what they can be done. And we can, you can train our nursing staff. So 9th take home, simulation training of the team is only possible way to effectively tackle such events. Pre-event counseling for all admitted patients. Communication with every admitted patient. At least one detailed meeting explaining the disease, probable progression, probable complication, possible anticipated events. How much time do we send counseling our patients? At least one good meeting with them. And when there is prolonged patient, at least every third day a good counseling meeting is very essential, especially those who are working in ICU, PICU. I'm sure you do it morning, evening, but a ward patient sometimes feel neglected, that they are not being communicated properly. So the patient who stays there for more than 3 days, at least every alternate day, good detailed counseling has to be done. And last, most important, documentation of the communication. So preferably audio-visual communication, not with one relative, preferably with 3-4 relatives. So at least somebody sensible to note that everything is audio-visual documented. Post-event counseling, I'll just take one last minute. Counseling after event has occurred. Primary brief counseling with the available relative immediately after the event. Many times only one relative is there. And then the others will come after group of another 10 after 1 hour. So one who is there, he should be made to stand and see what resuscitation being made, and primary counseling is to be given. And when the rest of them are coming, you can give a detailed counseling. This part is important. If possible, call their family physician or a senior pediatrician in the area to help you in this counseling. That gives a good impact. They have a lot of faith in their family physician, so that will help you. Counseling to be AV recorded. Don't hide anything. Tell everything that you know. This is very important. Many times we make one mistake in hiding, and then we need to keep making more and more mistakes, and the loopholes can be easily detected in the court of law. So be careful when you are making those kind of wrong things. Inform about risk, probable complication outcome, option to transfer SOS after stabilization, and whenever needed, inform high alert security. I think every city has this high alert security system, so we can inform them. So there is a mob kind of a nature in first few hours that can be tackled. So last take home, effective pre-event communication and post-event counseling is the most important aspect in present circumstances. This can happen to anybody in the best possible scenario, in best possible hospital. So security system has to be strong, counseling has to be there. So friends, to summarize, sudden deterioration is seen in true sudden deterioration, missed subtle signs, or delayed recognition and transfer. So the subsequent two parts, the missed subtle signs and delayed recognition, can be easily countered. They can be easily prevented. Prevention action, pediatric early warning sign to be taught to your nursing staff, to your postgraduate, to your RMOs. Team simulation training should be conducted periodically to avoid these and to have kind of a first, second action once the event happens. And communication with the parents. I think most of the medical legal issues, most of the havocs happen because of poor communication or miscommunication. So have a good counseling session and record them audio visual for your future use. Thank you very much.
Thank you, Dr. Maheshbhai, for the excellent lecture. We can have few questions for this talk and Dr. Ketan Bharadwaj's talk. The house is open for questions. Any questions? I would request Dr. Bankim Bhai to present a memento to Dr. Mahesh Mohite sir.
I just wanted to make a small comment related to IYCF. I know a lot of work is being done and a lot of data is there, and we all know that breastfeeding is the best. But if you see the current generation, the mindset of the males has to be changed. And as we are, so many of us are male pediatricians, I think more important is to talk to the father. We have always been talking to the nurses, the mothers, the obstetricians, but have we ever talked to the father who is there? And it is their attitude. I know I belong to a generation above, and I see this young generation, these young boys, all educated and all. They are the ones who are discouraging their wives from continuing with the breastfeeding. They are the ones. क्यों इसमें पढ़ रही है, इस चक्कर में क्यों पढ़ रही है, बोतल लगा देना, बोतल शुरू कर देना. See, so far we have been thinking that it is the dadis or the other members who are talking about it. But I think we need to change the mindset of all the men who are going to be fathers or who have become fathers. We need to talk to them, and that is the message which I wanted to give over here. And I think we should do it. And of course, the IMS, we know that the formulas are given over the counter by the chemist. Even if you try to trace, you ask them, किसने बोला, किसने prescribe करा? They said, but हम डिब्बा we just got it from the chemist. That's it. It's all self-prescribed and over the counter. I do not know how and where we can address this issue. I think we need to just focus on that. Thank you.
Thank you, ma'am. So we proceed for the last part of pre-lunch session. It's a panel discussion on adolescent health issues. And to moderate the session, I invite Dr. Satish Pandya. Dr. Satish Pandya is a senior pediatrician from Baroda, past president AOP and past president NNF. Dr. Satish Bhai is a great academician, at the same time having a great sense of humor, and he has the capability to convert any hard topic into enjoyable and simple. I would also invite all the panelists, Dr. Sangeeta Yadav madam, Dr. Prasant Karia, Dr. Bakulesh Chauhan, and Dr. Samir Shah to come on the stage for the panel discussion.
Hello. Yeah. So, good afternoon, friends, and welcome to this very interesting panel discussion. The topic, as you must have read, is about adolescent health issues. This is a topic which can be taught or learnt over a period of, say, 45 months, 45 weeks, 45 days, or 45 minutes. That is what we are going to do. And when somebody says that, no, I have very little time to talk about this topic, it means that probably there is some lack of expertise in that person. But I am very proud to have a very elite panel of panelists who will do a wonderful job in next 45 minutes. And we will try to cover the most important issues which are relevant in today's adolescent health medicine. Of course, their introduction has been given, but it's always a pleasure as a moderator, to introduce your very brilliant panelist. Sitting in front, the very beautiful lady who just few minutes back said that, no, I have to wear many hats, but even without hat, you look very beautiful, madam. As you know, Sangeeta madam has been involved in so many IAP activities in collaboration with Government of India, and we are very proud of you, madam. Giving so much inputs into what government's insight into various issues like corona vaccine you talked about yesterday. Next to her, on her right, is Dr. Sameer Shah, a volcano, I would say, a full of energy person, always working, always responding to any kind of work that we demand, and he's very active in various fields of IAP, especially in adolescent. So, welcome, Sameer. Then to her left is Dr. Bakulesh Chauhan, my buddy as a classmate when we had our first batch of adolescent medicine in Kerala University way back in 2005, I believe. And next to him is Dr. Prashant Karya, very popular. He is the only adolescent amongst the panelists and the whole panel. A very handsome guy and has been going to a lot of schools and interacting with, I would say, thousands of students over the last 5 years or so. So that is the brief introduction of my panel. Now, first thing, Madam Sangeeta Madam, that with background of your long professional career and involvement in adolescent care, very briefly share your thoughts on relevance of this discussion that we are having. Let the audience know why we are here.
Thank you very much, the organizers of GUJPEDICON, and having put in this topic, which is of great relevance. And thank you, Dr. Satish Pandya, for that kind of introduction. And very rightly said, we have been into adolescent practice now for almost 20 years. At the turn of the century, it was realized, the need was realized. And since now we have also seen that children, they prefer to continue with their own pediatrician. They are more comfortable with them and they do not want to transit towards medicine. And that is what I have also observed in my clinical practice, that I've been looking after endocrinology. So some of my patients continue with me even as young adults. And so that is there. So as an adolescent, many of us are trained towards it, many of us are practicing in it, but then with what objective we have been practicing? One is, this panel discussion is basically everyone is not into clear-cut adolescent practice. We are all into acute emergencies, acute management, and adolescent practice actually is not anything acute. It is something more chronic, and people they come into limelight only when an issue happens and they hit the headlines. That is very important. So basically we are here to just create some awareness amongst the pediatricians who are not very comfortable about the adolescent practice. We want also, it's a dynamic process. The current times have changed. We should know what is the thought process of the current adolescent, what they want, not what we want to put upon them कि अच्छा ये हमारी धारणा है, हम इस तरह से चलेंगे, but we have to listen to them and we must see what they want. So I remember I had attended the RKSK sharing learning experience 1 year back, and there we had the adolescents, and they are the ones who are sharing what they want from us. The other is we should also know how to communicate what and how much and what has to be communicated, not only with the adolescent but also their caregivers and the community at large, and what has to be communicated through their peers, because peer education is very important. And most important is we must listen to them, we must understand what their perspective is, and we are there to facilitate them, guide them, counsel them, and through their different life situations. So that is in
Yes, thank you, madam.
the points which we need to address.
Right.
Thank you.
So what madam said and what I could summarize is that there is a huge chunk of our population which falls in that adolescent age groups. And we as pediatricians have been looking after them till 12, 13 years. Now times have changed. We need to expand horizon of our practice. And as somebody very jocularly yesterday said when we were talking about early childhood development, that communicable diseases are going down and we need to explore more avenues of our practice. Apart from ECD, I think this one area where there is a felt need in the society for more adolescent experts, because the problems, as I said, the list is very long about the various problems. So there is a need for this kind of discussion, not only to sensitize the audience, but also to initiate a process of learning adolescent medicine. Samir bhai, there is a raging concern about impact of digital media. No discussion goes without talking about digital media amongst adolescents. So please just enumerate the kind of issues that you face as regards use or abuse of digital media. Just enumerate them.
Mainly the issues that we come to across regularly is related with the scoliotic and academic performance deterioration. No doubt few intelligent people taking advantage of that also. But the overall it looks like it's a poor scoliotic performance. Second thing is the related with the lifestyle related issues are now more come across the problematic related due to the media usage. That include the lifestyle, include the diet also, exercise also, and the sleep also. So that related problems are also common. Parental discordance will be quite high, and the problem related with the parents' interaction is also on the high. So that is also one of the important thing. One new addiction is added on other substance abuse, that is the digital media addiction, and other addiction is also there. And we must know about the cyber bullying, cyber crime, and the cyber related all the problems that we have to accept that. So
anybody wants to add in this list problems related to digital media? We'll come to the other aspects of that. Just do you want to add any list to that?
As such, many points are covered. If we want to add a digital media and its problem, then I would like to add regarding the OTTs. The OTTs are full of nudity, sex, violence, which we don't want our adolescents to be exposed. And that is there, everything is there. I mean, you open any OTT platform, and if it is popular, then it is having these issues, and these issues are having many other issues, which I think we will be discussing later. But then media use is should be controlled in adolescence by the use of OTTs. Otherwise, the many issues will come.
So continuing with that, give some crisp tips on the management. How do you approach this issue when a parent comes, say, day before yesterday, I had a couple of parents bringing their adolescent girl that she's so much addicted to this digital media, that all her behavior is changed in last 1.5 years or so. She is not interested in studies. She's locking herself into either toilet or in her own room. She doesn't allow us to go to her room and see the things. There was another girl who said, when I counseled her, parents had come with some issues, and the example that she quoted as to why she hates her parents is that Papa came to pick me up. I sat on the back side of the car, and he immediately said, "Why are you sitting on the back? Let me see what are you doing? What are you scanning in your phone?" So that kind of big divide is happening between parents and children. So how do we manage? Parents are often found totally helpless. They often cry also. I've seen parents a father who comes to me and cries that, "Sir, I don't know how to deal with this very, very sweet little girl who has now grown into a 15-year teenager, and I am simply lost as to how to manage it."
So Satish bhai, before answering the question, I'll just say to everyone, we all are sitting over here and the media menace which you are saying is mainly a mobile. I mean, every time, the study says that every 6 minutes we check our mobile. Bhai, tu zinda hai ki nahi hai, battery hai ki nahi hai. Pata nahi karte kya hai, but we always check it. And that is what our adolescents are also observing, and they are doing the same thing. So, I mean, if we want, the cases which you said that girl is locking this and that,
Right.
at that time, if that parent comes to me as a counseling, मैं पूछूं बेटा कितने टाइम मोबाइल देखते हो? नहीं अंकल मैं तो सिर्फ आधा घंटा ही देखती हूँ.
Exactly.
And then when you ask them, show me the mobile. No, no, I will not show. Okay. Even if they show and you check it, then the main use. See, the thing is, normally we used to say कराग्रे वस्ते लक्ष्मी, ये श्लोक पढ़ के उठना चाहिए. उन लोगों के लिए ऐसा हो गया आजकल, कराग्रे वस्ते Instagram, कर मूले Facebookam, कर मध्य तू share chatam and प्रभाते कर दर्शनम. So this is what is there. See, one of the students which came to us was saying, sir, मैं तो 1 घंटा ही मोबाइल देखता हूँ. And when I installed an app called as a screen time app, I'm again saying this screen time. See, those who are using iPhone, they are already having inbuilt screen time app. But if you're not having an Android phone, you can install screen time app. So we can install in our children's mobile this app called as a screen time app. Or Google has gone one step beyond. They have come with a new app that is called as a digital wellness app. Digital wellness app is having 2 parts. One is for the parent, one is for the children. So if my child is using mobile, I don't want him to be exposed to more than 18 years content. I can have a control. I can use the settings from my phone so that my child will require a password to install that sites or to open that sites from the browser. So that is the first thing which the parents can do. The second most important thing for decreasing all this use, we have to be a role model. If we are using continuously, I'm saying this because when I was the president of SPAC 2018.
Even now, so many delegates are on mobile. You know, they are doing WhatsApp.
So please don't do it. If you are on mobile, तुम्हारे mobile में कीड़े पड़ेंगे. बंद करो mobile, virus. So this is what we can say. So be a role model. I was president of SPAC in 2018 and every time ये faculty को लेने जाना है, इसको mail करना है, इसका PPT मंगाना है, ये base branch का award भी जीतना है, ये सब करना है. I was on mobile and my first article came in newspaper. घरे हो त्यारे mobile અને laptop નો use ઓછો કરો. When you are at home, don't use mobile and laptop. My son was in English medium. ખાલી title વાંચ્યું મને કે પપ્પા પહેલા તમે follow કરો પછી બીજા બધાને કહો. See, this is what is happening. So if you are not a good role model, your children are going to use it. Third thing, social media is so much addicting. I bet that everybody, it's like a cocaine. I mean, you take and you have a kick. Same is with social media. I put my photo and I'm getting 100 likes, 1000 likes, lakh likes. It's like cocaine. It hijacks my reward center in a brain. So they are using it. So we have to make control of that. And for that, this apps will again use. Second important thing, as Samir bhai said, the cyberbullying and part. See, they are using mobiles or any social media and posting anything and everything. I've gone to this place and I've gone to that place. That is fine. But then they are posting so other things which are not age appropriate, and that is causing problems. So for preventing cyberbullying, we must teach them the social media literacy, and for that, think strategy, which is there, which I will like to say in fast. T is for true. Post which is true. H is for helpful, which is helpful to others. I is inspiring, which inspires the other. N is nice, which is to others, and K is kind. So if it fulfills this criteria, then post it. GUJPEDICON ની post Facebook પર મૂકો તો એવું જ લખવાનું કે we were very happy that we got a very good hospitality. That is on Facebook. But if you want to say anything bad to me, then talk to me face to face. That is what we want to say to our children. And as I already said, OTT platforms. See, pornography uses, sexuality related issues, and all these things which are happening in this. For this, we must have a passwords in all the apps, and that we have to talk to our children that yes, if I'm using a Netflix, then my account will be adult account, but if I'm giving a password to you, then it will be a less than 13 years account, so that you are not exposed to other things. Why I'm saying that you are not exposed early? Because your prefrontal cortex is not mature enough. You don't understand the things. See, the 10-year boy watching someone kissing in a scene will be very much excited, and an adult will be watching that, will be interpreted differently because of their brain development. Same is true for the other things also, the pornography and everything. So we must restrict that use, and for that, the most important thing which I say to everyone is have family media policy. What happens is everybody is on phone when they wake up, when they are taking breakfast, when they are talking to each other, when they go to bedroom, even while you, as you said, the father was very kind that he said that show me your mobile, I want to check. Otherwise it happens that father is driving and father is watching the mobile. See, it has happened that the father is also watching the mobile. So this type of thing should not be there, and this type of family media policy, if we follow, then I think we can decrease the hazards caused by a digital media.
Now there are adolescents who come directly to you. I mean, they may come with parents, but they want separately, they want to talk to you. And if she or he says that, doctor, this is happening, like say cyberbullying is happening. There was a girl who was having a cyber relationship with a stranger. She didn't actually know who he is. And then they exchanged some nude photographs also. And then he started bullying her. So what actions can the parents or the child can take in case of cyberbullying? There are some tips on that also.
So this is very similar to a recent case which we solved, that this is called as cyberbullying related to sexuality. So the first and foremost important thing, mnemonic which I developed is smart mnemonic. One is stop the messenger which you are using. Say for example, first don't make friends with the strangers. If you make the friends with the strangers, then that is a problem. So stop the messenger which you are using. Second, messenger to be blocked. If I have messaged something obsessive to you, offensive to you, block that person. A is actually always preserve the evidence. If somebody is bullying you or somebody is sending you some bad comments, then preserve that comments and not delete it. You can just hide it from your social media accounts. R will be retaliate. Normally what happens is, but somebody is saying bad to me, I will retaliate. And that will also cause a problem. So that should not be done. And the fifth most important is tell to your parents, talk to them, smart way. Report it. And now how we report this cyberbullying or anything, we are having a very good website that is called as a cybergov.in, which is our website on which you can do a cyber complaint. See, normally we do a police complaint by dialing a 100 number. Instead of that, we can use this website, or I just forgot the number of cyber bullying.
It's okay. I mean,
this 6-digit number, you can just Google it. It's a 6-digit number which you can just dial it and you will get an assistant. Surat is very lucky that Surat police is very active. They have launched a program called as a Cyber Sanjeevani, in which they teach parents, adolescents, everyone regarding the media hazards and the cyberbullying, cyber safety, everything, and they give us certificates also. So we must take a help of this people. When you call cyber department by dialing that 6-digit number or logging into that website, they will officially launch a complaint. And you know what? The case which we got was the girl was in India and the boy was from the Pakistan. See, it happens. International cyberbullying also. So in that case, this cybercrime, cybergov.in helpline can help us.
Yeah, it can definitely help. In that girl which I was talking about, again, the stranger was from Karachi. Yeah. Anyway, so anyone wants to add to this? Any parental tips or any tips on this?
There should not be mobile using when you are having lunch or dinner.
Okay, that is what he said. Social media policy in the family.
One of the mothers said, "Sir, bathroom mein mobile nahi hona chahiye." See, there are so many things which can happen when the mobile is in bathroom, but then there were some hazards happening to that child, and they made a policy, bathroom mein nahi hona chahiye. मतलब जहाँ पे आपको hazards लग रहा है, उस area में नहीं होना चाहिए. And I must say, Indian Academy of Pediatrics has come with a beautiful guideline on screen time, in which we say adolescents, if they are using the mobile, then it should be 2 hours maximum. And again, parental supervision. जो parents ने बोला ना कि तू क्या कर रही है मैं देखना चाहता हूँ ये नहीं. We have to talk to our adolescents that I want you to be a safe and I want you that you don't bully any other person. And for that, I am just checking your phones. So that is fine.
So in adolescent, when we talk to the parents, we must emphasize the need for keeping the communications channel open. And there are various ways in which you can keep those channels open. Unless those channels are open, the adolescent will not share the difficulties that they are having. So that's another topic of discussion. But let us move on to this pandemic. Dr. Bakules, apart from increased digital media menace, what are the other problems adolescents and parents have faced during this pandemic and even now?
First of all, let me thank you, Prashant and Spec, for inviting me and giving me this opportunity. And you are not my buddy, but you are my guru. You have taught me lot many things. So thank you for that, sir. And coming to this answer, I have just last month in the same line of cybercrime and what cyberbullying you say, it was a 10th standard student, and he was succumbed because I'm 10th standard student, I have to read like that, and he was like succumbed to pornography. He has accessed one site on which the opposite end was the girl, and he was like instigated to be nude, and then from that call is coming, you give me this much money. He has access, some access to some money, and then we had to do police complaint in Baroda, Fatehganj police station, and then this was solved by a huge effort.
Thank you for that feedback. What other issues that we have faced during this pandemic?
Other issues means this was because I was coming that thing. Other issues like there are two things like issue for parents and issue for adolescent. And because there was no school, everything was at home. So issues to the student is that there was no supervision from teacher, there was no supervised work, they could not meet their peers, they could not study well, they were means પહેલા એવું હતું કે આપણે મોબાઈલ નહીં આપવાનો, સ્કૂલમાં મોબાઈલ નહોતા લઈ જતા, આખી સ્કૂલ જ મોબાઈલમાં આવી ગઈ. સો it is very difficult for parents to supervise કે બચ્ચું શું કરી રહ્યું છે, he is studying or he is on some platform and not studying. So that was the thing. And the health issue for the adolescent, eye strain, backache, frustration, depression because of not going out and every time they are on the screen. And for parents, like they were also working from home, so issue of giving a separate place to the children, issue of giving separate like iPad or laptop to the students, like there are multiple issues like
Any
this.
other issues that you have faced in your practice in relation to pandemic, excluding this digital media issues?
Previously, that was called is the empty nest syndrome. And in COVID, it is called the crowded nest syndrome. Means multiple people is staying in the one place, and that leads to the more problem and discordance between the parents and the adolescents because they are not getting enough space. It's one thing. Second important thing, increase in the child abuse is a lot because of the poor parental relations and the lower socio-economic conditions. And one important thing is a failure in the nutritional part. Obesity is also increased. Opposite to that thing, few people who are children who are getting the nutrition from the school, that is also much lacking. So these are the few things that also is associated with these things.
Madam, you or Prashant want to add? Just add to the list.
I think we are somehow concentrating more into the cities, and what about the low socioeconomic class and the rural class, because a lot of issues are over there related to this accessibility and how they are going to go about it. So some of these things we also need to think from their aspect also. That is what I would like to generalize.
Thank you, madam. Some of the issues which I have faced in my practice regarding mental health issues, not related to digital media, is related to fear of death of him or herself, or fear of death of parents. And some of them have lost parents or grandparents with whom they were so much attached. It has been a very kind of terrible experiences that they have gone through during this pandemic, when there was so much morbidity and even mortality and difficult times to deal with situations. So I think mental health issues have escalated to a great extent during and post pandemic. And another aspect which Dr. Samir mentioned was the high incidence of obesity that we are seeing these days. I mean, 15-20 kg weight gain is very, very common these days. We see when a patient comes to you after, say, 1.5 years or so. So these are some of the issues related to pandemic. Now, one more aspect of that is, Samir, how do you counsel parents about need for school and outdoor activities? Because this was one major issue when parents could not give any alternative to the children. What do they do in their spare time, apart from online school from, say, 7 or 8 a.m. in the morning till 2 p.m. and then we say don't take mobile, don't have any screen time. What do they do? So there was a lot of lack of outdoor activities also. Now parents are asking us whether we should send our children for outdoor activities, whether we should send them to school. So what are your views on that?
First important thing, why they are not sending these children to the outside their home. That is a thing that what we have to attend because of the fear of that COVID related thing. So that we have to assure that it's a totally depends on their own consideration how they protect themselves even outside the home. That is important part proper that we are saying SMS, social distancing, mask and the proper sanitization, that if they can take the proper care, they can definitely go to the school. One important thing. Second thing, what is the important in the school? It is not only the academic performance or it's related with the only academic thing. It is give many other lessons of the life that they learn a lot during the school time. So if they are not going to school and taking only online school, it's only academic part, definitely it will be covered very well, we can say, other than the school. But the closeness to the friends, peer education, social life skills, that are the things that we will definitely miss if the school is not properly attended by them. Clear-cut direct observation of the teacher is also lacking, because if teacher come directly physically, then and then they can understand what a real problem, why they are not properly taking the interest in the specific subject. So that also we are lacking. And that's why our Gurukul from since ancient we are thinking for the school is the life education system, not only the education of the academic thing. That's an important thing that we have to understand. Coming to this activity related. So that is the thing, we have to divide the activity to just a simple exercise or the sports. That we have to keep in mind, and then we can give the proper idea to the parents. And of course, here again, the parents will be the role model. If parents understand the importance of the exercise and the sports, then and then they can elaborate that thing to the child, and they can follow the parents. So that is very important thing, because exercise itself give, or even simple gaming distract them from the social media or the gadgets things. So that is the important part. Proper exercise give the adequate nutritional uptake will be definitely increased. Proper rest, because sleep part is also increased. So that is give an excellent thing. Vitamin D itself gives by the physical activity outside the things. Yeah. So we have to keep emphasis on that thing. Exercise, definitely it's a wide things, and sports also giving kinetic, isometric and that we are not going in detail, but that is itself is a very important thing. So if we take proper care by the role model by parenting, it will give us a lot to give.
Excellent messages Dr. Samir has given regarding. I think the most important message what has emerged from his answer is that we need to explain to the parents that it's not, schooling is not only about passing the board exam or some competitive exam. It is much more than that. That schooling is important for the all-round development, personality development, growth of the child. So that point has to be, driven well home. Otherwise, our parents are often under that impression that schooling is only for formal education. So very well said, Samir bhai. Coming to a very interesting topic, which is often, we all, when we attend our adolescent con, we eagerly look forward to the issue of sexuality. So, I have a question for you, Prashant, that spice up your answer with some interesting stories which you have come across in your day-to-day, counseling practice. I can narrate a story where about 3 days back only a couple of parents had come with a girl who said, who managed to get the boy home, and when the boy came, supposedly her friend, she said that, Dad and Mom, I want to be alone with this boy in my room. Flabbergasted. Now parents could not, they were stuck, shocked that this girl is asking to be physically alone with a boy in this room. There is another girl who is sitting in her balcony, and just across the street, across the road where the opposite house is there, where a young married man is always, when she is sitting there, he opens up the windows and starts changing his clothes. She saw it, then she started not sitting in the balcony. It stopped, and then again when she started, again that fellow started. Now this was a neighbor, and that man had grown up from a boy to a man and a married person. The parents were also very scared about what to do. Ultimately, they gathered the courage, went to his house, narrated the whole story to the young man's parents, and then the story ended. So parents need to be conscious about this. But how do we address this issue to the girl? How do we explain that why this is happening, and what kind of other dimensions to this sexuality are there. So narrate some stories and give some crisp messages on that. Difficult topic to discuss, but I'm sure you can do it.
Yeah, that's what I thought when you gave me that question, that this is going to be a very difficult. I still remember when I first talked about sexuality in 2007 and somebody said, sir, masturbation kariye to shu thai, and I was anesuko. I mean, that time I was blank, but now I think few years of adolescent experience, I can just talk. Few stories, as you said, the girl taught me how to kiss hygienically. She taught me how to have a sex wearing a condom and know that the condom is torn. The girl taught me that what is buddy sex. The girl taught me what is different sexual orientation. I mean, I used to talk about homosexuality and lesbian. She said this is a different sexual orientation. So these were the things which they taught me. And the last thing which we learned was about the child abuse, I mean the sexual abuse which were happening. Now, coming to the points, this generation believes, adolescent generation, I mean everybody believes in experimentation and achieving something more, but they believe and do experiment more. So if they are exposed to a media, the first talk in which I said OTT and pornography. See, I still remember MKC Nair sir saying that there is a difference between a pornography and erotica. If you show pornography, if you see pornography, what you see in pornography, there's totally nude sex, threesome sex, animal sex, unusual positions, unnatural expectations of a size of the genitals, breast, everything. And the children expects that. They do expect that the climax should last for at least 30 minutes to 40 minutes, which they are seeing in pornography and which is actually problematic for their sexuality. He said, erotica is fine, in which you are just having some sexual arousal and that is fine. And after erotica, if somebody is doing masturbation, that is also fine. So we say masturbation is not abnormal. We don't advocate that masturbation should be done, but we say that somebody is doing masturbation, it's fine. If it is not hampering with the normal day-to-day activity or the academic activity or the social activities, then that is fine. So that is what one thing is there. When they talk about these things, like the buddy sex, they say, why should boys have only fun? We should also have a fun. I mean, one of the Chinese kit, Satish Bhai, which I came to know before 2 years, that's called as a virginity kit, in which the hymen-like membrane is there, which has to be inserted into a vagina, and that has to be worn on the day of a wedding, so that the couple having a relation will, I mean, that membrane will be torn and literally the blood will come and the boy will think that this girl was a virgin girl. And this type of kits are available which this are using. So anybody indulging into any sexual activity before 18 years of age is actually a problematic which we have to talk to them. Because first thing, the POXO Act says, with consent or without consent, sex below 18 years of age is called as rape. That is a punishable act. Second thing, there are more chances of getting STDs, which can happen with this. There are chances of getting pregnancy, which can cause a problem, medical-legal problems and everything. So we have to talk to them regarding the sexual practices in a way that is making them more responsible. When we talk about ABCD of sexuality education, that when we say abstinence, that is actually problematic for them. Because, see, the hormones are at the peak. They are having at peak and they used to experiment. So they will like to go for some sexual activity. At that time, if you say abstinence, that can be a problematic. So we can discuss about the masturbations and what are the things that can be there. When you say be faithful, at that time, again, a life skill educations will come that yes, you have to be faithful because there are risks associated with that. And then if they are into a sexual practices in this age, then according to law, you have to report it. I mean, because it is less than 18 years and you have to report it. But then we have to teach them regarding contraception also in this age. Reason being, majority of knowledge which they received is from the Google. So that is a problematic.
5 minutes, okay. My watch also says the same thing. Now, so please don't ring the bell. I'll stop after 5 minutes. Yeah.
If you remember, when we were taking one family life education in school, the 10th standard boy, 400 chokra hota, that 10th standard boy was just raised hand. Normally, we used to have question in cheat. And that boy was asking, sir, I am taking care of privacy. You told me never hurt yourself. I am not going to hurt myself. You taught us that never hurt other party. I am going to take care of it. I am doing it with her consent. And I am going to use condom. What is harm in doing it?
Yes.
You remember
that is the issue actually I wanted to bring out. There is another girl who talks to her parents, and same dialogue happened, and she went to an extent that if not abortion, I can deliver that child, and since I am an adopted child of yours, you can adopt as well this my child also. I will take all precaution, everything, but if pregnancy happens. So I think the issue here is not physical sex. Sexuality is not talking about physical sex. There are many dimensions to sexuality. It reflects your whole being actually. And so, Madam Sangeeta, Madam, do you want to elaborate on these various dimensions of sexuality? Okay. So,
I'm not fully prepared about it, so I'll not talk about it.
No, it's fine, Madam. Well, I mean, what we do when a teenager comes to us with this kind of questions, and the parents also are perplexed as to what to do, we need to explain them what are the various dimensions of sexuality, which involves their emotional life, their social life, their career, their social interactions, their standing as a being, their ethics, their spirituality. No, there are various dimensions. No, if you can understand those, I mean, for counseling sexuality, no, you also must be yourself well adjusted with your own self. So that is the requirement for counseling on this subject. Otherwise, the tips which Dr. Prashant and Bakules have said are very important, but that is for physical sex that we are talking about. But there is much more than that. The girl who was seeing that nude man and was complaining, it is the duty of the counselor, we as counselor, and the parents and the teenager to get together, work as a unit, clear out these ideas about physical sex and all those precautions that they have to take. But we need to add to all these other dimensions. Faith he was talking about, emotions I am talking about, social life I am talking about. And that is the age when their prefrontal cortex is not developed. So they do not realize what is happening. They have that urge and they indulge into it. But then there are many more dimensions to that, which we need to explain to them to help them to sail through this. We have all gone through this phase. And there were people who helped us. There are not so many obstacles coming in the way like media is doing now, or whatever, I mean, stimulating factors which we are seeing now were not there. So we had a little easy life that time. But today's parents are facing a lot of problems. So since there are only 2-3 minutes left.
The incidents which you said, sir, just 1 minute, that the boy, I mean the person was showing genitals and everything to that girl. If this type of case comes to us, that is called as a sexual abuse, and you have to report it, because sexual abuse doesn't mean penetrative sex. It means showing your body parts, asking someone to touch your body parts, even sending some messages which are offensive is also called as a sexual abuse, because the data which ECD, was saying that 53% of children below 16 years of age are sexually abused because of all these things. All these things contribute to a sexual abuse, and POCSO says this is a punishable act. If patient comes to you, you have to report it. Thank you.
Right. Sir, one line, which is called sexting.
Yeah. You can add one, and then we move on to one more issue that we want to discuss. Yeah.
It's a sexuality means does not mean how to take the precaution. It's a preparation of the body for the mentally and physically for the sexuality. That's the important part that we have to take.
Fine. Thanks for that input. Madam, one question for you is that there's substance abuse, as you see in media, a lot of drugs are being found out at various places. Recently, we had a huge amount of drug in Kutch at Mundra Airport or in Mundra Port. So drugs are there, but do we see drugs being abused, drug used by kids in our practice? And if you are finding that, how do you suspect that there is a substance abuse, and what precautions you take? How do you manage?
I'll try to be a little brief because of the paucity of time for this whole session which is continuing. Definitely the data is there, available in 2019, published by in the public domain by Government of India, saying that the substance abuse is to the extent of almost 1 to 2% of alcohol and the various opioids and everything in this generation. And the other thing very important is that we all know that the red flag signs, we have to see to the red flag signs, their change in behavior, and their whole lifestyle changes, their hygiene and everything changes. And the most important is the heads approach, the risk and the protective factors. So I actually wanted to flag off the heads over here related to substance abuse. and what kind of environment they have, what kind of friends they have in school, what are their peer interactions, and what are the family interaction, anybody abusing in their own home. So these red flag signs can be picked up. And the other is, as in office practice, we must know what is primary prevention, secondary prevention, and tertiary prevention, and primary management, secondary, and the tertiary. And and plus there has to be anticipatory guidance for the children, making them aware of it about the substance abuse, the parents, the community, as well as in the institutions and schools, let them be aware about it. And also the secondary prevention, if they have already initiated it, we must refer them to a psychiatrist. Let the psychiatrist handle it. We may not be able to actually do justice to it, and of course once it is there, they have to be sent to the rehabilitation centers, and the peer group is very important. And many of these peers sometimes have gone through the rehab centers, and they themselves become supportive to prevent substance abuse. So that also we should have this thing.
So the important thing for us to remember is that it is there in our society. It is there very rampantly. Probably we are either not getting them, or whenever we get them, probably we are missing them out. So please remember that substance abuse should be one of your differential diagnoses when a child comes with some physical problem or even behavior issues. Lastly, Dr. Samir, there are now adolescents who come to us seeking career guidance also. So please give some tips on that, briefly. This is the last question.
Sure, sir. So basically, we have to keep thinking they are coming for counseling for two ways. One thing, એક જણ એવી રીતે કહીને આવશે કે સાહેબ આને ડૉક્ટર બનાવે છે પણ એ સમજતો જ નથી. અને સેકન્ડ પીપલ ઇઝ કમિંગ કે અમારા મગજમાં હજુ બી નક્કી નથી થતું કે સાહેબ એને કેવી રીતે શું બનાવીશું. તો there is a two issue. One having a targeted thing, and second having a problematic thing, how to go ahead for that thing. So one important thing, keep in think, now each and every chapter ultimately ending with the counseling. So we have to learn how to counsel. That is important thing. And counseling includes the patient's listening, very important thing. Second is the communication, and third important thing to empathy.
How should we prepare ourselves for career counseling?
Sir, that's I just...
As a counselor, what should be our preparation?
Yeah, that's...
Apart from counseling skills, this specifically targeted career counseling.
So this is the thing, one important thing, we are not a career guider. So we should not prepare everything. We have know all the because almost 12,000 lines are available for after 12th is there. So we are not expert. We are counselor. So we can guide them how to go ahead for the which is equally pardonable by the parents also and the children also. And that's the important thing in the career counseling. Definitely we should having a basic knowledge, but after that we having a good team that can give the proper career guidance. If that is two things is available with us, and because of our counseling skill, if they can guide them, definitely technical aptitude tests are also there to guide that thing.
Right.
So that's all things.
I think the role of pediatrician is to communicate well with the parents that it is the child's interest, attitude, capabilities that should be considered rather than imposing our own wishes on them. Recently, I met my cousin during Diwali, and his daughter was, I said, what are you doing? He said, she's doing biology. So you are going to become a doctor? No, she said that I'm going to be a veterinary doctor. And his father was calling, what are you talking? But she's an animal lover. She loves to be with animals. So here comes our role that, okay, if she's interested, veterinary is not a bad field to be in. So that kind of support we can give to the family. And if we are not equipped with all those tests and specific guidance for career, we can always refer them to a good career counselor. So I regret to the panelists that the issues that we had decided to discuss, we have been able to cover only 75% of them. But there is a time limit because I requested not to ring the bell. They have not done it, but I think we need to wind it up here. And I thank you, all of you, for very brilliant inputs. And I also thank the audience for being seated on an empty stomach to listen to our discussion. Thank you all, and thank you, organizers.
Thank you, Dr. Satish Bhai, and all the panelists for the excellent panel discussion. I now would request Dr. Prashant Karia, Dr. Bakulesh Chauhan, and Dr. Samir Shah to please visit our memento corner.
We will not take memento, but we'll
Yes, definitely. Yes.
photograph.
And I request Dr. Digan Sastry to present memento to our panelists.
Sir, excuse me, sir.
Satish bhai, one question from the audience.
Thank you very much, sir, giving me chance. કે સર એક સજેશન એ છે કે પેરેન્ટ્સ એક સ્પિરિચ્યુઅલ સારો પ્યોર સ્પિરિચ્યુઅલ પાથ તરફ જાય, ધારો કે રામકૃષ્ણ મિશન, બ્રહ્માકુમારી, અને ચિલ્ડ્રનને પણ નાનપણથી લેતા જાય તો એક લોંગ લાસ્ટિંગ.
When I counseled during this pandemic, I had encouraged a lot of parents, even abroad also, to undertake AOL or some other that helps them a lot, and they have come back with that feedback that we have benefited a lot.
She is a pioneer in therapeutic endoscopy in children, a pioneer of liver transplants. I request Dr. Neelam Mohan to please come on the stage and give her lecture on acute fulminant hepatitis. Welcome, ma'am.
ये दे देंगे नीचे. पानी भी दे दोगे प्लीज. टाइम अभी स्टार्ट करना जब मैं सलाम मारूंगी. पिछली बार ही 3 मिनट ले लिया, अब मैं 5 मिनट लूंगी. मजाक कर. Anyway, good afternoon everybody. Either the organizers love me too much or they don't, because usually lunch के बाद दो ही लोगों को मिलता है, आम को टॉपिक नहीं मिलती. या तो स्पीकर इतना अच्छा हो कि पब्लिक जल्दी आ जाए, या दूसरा पूरी भड़ास निकालना बोरे, चलो हम लोग खाना आराम से खाते हुए बोलता रहेगा. So one of the two, I don't know what the intention was, but having said that, it is said that even though there are 10 people, but those who, are interested and it matters, it is better to speak to them than to speak to hundreds who are not interested. So we will have good eye-to-eye connect, and I will try to make, again, the topic liver failure as preferably maths. And there are some women on the other side. I would just like to say that I'm also the executive member of WW Working Women IAP group, and it's the main focus of it is to try to mentor and support more women, which is first of its kind in India. I did that at the liver transplant level internationally a lot, and I think it really matters because there were a lot of mentors for me too. So you must join if you're not a part of it. Okay, so what is pediatric acute liver failure? Very simple, something where your evidence of liver injury. How do I know there is liver injury? Either bilirubin or enzymes. So there is some evidence of liver injury, but that is associated. अगर आपको talk समझ आ गई तो अच्छी talk दूंगी, इधर ध्यान देना, मजाक कर रही हूँ. So if there is liver injury, if INR is more than 2 post vitamin K, that's very important because residents forget to tell that. And then you won't get the marks. Post vitamin K less than 2, even without encephalopathy. So that's liver failure. But if you have encephalopathy, things are easier. even 1.5 is liver failure. So according to pediatric acute liver failure definition, because earlier people used to say 4 weeks, 6 weeks, 8 weeks, 12 weeks, 6 months. So we just call 8 weeks from the onset of illness. So practically 2 months. Is that clear? That is the basic evidence. And the triangle says no evidence of CLD. That is it. So next somebody can ask me that first time it presents, so that nowadays we call it as ACLF and all that, acute on chronic. But we'll not confuse, no known evidence of CLD, let me tell. So simple, what causes it? Any virus which can cause, typically we say A, B, C, E, but we know that A and E. And the other viruses is very important, especially in infancy. The herpes, adeno, CMV, all this become more important in infancy. Very rarely you will find a child with an EBV or a CMV getting into an ALF. So especially that age it gets very important. Metabolic, all of us know in India, the two common metabolic conditions are going to be Wilson's disease, next is tyrosinemia. These are more, and the next third I think is coming above tyrosinemia is PFIC, progressive familial intrahepatic cholestasis, and you will be surprised, your side has a lot of genes. I've seen a lot of patients coming with PFIC from this side of the belt too. So besides that, less rarely fatty acid oxidation, mitochondrial, leave that for me, and and the third is autoimmune liver disease. So either viruses, metabolic condition, autoimmune, any condition where Dr. Saab is involved, dengue, sepsis, hypoxia, liver failure, and of course the pulmonologist and neurologist who keep referring us patients on tuberculosis or anti-epileptic, drug-induced liver failure. My first liver transplant in King's London, Birmingham, when I went, was a child with tuberculosis. So they called me first time because they got somebody from India. So they wanted to know, because that was a girl who had gone to Pakistan and come back. She was on ATT and she went into liver failure and had a transplant. And my next patient was a Wilson's. So it does happen that you need even liver transplant with tuberculosis also. So despite the entire workup, 40% is cryptogenic. So you must tell the parents, because parents keep asking, "Kyun hua?" So this is the simple diagram. Ki ye kyun hua? How does it occur? So simple maths, liver आपका आधे से ज़्यादा खत्म हो गया, because God has given you 2 kidneys and also 2 sides of the liver. So more than 50 has to get damaged before you get into liver failure. That is why. How can 50 get damaged? Because sadly, we Indians have a lot of fat in our liver. So if you do a fibro scan, don't be surprised if you have a fatty liver. I mean, 90% I would bet you would have. So in that, unless you know what is the percentage, so that fat is already not working. And uppar se the remaining, so that's how it does get. How does it occur? It's a very complicated thing, but simple I want to say कि अंदर ही हमारे अंदर ही toxins accumulate हो रहे, इतने सारे नाम, forget it, bile acid, bilirubin, phosphate, nitric oxide, phindole, fatty acid and all that stuff. In end, सारी खुदाई एक तरफ, जोरू का भाई एक तरफ, 2 things which matter, ammonia and lactate. These are the ones which really are making a culprit, and because of these toxins, slowly the brain function, kidney function, cardiovascular function, bone marrow, all is going on a toss. So you have to be very smart to understand that this is becoming a vicious cycle. And how do you get encephalopathy? How do you get cerebral edema? Why do you die? Is that this ammonia and the other toxins which I said related to sepsis, endotoxins, dyselectrolemia, that crosses the blood-brain barrier, ammonia. Ammonia converts glutamate to glutamine. Once this is converted, there is water. There is skull, there is swelling of the brain, and that's how you will get into increased ICP. That is the main reason of cerebral edema. So how do you suspect liver failure? Jaundice, somebody will tell me. Is that the right answer? Very good. It's not the vitamins. Because you've seen 1.5 years, 2 years, 3 years, they are in liver failure, but the bilirubin is like 1.52. So clinically, you can't even make out. Parents will never even tell you. So they need not be always jaundice. What is more important for you is, that's why I said my first round I made liver injury. So it could be bilirubin, it could be enzymes. So that is the important part to remember. And in child, it could be encephalopathy, it could not be encephalopathy. So therefore, this diagnosis, I deferred, again 30 years back when I used to take lectures, I deferred from S.K. Mittal. He used to tell in lectures that jaundice, no need to do any test, bacha apne aap theek ho jayega, do max enzyme. And I remembered as a student, I got up and I mentioned to him no, and it was taken as offense, because you will never be able to diagnose liver failure without an INR. So his message that forget was, it was inappropriate, because 1% is also high. In children, 0.1% get into liver failure. And so for coagulopathy, there is no shortcut except a INR. So that's what I wanted to impress today, that how important people will say, yes, clinically, of course, if you have jaundice, it helps you. Of course, the child is irritable encephalopathy. So all is a package in that, but you need that test. How do you manage? Extremely simple. Though the management is simple, but to execute, they say a good lifestyle is very simple. Don't eat after 8, do this, eat vegetarian, think good thought, think. So that it's very simple, it puts in 5 lines. But to do that is very difficult. Very tempting to have a sweet in front of you and to say no. So similarly, something like that. Basically, it involves sharp monitoring. So your life gets into a toss like a hepatologist means I don't have good sleep. And the reason for the good sleep, not that, is every few hours, like you, intensivist, I have a habit of looking at the mobile every 2 hours. Just can't help it. And that is because you know that somebody is a transplant, somebody is a liver failure, somebody's come. So it needs all the time monitoring to be there. Though you have a battery of people working, but this is very important, monitoring, supportive management, and the ICU setting that. Simple electrolytes you need more. Ammonia you will chase. Why? Because I have to monitor to decide, can I treat this patient medically or do I need liver transplant? A. B. Can I treat it my center or do I need to refer it to a tertiary care, whichever place at your place? Very simple. That is the key message that needs to be done, because from supportive to definitive I have to decide, and I have to decide should I transfer. So for that, you go on your evening round at 6 p.m. Dr. Shah goes there and he sees and he thinks this child thoda jada chidchida jada ro raha hai. He thinks I'll come early for a round at 8 a.m. Was he right? Orange shirt. Why was he not right? Sorry? Right. The reason is, in liver failure, liver goes like this. And liver comes also back nicely. So the reason is, if you think the child was deteriorating, you don't have 12 hours to decide. He has to decide in the evening. If he has to go for a party too, he has to say, iska 1 minute ye ammonia kar do, ya encephalopathy dekho, and I'll teach you what I do. I'll just teach you next. That you need to be just sharp. तुम्हें पूरा ना समुंदर दिखना, ना मच्छी दिखना, मच्छी की आंख कैसे देखना है, that I will tell you. So when to refer if you are in the periphery, like the most beautiful calm couple I met today, the lady in the mask and Dr. Saab in very calm couple. I really enjoyed your vibrations. So भैया आपका ये चले गया आ गया. So any time what Shah said कि behavior abnormality लगे उसको, he should not ignore it, or that rising coagulopathy. Now you feel that the INR is going above 2, you're getting worried, or you think there is fluid imbalance, child has started looking puffy, and you're not sure how things are going. Creatinine is rising, urine output is decreasing. There is evidence of hemoglobin going down. There is hemolysis in three conditions. One is Wilson, one is hepatitis A with G6PD, and third is autoimmune, DCT. So these are the conditions where, or there is a family history of liver disease and a past history of very worried, maybe the underlying liver was really bad, and you cough. So you all need 2 lines. You all at 24 hours in your phone, whoever in your nearby place, you need to have a number of an ambulance or an airlift ambulance or an ambulance to send to the place you want to send. That is my key message, because if you say the parent, there was a patient who had actually from Gujarat region only, as much as I recollect, and the patient was sent without any monitoring. That the parents were so upset with the doctor, and it took me so much of time to keep telling, no, he was not wrong. And I called up the doctor to say, please make sure that all your documentation is right, because that gets very difficult if you did not tell them how to transfer. And that is a different lecture, but how to transport, the doctor has to be called whom you are referring, and all management has to be done before. So the management is a beautiful cycle. Whoever is on duty, you just tell them 5 things देखना है, fluid देखना है, INR देखना है, तो fluid के साथ sodium potassium देखना है. Fluid कैसे देखूंगी अभी बताती हूँ. What I do is, we keep an ultrasound in the ICU, we do the IVC monitoring. IVC fullness say we will get to know. CBC helps you for the trend, but fullness is best with that, and residents get smart into that. And then for ICP, we will look at optic sheath, I will just show you, lungs, kidney, infection and sepsis. So what happens if you give more fluids? You will get into edema, cardiac CCF, congestion, pulmonary, kidney. So these are all the issues with more fluid. If you give less fluids, again same, bad for because the intracranial pressure have to be maintained. See, the difference between the ICP is high, so cerebral perfusion to increase, you need to give more pressures. So the best inotrope is noradrenaline that we like to use. You should not allow the BP to go down. Use it to keep on the 50th to 90th centile and do that. And your goal is basically brain. So you have to prevent brain edema. So these all things, head and raise, midline, less stimulation, quiet room, give 1 nurse to this patient. My reason of moving, with due apologies, I mean, I have nothing, I'm happy and regrets both, but I worked to 2010 in Gangaram, and then I moved to Medanta in 2010. And let me tell you, in 2010, I made 30% more than what I make now. So it was not for money, but what I enjoyed here was 1:1 nursing, 1 ICU, 1 K. So yes, the doctors may not end up making, but the care was so interesting that that is not possible by just me. So I made the first department. I made I have like 6 people under me. So that's how it was possible to give it. Otherwise, you can't. So this is one care, because if there is very high chances of sepsis. So patient is looking after 2, 3, and you'll end up with sepsis and lines. So you just see the monitors that there are 7, 8 monitors. एक में NAC चलेगा, एक noradrenaline में भी, एक albumin, एक में IV fluids, एक में potassium infusion, एक में 3% saline. So these all 5, 6 monitors are going on. Keep your target sodium 145, 150. 3% saline we all prefer. Of course, mannitol studies are done best, provided there is no renal failure, you are sure about it, then you can give you check your osmolarity. Fluid balance is the key that you need to avoid overload and dyselectrolemia. No great role of hyperventilation or hypothermia, though people said. Prophylactic we don't give, but when they get it to grade 3 encephalopathy, then maybe you can consider. Otherwise, if there is seizure, levetiracetam, phenytoin. For ammonia or hepamerge, no great role for ornithine and all. Yes, rifampicin, lactulose, and the key to my success is this, CRRT. So what I do with that is I usually do a lot of CRT dialysis. I get at grade 2, I am there that I want this to be done very quickly to get the flow. So when I do, I'll share the next slide with you. So we do give antibiotics, we do give antifungals, we take care of the line, we take care of the catheters, we monitor for SIRS. We give FFP only for invasive procedure because we need to see which way the patient is going, and just giving FFP is not the right. You can do TEC if the facility is there, which tells you what exactly blood product you need to give. And it's like an ABG, you send a sample, it comes within 30 minutes, the machine tells you what product actually you need for it. And suppose you're not able to, during that support time, you need some device. So I have not used this device more than twice, thrice. The reason is we are a transplant center. But sometimes in cadavers, you're waiting for a cadaver. That is the time where you use the hepatic support, because each system, that dialysis Mars therapy cost 1.5 lakhs. So what is the difference between CRT? CRT removes the water-soluble toxins. Mars removes water-soluble and albumin-soluble toxins. So some toxins which are protein-bound in the liver, it removes both. So this is what you say. And in the end, have you seen that movie Chashme Badur? One of my favorite movie. Uska ek favorite dialogue hai. If you can't, dash, dash, dash. If you can't change the girl, change the girl. He tells to the hero. मतलब उसकी गर्लफ्रेंड से बड़ा परेशान था, उसको बदल नहीं पा रहा था, उसकी गर्लफ्रेंड जिद्दी थी, तो कहता if you can't change the girl, change the girl. So ultimately, Salah, if you can't change the liver to get good, you have to change the liver. So that is when you need a liver transplant. And that, when do you need a liver transplant? If your INR goes more than 4, or the King's criteria, if your INR is more than 6, irrespective of anything, or 3 of the following: age less than 10, non-A, non-B, jaundice more than 7 days before encephalopathy, bilirubin more than 17, or INR more than 3.5. Any 3, we also feel strongly that that is the time you need to start working and seeing for the transplant. See the trend over the next 48 hours, how the patient is doing. So 14 years old child who came from Delhi with liver failure presented in grade 3 encephalopathy right at that. So you all know encephalopathy, 1 is irritability, 2 is awakeable, intermittent, more sleeping, drowsy, and if it gets into grade 3, grade 4 is that, which means you're very bad in your caring if a patient has gone there. Grade 3 also, before that, you have to get into ventilator. So 2 things, key messages: early ventilation and early dialysis. So this patient I'll show you. So he presented as Hepa, fever, and there was cola urine. I told you 3 condition cola urine. You remember? So because he's from North India, I will look for G6PD in North India. So if that is there, what will I do? Anyway, the patient was grade 3. So when they called me, what did I tell them? Wait, let us put on ventilator there. I will give you an ambulance and we'll shift on ventilator. That was better. So we put the patient on ventilator there wherever the referring center is, and on ventilator transport better. You ask an intensivist, एक sick बच्चा है या 4 बच्चे वेंटिलेटर पे है, वो कब सोता है? वो तब सोता है जब 4 वेंटिलेटर पे, बड़ा खुश होके, क्योंकि वेंटिलेटर पे सब सट्टे सिस्टर देख लेंगे. बट वो सिक है तो कब दालों पे टेंशन पे सो नहीं सकेगा. सेम चीज. सो आई विल बी मोर हैप्पी कि वेंटिलेटर पे मैं लाऊं rather than उसके बिना लाऊं. So now I was telling, I'll tell you what do I do. So I look into the pupils optic nerve sheet diameter. So pupils normal is less than 4 in less than 1 year or 4.5. If the pupil diameter optic nerve sheet जा रही है, that means cerebral edema है. So this is how we quickly look right there. And then the liver was slightly palpable, spleen not. Ammonia was 172. What should I do now? Immediate dialysis. Best way. You have to do dialysis because ammonia is water soluble. वो आ जाएगी. Bilirubin नहीं आएगा. उसको मेरे को albumin चाहिए, Mars चाहिए. CRT is cheaper. 10-20 हजार per day. Setting line में 30 हो जाएगा first day. So start with that, give a continuous CRT. लेकिन इसको क्या था? कोला था. तो और क्या करूं मैं? और क्या करूं? Intensivist. What should I do? Plasmapheresis. So anyway, ये guidelines of CRT, King's College criteria, more than 150 or an absolute value of more than 200. तो जब वो 170 आती है, आप CRT अरेंज करते हो, 2 घंटे में रिपीट करते हो, 150 से नीचे है तो थोड़ा देखते हो, अगर वहीं है और जा रहा है तो आप उस पर डायलिसिस स्टार्ट कर देते हो. अब उसके बाद पेशेंट की हिमोलाइसिस हो रही है, बिलिरुबिन इतना बड़ा 38 and 25, तो प्लाज्माफेरेसिस भी करी, CRT भी करी, इम्प्रूव करी, सब कुछ हो गया, खुदा हाफिज, चले गया घर पे, हैप्पी, स्टोरी फिनिश्ड. दूसरा बच्चा 7 years, सेम जॉन्डिस बट 5 days हिस्ट्री ओनली. विद इन जॉन्डिस के अंदर 1 month जॉन्डिस एंड स्लीपी फॉर 5 days, इरिटेबिलिटी. दैट इज द ट्रेंड नाउ गोइंग. दिस वाज फ्रॉम नॉर्थ इंडिया, दिस चाइल्ड हैड कम. सो रेलवेज का बच्चा था. August 2018 में you see, and by 3 weeks later he goes to a referral center, North Indian referral center, and they immediately, smart people, they did the INR. Before that किसी ने उसका INR ही नहीं किया रेलवेज में. वो tertiary वाले ने INR किया. INR is 4.5. They didn't believe, they gave vitamin K, repeat 5.2. Immediately they said you should urgently go for a liver transplant because it's already 3 weeks, bilirubin is very high, INR is 5, go for a transplant. So now the story starts कि पहले वो Northern Railway जाएगा, then Northern Railway refers to me, so that protocol, then they come. As soon as the child comes, transport care, I will teach them, जो पहले teach करी, I teach transport care. This child I did not intubate, ventilate, because they told me grade 1 है चिड़चिड़ा. They did not tell 2. But when the child came, at the emergency, I could feel there was slight decerebrate. Immediate intubation has to be done. So maybe it was wrong. The doctor who told me was grade 1 was probably not appropriate. A, B, the child deteriorated. So now question comes transplant. Mother is O, baby is O, but father cannot give, and mother enzyme high. So enzyme high, I cannot take it. I have to first treat her for this enzyme. What do I do? Now I need a bridge, because I can do transplant, but donor is not. So for this bridge, this is what you need to do. There is a bedside CT scan, there is bedside plasmapheresis, there is bedside dialysis. Everything should be going on to sustain this child till I've done plasmapheresis, CRT, all that I'm doing. This is the SIRS. You can see that cardiac, all how it is contracting. Everything I should know for this child. And then once the mother gets fit, the zenith of satisfaction, there's a video which is not playing. When she gets up, I'm scared because she came like this. I asked her, what is your name? She says, Soumya. And I said, wow. Because the doctor is worried that brain should not get affected. And that is our experience of, our team has done 3,200 transplants. And we've done more than 300 pediatric by September, October. 30% of the transplants are in less than 8 kg. And I bow before the Almighty because the world's lightest baby, 2.1 kg, was done by our team. So that says the passion Indians have into working. So liver failure is 23% of the patients we do. And if it wasn't for this mother, in 2004, this mother I spoke, her child was in liver failure, Wilson, family was against it. I said, please donate, I'm confident on myself, I'll save your child. She trusted me, and this was the first transplant we did in liver failure. And look at that handsome guy, he does modeling, he does gymming and all that stuff. He's a smart guy now, 17 years down the line. Liver failures, they do very well actually compared to that. So surprisingly for liver failure, this is sad, males have been more. Maybe they are brought to hospital more, I don't know. So this is the data of ours, male is more, and the various milestones of our team was the first combined liver kidney in Asia, first swap liver transplant, first MSUD, first ABO. This is very interesting, I have to tell you. We do ABO incompatible. That means mother is B, baby is O, I can transplant. So the cost is more. We do an immune adsorption of plasmapheresis and remove all the antibodies. That costs 2.5 to 3 lakhs more. But you can do it. So we were the first one to have started that in India, both adults or peds. That was the first. Hepatopulmonary is when the child starts getting blue, saturation is getting low. So the only cure is a transplant, but it's very complicated in that. So these were 3 world records. The youngest domino. What is domino means? A patient ka liver, मैं किसी और को दे दूं. Patient ka liver जो खराब है. That happens only in MSUD because the enzyme is defect in the whole body. But you need a transplant, but you have the enzyme in the whole body. So even if it is less in the liver, it's okay. And the patient, even an 8% liver will make him normal. So that is a condition which is called domino. And I was the first in the world to do factor 7. Nobody had done how to do it. So I end up, before boring you all, it's the team who works, and I would like to acknowledge my mentors, my teachers, whether it was in AIMS and my Birmingham and UK, London, media, all of you all. Thank you so much for all the support you gave me. And the take-home messages are pediatric acute liver failure. The key maths is early recognition and prompt management. And main thing is cerebral edema. So it's liver chemistry does not, don't worry about jaundice, don't worry about that. It is that you need 2 messages that CRT is very useful, plasmapheresis is useful in that, broad spectrum antibiotics, culture, de-escalate, modify, consider all causes, G6PD and all, transfer and good care in transport. And thank you so much for that.
Thank you, ma'am. Thank you for in-depth talk on acute pulmonary hepatitis. And thank you for giving a positive message towards the pediatric liver transplant and all those figures.
Yes, another message I was just telling to someone is Dr. Yourself, Praful, and Dr. Bharat Shah from your institute, right? Vijay, Amitabh Bachchan, I told him. So what I wanted to say was, by the grace of God, things have changed in India. I can't believe it myself. But when I started the journey, it was only the rich who could pay. But now we have a lot of sponsors. And in 48 hours, I'm able to sometimes collect as high as 10 lakhs, 15 lakhs, 18 lakhs. There was a rickshaw puller who came from Surat or Ahmedabad, I can't recollect, a rickshaw puller. He got to know about me and he came and we arranged funds, but he went back home. He was very malnourished and he was upset that somebody told him कि तुम एक बारी उसको दिखाओ. And when I collected funds, but the child died before the transplant. It was a Muslim Ali somebody. So I just want to tell you all that believe in karma, believe in Krishna. I have all Krishna photographs around me in my room. That you do your karma, money will automatically come. And there are a lot of patients whom we don't charge and quit off our thing so that they benefit. And I've decided that I'm going to open up a parlor or a clothes salon to make money.
Thank you, ma'am.
Thank you.
Thank you very much, ma'am. So our next talk is spotters in pediatrics, and to deliver that talk, we have our well-known figure, Dr. Abhay Shah sir from Ahmedabad. He has been contributor and resource person over 2 those IAP modules and training programs, over 50 chapters and articles, editorial board, IAP textbooks of pediatrics, and he has been part of our all of the academic activity at SPECT. We welcome you, sir.
So, after that very high-fi talk on liver transplant and acute permanent liver failure, let us now try to come to our basics. And there is, can I do a slide? So? Very basic. And there is a one probe that I sees, hello, I sees what the mind knows. So most of the time, I'm always talking on the pediatric infectious diseases. But this time the organizer, especially Dr. Digan Sastry, was very particular that no, it is not spotters in PID, it is a spotters in pediatrics. So it will little change for me as well. It's not moving. It's not moving. Yeah. So, as we know that skin is a mirror of number of systemic infections, so diseases. And these diseases may be infections. It can be a non-infective pathology. We often know a different type of drug rash can be a clue to the underlying process. It can be endocrinal. It can be developmental disorders. Whereas vasculitis, non-infective inflammatory vasculitis, even collegial disorders and malignancy, and to add even primary immune deficiency. So all this can be reflected most of the time as a skin manifestation, or sometime they may give us a clue. If you identify that particular spot, probably you come to the diagnosis what we are dealing with. Of course, this talk will never undermine the value of the history and detailed examination, but just it's always an entertaining and thrilling experience to go with one of the spotters. Now, as far as newborn is concerned, we see a lot of this type of the newborn, especially in the summer months. And these are the rash which usually involve the face, trunk. Palms and soles are usually spared. There is a flea-bitten appearance, more common in a full-term baby than a low-birth weight baby. And usually there is a erythematous 2 to 3 millimeter macules. Some papules will be there, and the condition subsides of his bone in a week or so. It's a very common situation. We come, and that is erythema toxicum, and it doesn't require any treatment. Another common skin manifestation that we see in a normal child is because of the sweat retention, because of the obstruction of the sweat ducts, and if the superciliary layer of the duct is blocked, it causes a miliaria crystallina. Again, it does not require any treatment. If the deeper tissues, the deeper structures in the sweat ducts are affected, it causes some heat rash, that is miliaria rubra, and usually it appears on the covered portion of the skin. Again, it does not require any anti-allergic drug or any steroid cream or nothing. What is required is only reassurance and ask the parents to take the child away from the hot and humid environment. As against this, there is a white epithelial debris in the skin. It is a transient disorder in the neonate, present in 30 to 50% of neonate. Again, it is not require any treatment. And you can see this is a 2.8 kg child. These are the lesions, and this is nothing but a neonatal milia. So the miliaria and milia are the different things, and they are all physiological and does not require any treatment. Now, various cutaneous hemangiomas are there. You can see this is a Salmon patch, but most of the time, this hemangioma will appear on the 2nd to 5th week of the life. They progress as the age advances for few months, and after 2 to 3 years, they usually stop further progressing and they start regressing. Only thing, the hemangiomas, which interfere with day-to-day function, like our vision, deglutition, feeding, they needs to be treated, and the drug of choice here is a propranolol. So again, I will not go into detail of it, but out of this nevus simplex or the Salmon patch, the part 1 stain, and infant hemangioma, most of the time, they do not require any treatment, and as the age advances, they become fade up or may disappear. Another one is a cafeolate spot. When it's a very large cafeolate spot, when they are more than 5 or 6 in number, when they cross the midline, or when they are in the unused space, like in the armpit and groin, then they are cause of concern. Otherwise, these are also a benign patch, benign macule. But important that if this cafeolate spot has a zigzag border, then you have to entertain the possibility, yes, this child may have a McCune-Albright syndrome. And you know, friends, that you can see this zigzag border, and these are the cases who present with precoce puberty, cafeolate spots, and polyosteotic fibrous dysplasia. Now, if you only concentrate on this macule, cafeolate spot, they have the irregular zigzag border in MS, but if case of a neurofibromatosis, they have a smooth border. So here the border is zigzag, where here the border is smooth, and usually in case of neurofibromatosis, the cafeolate macule will cross the midline as well. Now, this is the child who has got the crying faces syndrome or the asymmetric crying faces, and this is mainly because of the congenital hyperplasia or aplasia of the depressor anguli oris muscle. The prognosis is usually good. As the baby matures, as the age advances, the other muscles will come in the action, and this deformity will disappear by age 5 or 6. But sometimes these are the cases who are associated with the other malformation, especially congenital heart disease is quite common in a child who has got the crying faces syndrome. In the morning, we have got a beautiful lecture on this. I may not go, but see the protruded tongue, periorbital edema, and good neonatal screening program, very effective program, would have prevent this calamity. I think it's a crime to have it. A diagnosis delayed, it diagnosis denied. So we won't like to see these cases like congenital hypothyroidism. Again, a child where there is ambiguous genitalia, of course, we do not use it. It's a disorder of the sexual dysgenesis. You can see the failure to thrive, marked dehydration, recurrent hypocalcemia, and this is the child who was suffering from congenital adrenal hyperplasia. You can see that 17-hydroxyprogesterone was quite high. Yes, this is day-to-day problem we see is a cradle cap. It's a multifactorial, but sometimes a fungal infection can be there. It is described as a type of seborrheic dermatitis. But number of things are there. As far as different, it can mimic a tinea capitis, but usually it is associated with the easy pluckability of the hair. As Dr. Ramesh Kumar told, it can be a part of atopic dermatitis, but here there is a presence of Pityriasis alba, and there is family history of atopy and allergy. And in case of impetigo, the crust will be honey-colored crust. So this is a case of cradle cap. And what is important here is that your treatment is removal of the crust, of course, with gentle hands, low point steroid like hydrocortisone, and sometimes, of course, antifungal local can also be helpful. As far as the omphalitis is concerned, it is a very common issue. But sometimes, is this omphalitis associated with cellulitis of the abdominal wall, you have to look for the systemic infection. And this is the child who was having a severe congenital neutropenia. having a persistent omphalitis. So just do not focus only on the umbilicus, but always look comprehensively at the child, how the child is growing, and whether the omphalitis has been taken care of with the help of proper treatment. If it is not responded, or the common omphalitis, which is not behaving like a omphalitis, you have to think of the primary immunodeficiency. This is again a case of BCG adenitis. We all know that masterly inactivity is the treatment. There is no need for the AKT, there is no need for the antibiotic, and if the suppuration is there, we have to have the needle aspiration. But some of the cases, you can see the exaggerated BCG response. There is a failure to thrive, there is rash, there is organomegaly and osteomyelitis. So this is a situation where a disseminated BCG is there, and this may be a probable candidate for SCID, that is severe combined immunodeficiency. It can be a cause of Mendelian susceptibility to mycobacterial tuberculosis, or it can be a child who has HIV. So BCG, when the child has got a BCG adenitis, again, always try to examine the child comprehensively and just do not focus on the local area. Again, a very common diaper dermatitis. The commonest one is a return dermatitis, increased wetness, elevated pH in the urine, fecal enzymes, and presence of microorganisms will cause it. But what is more important, I want to say that it mainly involves the convex surface of the inner thigh, lower abdomen and buttocks, and the intertrigus creases are always paired. And zinc oxide is a treatment. You can have a mild steroid if it is there. As against this, if it is a candida, you can see there are multiple satellite lesions. And the bilateral valve areas, and there is a satellite lesion, and the crease is more involved. And that is very classical as far as the candida is concerned. So this is again, you can see that the crease are affected, and you can see that the satellite lesion, this is very classical as well as candida. So no amount of antibiotic is going to work, only you have to use a anti-candida element, cream. Now, when there is a pus formation is there, it is a pustule. This is a classical bacterial infection, and here there is a definite role of the local or the systemic antibiotic. As far as again this is a candida, and again there is no role of the antibiotics. So that is about diaper dermatitis. We have a full lecture on atopic dermatitis. You can see this atopic dermatitis. It is the lesions in the childhood form are flexural in distribution, as contrast to infantile form where there is axillary. So in a young infant, usually the face and the external are affected. In grown-up children, usually the flexural distribution is quite common, and there is an itch, scratch, and itch cycle that we have to take care. So it is a moisturization, 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 followed by some steroid cream like Dazonide may be helpful. Again, a very important one is a Staphylococcus aureus syndrome. But what I want to say that in a newborn, the close diagnosis will be epidermolysis bullosa and aplasia cutis. There is a congenital defect in the skin, and there is localized absence of the dermis. How will you differentiate between this? That in case of the SS, mucosa is not involved. So this is very important. If the mucosa is involved, your diagnosis of SSS should be should not be there, and we should have to think for the other possibility. So this is again paraphimosis. There is an entrapment of the retracted foreskin behind the sulcus, and it can occur in an uncircumcised penis, and this results into a constricting ring leading to engorgement and edema of the gland. So it's a surgical emergency. So you need to know how to release this ring, otherwise you have to send it to a specialist. So this is very common, and we see quite often because the आया और जो मालिश वाले भाई आती है, they used to detect the skin, and this is the outcome that we may often get. Again, a red erythematous lesion with a clear-cut margin. You can demarcate the normal and the abnormal area, and the diagnosis is erysipelas. And it must be differentiated from two important things, that is cellulitis, and another thing that if this cellulitis, there is the infection of the subcutaneous layer, a red swollen area that feels hot and tender, and what is more important, I want to say that necrotizing phases. So it is very often difficult whether we are just dealing with the cellulitis or with our necrotizing fasciitis. In case of necrotizing fasciitis, if you do not thoroughly examine the child, the swelling obviously looks almost same. But if you feel some air in the swelling, if there is some patchy or spots over the indurated swollen area, and if the general condition of the child is not good, and if the pain is out of proportion to the degree of the swelling, you probably this cellulitis is going for the necrotizing fasciitis. So the pain out of proportion to the size of the swelling, and the unstable vitals, which is again out of proportion to the localized lesion, is a very characteristic that probably this child might go for the necrotizing fasciitis, and it's always a matter of few hours and a day or two, so it will not give much time, like our acute hepatic encephalopathy. So you start with local cellulitis with erythema, there is edema, shining skin, pain, marked redness, toxemia, and there is a frank necrosis, bullae containing hemorrhagic fluid, and there is a wood-like consistency. So that is about the necrotizing fasciitis. This is the child who has got the abdominal pain, joint pain, and a borderline hypertension, and you can see this purpuric spot, and the diagnosis was Hanox colon purpura. As far as this typical ring lesion is concerned, I think it is a book picture, and it's a tinea ringworm, and a KOH preparation would be helpful, but usually we don't go for it. We always go for the topical application of cotrimazole or terbinafine, and you will get a excellent response. But what I want to say that this, when it occurs in the scalp, there is an area of hair loss. So this hair loss is very, very typical of the tinea capitis. And here you need to have a systemic antifungal as well. This is the child who has got the fever, a sore throat, and you can see the rash, and you can see the tongue. The diagnosis is written on the face, and it's a scarlet fever, and you can see that the desquamation of the skin is also there, and this is a red strawberry. So diagnosis was scarlet fever. And if you see this, there's rash accentuated in the flexor. So you can see this. This is a Pastia's line. Rapid test shows that the most important part that circumoral area is always spared. So if you are thinking of a case of scarlet fever, if the circumoral area is involved, probably you have to again think of, yes, probably this may not be a case of scarlet fever. But very close similar to this is a non-infectious vasculitis. We almost look at, we'll have a strawberry tongue, we'll have a red eye, we have got non-responding to PCM, there is extreme irritability, and there is non-tender neuropathy. It looks like scarlet fever, but it's not a scarlet fever, and it's nothing but a Kawasaki disease. You can see that there is a lymphadenopathy is there, the cracking of the lip is there, tongue strawberry is there is non-prurulent conjunctivitis, a cracked lip here also see, and you can see this is a skin peeling, there is periangle, skin peeling is there. So it's a classical case of Kawasaki disease. Of course, it should fit all the 5 criteria. I am not going to detail, but this is the case of Kawasaki disease, and one of the most important, which is useful in about 20 to 30% cases, especially in case of incomplete Kawasaki disease, is that hyperreaction or the reactivation of the BCG scar. So this is also one of the important clues, especially when all the features are incomplete to suggest a diagnosis of Kawasaki disease. This type of the soft sign will be very, very useful to come to our conclusion whether the child should receive IVIG or not. Again, this is a post-COVID time. You can see again non-exudative conjunctivitis. You can have a rash. You can have the child very toxic, and you have a case of nothing but a misc. So we often call it a Kawasaki. So it's a Kawasaki that is post-COVID misc. And it's very important what is not Kawasaki disease. So when there is it's a non-infective inflammation. So anything which is non-infective should be considered. So if there is an exudative conjunctivitis, if there is an exudative pharyngitis, if there is discrete intraoral lesion, if there is bullous or vesicular rash, or if there is generalized lymphadenopathy, it is not a case of Kawasaki disease. So in a case of Kawasaki, only single lymph node, cervical, is affected. Bullous or vesicular rash are absent. We can all rash, but bullous rash and vesicles are not there. And you can see the discrete intraoral lesion and there is exudative pharyngitis and exudative conjunctivitis. These are not the features of Kawasaki disease. And there are certain situations where the discurrence of skin is there, that is scarlet fever, Kawasaki, streptococcal and staph toxic shock syndrome, scarlet skin syndrome, and ASA syndrome, and even tan. Again, a very beautiful target lesion. You can see vesicle at the center of this lesion. It can be erythema minor, the common infection will be HSV. It can be because of the mycoplasma pneumoniae, or it can be a widespread bully, which can be even a drug-induced like drug like phenytoin or even carbamazepine. If you look at the difference, in case of erythema multiforme, usually there are localized eruption of skin, and the mucosal involvement is very, very minimal. At the most, there may be involvement of mucocutaneous junction, but mucosa is usually not affected. As you can see, erythema multiforme major is a more severe, potentially life-threatening disorder, and one or more mucous members are affected, and up to 10% of the body surface area may be affected. And depending upon the area affected, if it is 10 to 30% involvement in body surface area, it is SJS, and if it is more than 30%, then we call it a TAN. Again, a very dreaded situation. You can see a meningococcemia, a petechial rash is there. There are confluent lesions are there, hemorrhagic rash. So meningococcal disease can present as pulmonary fulminans. It can present with meningococcal meningitis. It can have a meningococcemia, or it involves the adrenal gland with a severe shock, and we describe it as a Waterhouse-Fredrickson syndrome. Again, we have seen the COVID-2. So none is pathognomic. Any form of the rash can occur in COVID, but in the early part of when the COVID pandemic started, these type of lesions were started appearing in various our WhatsApp groups or even in journals on the nets also. But it is not a pathognomic of the COVID, but this was the one which was having a described as a COVID-2. Again, a mother was having a fever during the last part of the pregnancy, and the baby, there is browny nose pigmentation, and it is nothing but a neonatal chikungunya, and there is this post-inflammatory immune-mediated melanin metabolism has been disrupted, and that is why there is the pigmentation is taking place. So this is very, very classical as far as the chikungunya is concerned. Again, you can see something bullous and vesicular lesion in a child with a high fever. You can see some joint involvement is also there, and it is again a case of a chikungunya. So once you see this rash, probably you will never forget. It's a very classical. You can see a bullous vesicular lesion, which is also seen in the chikungunya. So in chikungunya, any form of the rash can appear, but out of this pigmentation, post-infective pigmentation, and this bullous vesicular rash are very, very characteristic. Again, we cannot forget dengue, so you can see this. This mainly taking place during the convalescent phase. I think we will not much. Yeah. Again, a irritable child, a growing child. You can see the wide epiphysis and a classical cases of the. You can see the cupping and fraying is there. It's a case of rickets, and the child responded to our vitamin D therapy. Fortunately, it was not a vitamin D resistant rickets. Again, another nutritional issue. A 7-year child, easy fatigability, hair loss, some mild icteric change was a hemoglobin 7.9. And you can see the acral pigmentation, and we did an MCV, which was 102, and it was turned out to be a case of megaloblastic anemia. A child who has a corticosteroid cough, multiple antibiotics, but what was missed in the general hospital X-ray, you see this foreign body. It was in the esophagus, and that was irritating trachea constantly, and this is a case of the foreign body ingested in the esophagus and presenting as a corticosteroid cough. Again, X-ray, 2 years, persistent cough cold, repeat antibiotic, X-ray, there is unilateral hyperlucent area. You can see the state border collapse, and when we did the bronchoscopy, there was a tuber dal that has come out. So it was again a foreign body aspiration in the trachea. A 2.5-year-old child, failure to thrive, hepatosplenomegaly, developmental delay, lymphadenopathy, spleen and liver were quite huge, and there was pancytopenia. And when we did a bone marrow, there was a foamy cytoplasm, and it turned out to be a case of Niemann-Pick disease. A 10-year boy, history of unprovoked seizure before 1 month, started an aptoin, presents with fever, generalized edema. There was intense erythematous rash, peeling, liver was there, and cervical glands was. So, child was given anticonvulsant, and there was hepatomegaly, there was lymphadenopathy, some rash was there, and if you count, there was leukocytosis, some eosinophil was so some high, SGPT was also high. So, diagnosis was DRESS. It was DRESS, this case, so it was DRESS. That is a drug-induced skin eruption, hypereosinophilia, atypical lymphocyte, systemic abnormality includes enlarged lymph node, hepatitis, interstitial nephropathy, and interstitial disease. In our case, we have got hepatitis, lymph node, as well as the rise WBC. So that is about the DRESS. So friends, this was the few journey of the spotters, and I want to summarize that one picture is worth 1,000 words. So our eye sees what the mind knows, and I thank the organizer for giving this opportunity, and also a learning lesson for me also, because I usually speak on the vaccine and infection, but I also took part of this also. So thank you, friends. Thank you very much.
Thank you, sir, for pictorial overview of pediatric skin disorder, and thank you for giving us extra 5 minutes. So now we are at the last session of our GUJPEDICON 2021, and I would like to welcome our own Dr. Ketan Shah, is a dynamic faculty, National Secretary of Rheumatology Chapter, contributed chapters to IAP textbooks. He has a special interest in rheumatology, breastfeeding, parent education, respiratory diseases, and he is a national trainer for several IAP programs. So now the last session of the event, that is PUO.
Good afternoon, everybody. Obviously, post-lunch, you need to have a spotters and some interesting cases. Some spotters in audience might be enjoying. Some spotters in the audience might be sleeping. Some spotters in the audience might be really waiting for a good lecture like what Dr. Abhay had taken. But definitely, being a last entry, the last person can also change the game, because you have a good team with you to make the whole GIPCon as a successful winner. And with me, we have an esteemed panelist. I would invite them to come on the stage. Dr. Mahesh Mohite, sir, my best friend, my motivator, and a great teacher, which all you have observed during DIP session in Corona. He has been the pillar of starting all DIAP activities. Sir, welcome, sir. He does not need any introduction. In the morning lecture, we could see that how he can save the doctor, how we can save ourselves. That's what he taught us. The another panelist is Dr. Kanak Bhai. Kanak Bhai, please come on the stage. The real scene of SPECT. Without him, this GIPCon would not have been possible. And the EB member of 2022, Dr. Kanak Bhai, welcome, sir. Dr. Kirit Sisodia, a very young, dynamic, and now the senior face in the AOPG. He will be the secretary of AOPG, and we call him as a computer wizard. Even if you have a minor trouble in your mobile or even on a laptop, he has an answer for everything. He's a computer wizard. He's a part of so many academic activities at SPECT, AOPG, and at national level also. And Dr. Monish, sir, please come on the stage. Sir will be the treasurer for the next year of AOPG, and he had been with me as an EB member of AOPG also. Sir has been always a good motivator for so many activities. Okay, so we'll start. Basically, it's a discussion on pyrexia of unknown origin. Some clues you will get it in the history, some in the examination, and some in the laboratory. And some you don't get any clue, even after 20 days of the fever. Few months back, we had a 2 patient who had a continuous fever and still going on for 6 to 7 months, and you are clueless for that. So many new things comes up during examination, repeated examination. This was a definition given by Beeson and Petersdorf in 1961, more than 101 degree fever for 3 weeks. This is for the adult. For pediatric, the definition is more than 1 week where you have no source to identify or to point your finger. Obviously, approach like all teaching session that the child is not very sick looking, but you can predict the sickness. You can omit the prediction of sickness. If you have a history of travel, emphasize that, exposure to animals, family history, and other relevant history. So we start with a case. Dr. Kirit sir, fever for 9 days, intermittent, morning, evening. There is a mild rigors. In between child is normal. Had 2 to 3 loose stools on day 2 or 3. Not very significant. Mother told कि sir 2-3 potty हुई थी. Non-toxic hepatomegaly, spleen just palpable. Rest of the examination is normal. I need to analyze this case. Kirit, Dr. Kirit.
Hello.
Just analyze the case. Not going to the diagnosis. What are your thought process?
Thank you, Ketan bhai. So, looking at the, what is the age of the child?
Child is around 8 to 9 years old.
Okay. So, 9-year-old child, fever is since 9 days. And as you are told, the patient is non-toxic. So, we might be intermittent morning and evening fever with mild rigor, and in between the child is normal. So, not any severe illness might be the thing. So it might be the infection, invading bacterial infection, or it might be the rickettsial disease, or any non-infectious causes could also be there. Hepatosplenomegaly are just palpable, so they are not much significant. So rest examinations are normal. So significant is he has high-grade fever, like intermittent, and it would be non-toxic child.
Sir, these are all Surat patient. So in Surat, rickettsia, there is no history of travel. So probably rickettsia will be in our last differential diagnosis. If it is from Mahesh sir's area, rickettsia would be probably in the top list. How would you investigate? CBC is normal. What other investigation you would go for?
So obviously 9 days fever, I would like to send a blood culture, CBC, CRP, urine routine micro, urine culture and X-ray chest. These are the common thing I would like to advise.
Immediately you would think of going for X-ray chest if you don't have any localization in the respiratory. CBC is normal. Other parameters?
Like what I told, CRP will
CRP is normal.
Okay. Blood culture and urine culture and urine routine.
Waiting for the reports.
Urine routine micro.
That is normal.
So X-ray chest.
Normal.
Okay. So most probably we might be dealing with the. Can you interpret the CBC, like elaborate CBC?
Yeah, total count is 5,400. Polymorph 60 to 65, lympho 30 to 35, eosinophil 2%, platelet normal range. ESR is 25 to 30.
Okay. So enteric fever could be.
What would be your first step to diagnose enteric? As you told, blood culture. What is the role of typhi dot and Vidal? Vidal will not discuss because everybody knows about Vidal. But typhi dot, would you recommend routinely?
Not commonly.
We
usually not recommend to the patient.
Sir, one liner from all other 3 panelists.
Rather, we'll go with our PG teaching days and put it our science PG clinic style, you know. So this child has come to you at 9 days. So many things are confounded here. He might have received antibiotics prior, which will change the whole scenario. Whether it's immunized, whatever is immunized will change the scenario. So what we go about is you rather try to get into first 4 or 5 days of fever pattern and you can make out something. So on day 9, without any localization, so far I have almost ruled out viruses except maybe EB virus.
Yes.
Rest of the viruses are nearly ruled out. I have ruled out most of the common bacterial infection in this child, pneumococcal, meningitis, H influenza, I ruled out. So non-localizing bacterial infections, which are they? Could be Cox, occasional UTI, bacterial endocarditis, brucellosis. The 4 non-localizing bacterial infections which may be left over. Maybe evolving connective tissue disorder which may come up like this, or a rare occasional leukemia may. I'm just keeping this option open. Now first 4 days of fever, how does it help me? I have a fever which is spiking right on day 1 and then starts subsiding and comes with kind of a multi-presentation. That's quite likely virus which I expect him to subside by day 4, day 5, which is not this. I may have a step ladder classical pattern. I myself had an enteric and I definitely remember day 1 I had just 99, 90, 100. Second day 101, third day I started. So I still believe that bacteria behaves the way they are supposed to. And then on 4th or 5th day when his virus is supposed to come down, this child is spiking, continues to spike, but don't get complicated. That's where it is not a classical bacterial, it's a slow growing subacute bacterial. How does a rheumatic will or this will be a classical quotidian which will continue with the same pattern in between touching the borderline baseline. So I'll go into first 4 days of fever in this child to find out where I log into. I've ruled out most of the viruses. I'm on to non-localized bacterial which I give you 4 common scenarios. So can this be enteric? Very well be. This can very well be enteric. On day 8, day 9, just about liver and spleen possible. Child is still not looking toxic, might have received some antibiotic. But a non-received antibiotic would have become slightly worse. So it's not classically, but though I'll keep that. Can this be tuberculosis? In an Indian scenario, yes, possible. Can it be malaria? You have not given me a classical pattern. But Surat, what kind of malaria is going on? If it is endemic, I'll keep that also in this mind here. So this is my way of going. Is it looking really toxic? Is not much. So leukemia and all, I'll keep lower on card. Rheumatic is possible because he hasn't shown me anything. But a liver and spleen already coming up on day 8, day 9, unless he had a pre-existing disease. One more question I want to ask here is, was he absolutely all right prior to this problem?
Yes, he was absolutely all
fine.
right.
Then on
He
day
had
9,
attended marriage
other
functions,
relevant history will be traveling history, exposure history, family history, contact history. Those things will definitely help in coming.
Kanak
I may ask about the races also.
There is no rashes. I just need to ask Kanak bhai, do you recommend typhoid dot test? My focus was on a typhoid dot and its utility in routine practice.
As such, routinely, frankly speaking, we clinicians many times or almost every time we may prescribe that typhoid dot, but actually according to books and according to now our experience after 30 years, even I also dare to directly go for the blood culture because it is the gold standard and it will give you the 2 things. The first thing is that the Salmonella species is easily growing. So we cannot compare other blood culture with the Salmonella. 70 to 80% yield is there if it is not previously antibiotic treated with the antibiotic. That is the one thing. Secondly, it will give you the susceptibility also. So many a times when you have not the respond after 5-7 days, then also if you have the sensitivity report, you may be damn sure that I may continue, everything is fine apart from the fever.
So usually blood culture remains a gold standard. Typhoid dot in my previous session also is usually what our IAP guideline says is OMP outer membrane protein study, which is not done here. In Surat, majority of the time it is a lipopolysaccharide typhoid dot test is done. So if you are following IAP guidelines, it may not be true because our methodology of doing typhoid dot is totally different. And these LPS has a bit high specificity and sensitivity, but we may not include in recommendation. So this is what it is. Yes, I agree, sir. Yeah. Sir, Vidal, I agree, but I think
but it
Monisha.
has the poor specificity and the poor sensitivity also.
Yeah. Dr. Mohite, sir, I'll take your call last for these. ID-PCR panel, we had a good discussion yesterday with Dr. Upendra, but Dr. Monisha, sir, at your center, would you recommend doing ID-PCR panel in these cases?
Still, it's 9 days.
Have you been doing, sir, IDPCR at your center?
No, sir, we are not using.
Not
sir.
doing.
We are not doing.
Anything would you like to tell about these IDPCR?
Yeah, it's always better to get for the IDPCL. It's 9 days, and we are expecting to be.
Yes.
We should get it done.
So we should get it done
for the IDPCL.
Dr. Mohite, sir. 2 lines about PCR infectious disease panel.
I believe before sending PCR, you should have some presumptive diagnosis in your pocket. Otherwise, this can be a disaster. It gives you some wake. So I have a respiratory infection defined. I want to know which organism I'm dealing with. I have a CNS infection defined. I want to know which organism. This is a PUO case. I don't know where is the focus, what kind of organism I'm looking for. And suddenly I do it and I get some Bartonella positive or some Serratia positive, and then I'll tell you a recent story where we had an ascitic child, PUO, 2 weeks, only positive as ascites with some intestinal intermittent edema. We sent culture and PCR, it grew E. coli and sensitive to culture, sensitive to some cotrimoxazole. Responded temporarily, but again recurred and ultimately turned out to be SLE. Our PG clinic attendant there. So you may get misguided with these investigations if you don't make a presumptive diagnosis. Do I see any definite organism, some kind of a localization in the child? If not, then I should be very careful sending PCR in this child. I may be misguided.
So this is very important message. 2 message we learned from this case. What is a diagnosis is not important, but do a blood culture. Typhoid may have a reserved value. Read about the typhoid done in your area. Vidal, definitely a rising titer, 2 to 3 fold rise. And IDPCR, before ordering, you should have a diagnosis in your mind, then only send it. Otherwise, you may end up with Serratia and difficult to answer to the parents what is Serratia.
Just one point. You are strongly suspecting enteric here. For enteric, PCR is not a good test at all. 1. Secondly, about a Vidal, 2 or 4-fold rise after 4 weeks. That's a standard guideline. Who is going to wait for 4 weeks to that?
We don't wait. So I agree. Let's go to the second case. 9 years old, fever without focus for 10 days, no other complaint. On examination, hepatosplenomegaly, typhoid I had mentioned is normal, Vidal 60-60, chest x-ray done normal, CBC, WBC 5000, polymorph 45, lympho 55, eosinophil 4, no culture which has been, no growth in blood culture which has been taken on 3rd or 4th day, ESR is 30. Connect by some guess about differential diagnosis.
Okay. Let me tell you frankly that Dr. Mohite's first elaborative answer that make my task very easy. Here also I will think, see, in PUO, if we are taking in general terms, if it is near to 7 days, then it is more sort of a little bit infection part for the cause of fever. And if you goes away from the 7 days, it may be little bit less infective part, and it may be inflammatory part or the non-inflammatory other things like neoplastic inflammation or other things, thyroidics or whatever drug induced, or there are many miscellaneous conditions. So here you make my answer to confuse me to 10 days. So it is not near to 7 days also,
Yes.
not at the 14 days also, but definitely here again I am going for the fever history. Okay, how that fever was. Because many times when somebody is telling, no, for 10 days, there may be 1 or 2 days of the afebrile phase, then it may be like a dengue also.
Sir, it is an intermittent fever and
Yeah.
child is not very toxic. There are no rigors.
That's what. Second thing is that many times the history of the antibiotics, because see, this is the eosinophil is 4 and the count is
Child
normal.
has received cefpodoxime for 5 days.
Yeah. So many times
After
what
blood
happened?
culture taken.
Many times what happened that it may be a case of enteric fever. It is treated by, and now eosinophil is raising to normal, so it may be responding. Even the fever initially it was high grade. It maybe comes to moderate, or sometimes child was ill looking. That relatively get better. So this is a on treatment enteric fever too. That is the one thing. So what I want to elaborate is that here the viral infection, as sir had told, EB is, except TB or the hepatitis virus, we may exclude the viral infection. About the bacteria, common bacterial infection, which localize early, or if not localize early, then also it is little bit less common. Like even enteric also, if they are not treated, and child is okay. Third thing, this may be evolving case of the inflammatory disorder also. And
so sir, he started joint pain on 13th day.
Yeah.
Now what is your thought process, sir?
That me gives a clue that it may be some non-usual infection with the chronicity, like brucellosis or even the...
Sir, could it be an inflammatory disease?
Yeah, that also I have to keep
but
in mind.
But ESR is 30. Usually in inflammatory disease, on
ESR
10th or
is,
14th day, ESR should go up to 90
that
to
even
100.
the history of the race is there, events and race with the fever. But then also you cannot exclude only from the ESR.
Sir.
So I have to keep in mind. Again, I have to ask for the history also, exposure to animal or the unpasteurized utilization of milk, because the joint is involved. So I have to think for brucellosis also. Even
what test you will order, sir, for brucellosis?
There are two main tests. One is the agglutation test, they routinely available, and second one is the
ELISA blood culture.
Yeah.
Blood culture.
Yeah.
Routinely
blood culture is a little bit less because it is a very we have seen in the typhoid, salmonella, it is a very easy growing organism. Brucellosis is little bit notorious like me. It will not easily convincible. So it may take 4 to 6 weeks.
Mohite sir, about
it only takes longer time, but as last talk of Camilla Rodriguez we heard, she said it's very easily culturable. The only thing is you have to culture it for at least 2 weeks.
2 weeks, sir.
It takes longer time.
Sir, which test you recommend in brucellosis? Blood culture is different thing.
But IgM.
ELISA, IgM.
Yes.
So when you get this type of picture, there were two important clues in the CBC report. ESR has not yet increased. It is 30. Eosinophil is 4%. Usually in enteric fever, we get eosinopenia or any bacterial. So bit less likely enteric. Collagen vascular not yet came up totally. There is a joint pain. Arthralgia is there. Arthritis is not there. Arthralgia with fever. SOJI usually does not come with a joint pain on initial 10-14 days. It is usually fever with rash and high ESR. ESR on 10-14th day of collagen vascular should be 90 to 100. So focusing on that, brucellosis would be the first diagnosis, culture as well as IgM ELISA test, which can give you clue. You may have a history of pasteurized and unpasteurized milk. Don't go into that story because where they had taken a milk, we don't know. So these are the common important clues in the diagnosis.
Just one point here.
Yes,
when
sir.
the joint pain comes on 13th or 14th day, it can be either way, either it's brucella or a connective tissue, where one need to differentiate whether this is arthralgia or arthritis. If it is arthritis, we are more into connective tissue. If it is arthralgia, we are more into brucellosis.
Very important clue sir has mentioned. Connect by just 2 lines about the treatment. How do you inform the audience what is the treatment of brucellosis? Just a short.
Here, as the drug of choice is the tetracycline, so I would divide the treatment into the age group of the two type of the patient, under 8 years and above 8 years. If it is above 8 years, again I have the two type of the treatment. One is the oral and one is the parenteral. If it is parenteral, doxycycline plus either Genta or streptomycin. If it is orally, then doxycycline plus rifampicin. Doxycycline dose is 2 to 4 milligram per kg. And the most important thing is the duration. Duration at least minimum 4 to 6 weeks. And if under 8 years, then we may use orally for sulfa plus rifampicin. And if it parenterally, then it is a doxy and streptogenta only. At that time, in crucial cases, we may use doxycycline under 8 years also. If it is involved bone or the heart, then we may use the 3 drugs together. One is the doxycycline, second is the streptogenta, and third rifampicin. But again, the duration is 4 to 6 weeks.
Sure. My friend Dr. Sanjay Gorupoda had taught all India about the brucellosis, and in all his presentation, he has been the mentor for brucellosis study. So, next question to Dr. Monish sir will be helped by Dr. Mahesh Mohite sir also. 9 years female, fever for 10 days, no other signs, symptoms, has a cervical lymphadenopathy. The descriptor of lymph node is non-matted, soft, non-tender, more than 1.5 to 2 centimeter. Rest examination is NAD. CBC is normal, like polymorph 54. and lympho around 30 to 40, ESR is 90, total count is 5,000, 6,000 around, and Monto test done is 10 mm. Monish sir, primary interpretation of these, where is the focus and what are your thought process?
It's a 9-year-old female child with the fever for the 10 days, and it has a localized sign of cervical lymphadenitis. It's a non-tender, non-matted and soft it is, and the ESR has also increased. And Mentus test was the if it is BCG given child or not given child. That's important.
BCG given, sir.
Then it's we have tend to we consider as a positive for this child. So it's a localized, like we can think about of the cervical tuberculosis, lymphadenitis.
Should I start with AKT, sir, on this patient?
We should give a primary, like so first antibiotic, and we should go for the FNSC.
We had given 10 days of antibiotic.
We can give the fine needle aspirate FNSC, and we should confirm the diagnosis, and we should get for the one chest X-ray either any the signs of the systemic
Good point, sir. X-ray chest is normal. Mohite, sir, would you ready? I have two questions.
Lymph node unilateral, bilateral in this child?
Unilateral, sir.
Multiple, single?
I'll show you the photograph.
Yeah, which group? That all matters.
Yeah, this,
jugular digastric or posterior triangle?
Posterior triangle.
They're posterior triangle? Posterior triangle could be non-specific. Jugular digastric means a lot to me.
It has extended to the anterior part.
At the angle, then it could be JD. Yeah, please. So it's a JD group predominantly. Yes. So that means a pharyngeal infection very likely. Some localized pharyngeal infection. On unilateral, pharyngeal with 10 day. Go back to the previous history, please. And child is not toxic.
Non-toxic.
And it's not tender. Now unilateral solitary lymph node progressing in a near adolescence girl. 2-3 possibilities. If it is toxic, you should consider possibility of Kawasaki, which may come awareness. Second, it could be EB virus if I have pharyngeal infection. Third, it can be some rare one like you are showing me, ESR very high, non-localized, Kikuji, Kojumato and all those things we talk about. So those kind of thinking line I'll have. And obviously, I suppose there is no other positive finding in the body anywhere. There is no spleen, no liver, nothing, then EB will come lower on card. Yes. Then I will come with some infective possibility. I'll see the infect, but there is no throat pain and non-tender, not acute bacterial. I may keep EB virus as one possibility. Second, Kikuji can come. A rare Kawasaki can behave like this with unilateral.
Very well narrated. And I'll just contribute to your suggestion, sir. There is no hepatomegaly, no splenomegaly, no rash, no posterior pharyngeal wall congestion, no exudate in the throat. And child never had a pain in the throat. So reasonably it ruled out EBV virus. SGPT is also normal.
History of antibiotics?
Yes, sir.
History of antibiotics?
Child has received amoxicillin for 5 to 7 days and there is no rash. So these has reasonably ruled out EBV virus. Now the remaining two possibilities, either a tuberculosis or could be inflammatory disease. Sir, with Monto 10, do you agree to start anti-tuberculosis treatment?
At 9 years, Monto I don't do, honestly.
So just a very important message to pass on. 9 years Monto, not important. Strength is important, 2TU is important, and that is also not for 9 years. So Monto reading we can ignore. ESR is 90, not very tender lymphadenopathy, not very toxic child. So something is cooking inside the lymph node. And the final answer would be obviously lymph node biopsy. And the lymph node biopsy we would suggest histopathology, staining, CBNet and MGIT should be done together. And histopathology has proved Kikuchi lymphadenitis. So Kikuchi is once again a very common entity. It's a histopathological diagnosis. It is a part of an inflammatory disorder. You may have a ANA positivity in these. You need a steroid course, 10, 14, 15 days, then you taper it out. These children may have a relapse. I had 5-6 patients in last 5 years. One patient had a relapse of Kikuchi, lymph node biopsy proved. These female children may over years may become SLE in future. So these are autoinflammatory disorder. Monish sir, once again to you. 14 years male, fever for 10 days, low grade, poor appetite. No other finding, investigation, CBC, everything is normal, SGPT is normal, ESR is 90.
Again, it's a 14 years child with the low grade fever and poor appetite. Investigation, the CBC is normal and ESR is 90, ESR on the higher side. And first I would like to know that any weight loss or anything in this child. What was the weight and what was the because
There is
of
a
the
weight loss.
poor appetite? Yeah.
Objective weight loss of 2 kg in last 1 month.
Yeah. And there is a pattern of the fever.
Low grade, sir. Usually in the afternoon, evening, 9900.
Evening rise of the temperature or any what? And if we investigate, like in the CBC is normal and ESR on the higher side, it's some chronic infection or we are dealing with the. I would like to go for a first of the chest X-ray.
Yeah. Okay. So a very simple case, but needs an evaluation. ESR is high and clinical history and a very minimal pleural effusion can be missed on the examination. So role of X-ray chest in all PO has been emphasized in this case. Rayansh, 4 months male admitted for poor activity, not very active, irritable, fever for 6 to 7 days, low grade on breastfeeding, mild coryza, no severe coughing. Physical examination irritable, anterior fontanelle is normal, CBC normal, ESR 40, CRP 40, CSF has been done, which is not very significant. Dr. Kirit, sir.
Can we roll back to previous slide?
Yeah, sure.
So this is a 4-month-old child which is having an poor activity, not very active and irritable. So CNS involvement might be that either it's an infective or it is due to systemic response, the patient having an irritable. Fever running since 6 to 7 days. Though it is a mild low-grade fever, but we should consider very seriously as the age of the child is very low and with associated mild coryza. So next. So either it could be an invasive bacterial infection. Sometimes count may be normal in this smaller age group of child, which ESR is high and CRP is high. So infection or any inflammation which is going rise in the body. So I would like to advise some physical examination detail, as well as I would like to send the blood culture and urine culture. High possibility of systemic bacterial infection or urinary tract infection would be the first possibility.
So a very nice thought process has been generated in the treating pediatrician that this could be some serious bacterial infection without reflecting into the CBC, or could be some inflammatory response. And rightly he told that he need some picture. And looking to the picture on examination, you will have some clue. Yes, Dr. Mohite, 1 minute please.
Just one or two comments. He's just 4 months old boy.
Yes.
Any bacterial infection, he has to localize within first 3 to 5 days. And when I say localization, if it is CNS infection, he has to have seizure, encephalopathy. Pneumonia, he has to come with respiratory distress or whatever. This child has not localized till 7th day. If you see the up-to-date latest article, second most common cause of fever without focus is Kawasaki. To that extent, they are aggressive. Okay, so this child has been irritable without classical encephalopathy. This child is febrile without any further progression. 7th day, he has not localized. You have to be very aggressive in investigating for Kawasaki in this child. Obviously, you will be doing his CBC, urine, CRP, and a blood culture, but you will be very prompt in doing his echo as well. If he shows very high inflammatory parameters without localization with all these tests negative, you aggressively go and treat. Yeah, one more mistake commonly done here, you get pyuria, sterile pyuria, 10, 15, 20% cells. You do a CSF, you may get few cells there. Actually, these are all non-infective inflammatory markers. Get this kind of a picture, and by this time, all of us have become champion and seeing the face and recognizing Kawasaki. So, I mean, Kawasaki is such disease that we are really good at it just by recognizing the face.
So, yes. I would like to add here, as the generally patient directly comes to us at the time of 6 or 7 day. Before that, I think he has gone generally majority of time to the general practitioner. They are all the time treated with the antibiotic. So they may sometime mask or they may give rise to like clinical picture here it is classical. But when you have not seen the clinical picture, it looks to be sometime primary treated with previous antibiotic may give rise, and fever low grade, which is against the majority of time against the diagnosis of Kawasaki.
Kirit sir, COVID antibody is positive in this patient. How would you think of?
Obviously, it looks to be an MISC.
Okay. Mohite sir,
I have some objection.
now
I have objection to
short,
that.
very short description of difference between MISC and KD.
I will definitely.
30
Just give me
seconds,
half a minute for this. Dr. Jacob John said 90% of the Indian population is either vaccinated or infected. So COVID antibody positive is no more diagnostic of MISC today. So when I say MISC, you have to fulfill those 4 criteria, multi-system and all. Now difference, coming to your question directly. MIC is a child disease in the later age group. KD is a disease in the early age group most of the times. Though we saw MISN, not MIC in the infantile age group, we saw MISN. The vertically transmitted neonatological problem, which would be up to 3 to 4 months. 5 and 6 months baby thinks twice before labeling as MIC. It will be more KD than not. Cardiac involvement, classical coronary more common with KD than MIC. Prognosis of KD is bad, MIC is good. MIC is not left with any sequelae so far documented, no sequelae rate versus KD almost 25% of them will be coronary deficiency in later age group, less than 6 months, 40% coronary involvement. So that's kind of a difference, at least primarily.
I think the multi-organ involvement is more common with the MISC.
Absolutely.
And abdominal sign and symptoms are also more common with the MISC rather than the Kawasaki. And the third more thing, in cardiac evaluation also, usually KD with the only coronary, while in the left ejection systole and the shock-like pictures are more common with the MISC.
So these are the points which we can differentiate. Dr. Chitrang will take your question afterwards. I can finish up in the time. So these are the important difference for MISC and KD. KD is a very bad disease. Need to have a follow-up. If coronaries are normal, then also you repeat the test, echo after 10 to 15 days and look for the ectasia which has been converted into aneurysm. And these are important points, and these are the 2 pictures, 2 more new findings which came up in this patient, BCG reactivation and a very severe perianal excoriation. Dr. Monish sir, looking to this picture, child has a rash, excoriation, dry lips and skin lesions, excoriation. These findings are on 3rd or 4th day. Can these be Kawasaki disease? Excoriation, dry lips and the rash.
Yeah, it can be.
It can be?
It can be, yeah.
Yes. So, Dr. Kirit.
Last Abhay Bhai's lecture has shown the spotters. So, it could be...
Please continue. Kirit Bhai.
But see, the exfoliation is usually in Kawasaki in the 2nd to 3rd week. If it is 3rd or 4th day, then we have more in favor of the scarlet fever rather than the Kawasaki.
So these are scarlet fever related pictures. 2 more clues are in the form of periorbital edema, which is usually not seen in Kawasaki on 2nd, 3rd or 4th day. This is very common finding on scarlet fever. So
and one more thing, Ketan, in
yes,
Kawasaki, strawberry tongue diarrhea itself, while in the scarlet fever initially it was white coated and that squared up and then become the red inflamed.
So these are differential points of Kawasaki and MISC. In MISC you may have a prolonged fever. We are not yet much aware about the MISC, but WHO has released MISC guidelines last week only. We all can go through that. We had 2 or 3 patients who have still running high fever and nobody knows the reason. Rakesh, 10 years, PO for 10 days, had past history of epilepsy he's on anti-epileptic drug for 3 months, no focus, coated tongue, CBC 4500, polymorph 65, lympho 25, eosinophil 7. Vidal is borderline on 6th day, done by slide test. Blood culture is negative. Dr. Kirit, analysis of this case and then followed by Dr. Mohit sir.
So same here. So how is the fever pattern of the child?
Initially to start with a low grade, now it has increased and child is not looking good.
Okay.
Bit sick looking, not very ICU like patient, but with fever he is not okay.
Previously treated with the antibiotic?
Yes. 3-4 days he had received antibiotic.
Yearly fever which is increasing in pattern with past history of epilepsy and patient is taking AED. So that would be the positive history. Coated tongue may not be significant as the count suggests eosinophil count has raised. In spite blood culture is negative. So looks to be some infection might be going on. CRP, what is the CRP of the patient?
Not very high, 20-30.
So mostly, if it would be Vidal, then eosinophil count would be low. So it doesn't fit into the Vidal culture like enteric fever
like
also. Okay. And it looks to be like some AED related complication would be there.
Good. Mohite sir.
Any rashes?
Yes sir. Till 10th day there is no rash. But
any liver related affection?
No. No, sir. 10 minutes left. Chest X-ray was normal. USG was normal. No, we'll repeat it. Let the power to come.
Audible?
Sir.
Audible.
Yes.
So basically here, Achha. See, given this case on 10th day, there is no clinical localization. Available reports have reasonably ruled out enteric. I'm saying reasonable. You have seen occasional enteric with everything negative turning out to be enteric. But blood culture negative, Vidals are back normal. Eosinophil on the higher side. But that 7% doesn't become sacrosanct because it doesn't define the absolute eosinophilia. Is 4,000 count with 7%, it's just 280 eosinophil, which is normal. So as on today, if there is no rash at this point of time, nothing, I'll keep that AED in mind. That can give rise to, because once you said AED in a block later, it becomes, and that too started within 3 months. That's very important. Somebody getting for 2 years and 1 year, because all those complications would start within first 3 months. Usually after that, if somebody is not had it, then he will never have it. I'll keep that possibility. But as on today, just now, I don't have a definite diagnosis.
So these are the important analysis point that only for 3 months child is on AED and till 10 days there is no conclusion, but reasonably bacterial infection has been ruled out. And on 12th day, child has developed the rash on the palm. TV चालू करो, TV चालू करो.
Yeah, we can see the rash.
Yeah. So on 12th day, child has a rash. Repeat CBC is still normal, but SGPT has increased and it has become 235. Vidal is same. So almost we have reached to the diagnosis.
Multisystem inflammatory disorder kind of secondary to AED. So it's kind of equivalent. It's immunological reaction, drug related eosinophilic.
Yes. So it's a drug related
eosinophilic.
So likely to be a DRAS syndrome, which Dr. Abhay Bhai had also shown us the picture. Monish Bhai, 14 days fever, 9 to 10 years old child. In between child was normal. Normal means only 1 day was without fever and no other symptoms. On examination, child has a hepatosplenomegaly. Recent history of travel to Maharashtra. CBC is 15,000, ESR is 100, CRP is 45, neutrophil are around 50 to 60, lympho are 20 to 30, eosinophil 5 to 6%, and child has received antibiotic. Monish Bhai?
It's a 14 days PO with the 14 days of the fever, and there is a positive history of hepatosplenomegaly. And there is a travel history of the Maharashtra. In the CBC also the count is high, ESR is also high, and CRP is 45 after giving up the antibiotic also. So in the looking at the traveling history and the hepatosplenomegaly, we are dealing with some systemic involvement. Like travel.
Sir, could it be an infective pathology?
Infective pathology.
Infective pathology.
Infective pathology.
Which organism you think of?
In the Maharashtra, like epidemic, we can think about the rickettsial or rickettsial infection.
Dr. Mohite sir, on 14th day, does rickettsia will have fever and other serious involvement?
Usually not. He will see rickettsial classical. If you take the rash would, the scrub classical that we say, rash would come on 4th or 5th day. You will be lucky to have a share in 40-50% patients, 40% patients.
I would like to go to the previous slide. Some more details about the fever pattern. Is it rising further? Is it at the same level? What kind of pattern you have?
It's an intermittent fever, and when the fever goes, the spike is around 102 to 103.
Very high grade fever?
Yes, sir. 100 to 103, and in between child is normal, and there is a hepatosplenomegaly. So on 14th day, sir, in your area, rickettsia would come with this picture?
We do occasionally see a child without a rash, but generally the scrub is very common where rash is almost mandated. For that matter, we diagnose rickettsia by seeing the vasculitic rash predominantly.
Okay. And do you agree with these reports which favors rickettsia? 15,000?
You can get, but usually the associated thing is hyponatremia.
Yeah.
You know,
So
counts
on
are slightly
14th day,
lower
if
side.
it is rickettsia, it would be a bit sick looking child.
Absolutely.
And with have multi-organ involvement, some organ involvement
I agree
would
with
be
you.
there.
I agree with
Kanak bhai, would you like to analyze this? What are the important highlights in the reports and the history?
Before that, for rickets, normally in general terms, what triad of the rickets, fever, hepatosplenomegaly, rash, that should be usually. Without rash, maybe rickets, if there is a positive endemic history.
Agree.
Yeah. Now here the count is high. Normally what we pediatrician or even in the family physician count is high, that is favoring Bacterial. High count, it only suggests inflammatory pathology, either infective, non-infective. So here 14 days of fever is there and the count is high and ESR is 100, then definitely I will look for the systemic inflammatory disorder also.
Rickettsia negative, Brucella negative, Vidal negative. Ferritin is 700 and LDH somebody has done, so it is 1000. So now your point of systemic inflammatory disorder will come into the picture. Mohite sir,
if these numbers are to be taken to define HLH or something, you need to have bicytopenia, tricytopenia. Yes. Hepatosplenomegaly is there, but that's usually a common feature that we see. Invariably, it is secondary to some primary infection which is not defined in this child, though occasional connective tissue may develop into HLH or macrophage activation. So I don't think the picture is still very clear here. Yes. LDH is on borderline high. That is because of any kind of wear and tear in the body. Ferritin is not sacrosanct. For a HLS to call it should be more than 10,000 definitely. 700 is just about borderline, though we have seen normal ferritin with the macrophage activation. So its relevance comes when it is more than 5,000. So still the picture is not very clear. You don't have a localization. So you have ruled out virals. You have ruled out acute bacterials. You may be a non-localizing bacterial or you may be on connective tissue. That's where I stand. I'll wait for any further evaluation. During fever, I look for any rashes or something, evanescent rashes or something. Those kind of things will.
So during fever, somebody noticed a rash also, and after 5 days, the ESR has increased, CRP has increased, and ferritin and LDH has shot up. So this is likely to be SOJIA going into probably macrophage activation syndrome. SOJIA, when you are diagnosing, keep a watch. Many number of patients would go for macrophage activation very fast in SOJIA. Kirtan is having a PUO for 14 days, not very good, not very toxic, no fixed pattern of fever. At any moment fever comes and goes down. He has sign symptoms, nothing significant, but in the hospital some resident doctor noticed that basal pulse was 120 to 140, respiratory rate was 30, liver spleen not palpable, CBC 15,000, ESR 50, CRP 45, and blood culture grew Streptococcus viridans. Mohite sir, significance of these laboratory and clinical finding.
Now he hardly has any clinical finding. Not very good. You're saying this is toxic. That's all. No. What is the age of the child?
6-7 years old, sir.
Was he having any pre-existing disease?
No.
Any cardiac disease? Because when you show me streptoviridans, only condition where I see is a small VSD, which is missed out, totally overlooked.
Exactly. Got the answer.
Yeah.
Sir, your clue is, you're pointing out to is perfectly right. Streptococcus viridans, when you get it, and you have I had given one clue which was there, basal pulse was 120 to 140. So child has an endocarditis. When you get Streptococcus viridans, always think of endocarditis. It could be a normal heart or could be an abnormal heart. Even a minor VSD might have missed, and Mohite sir has very rightly picked up, sir. So a very meticulous and particular answer.
Ketan,
Yes.
if it is find out in the throat culture or genitourinary, then it has
We
least
can ignore
significance.
it, but
If
it's
it is
a
in
blood
blood,
culture.
then definitely
And
we
in
have to
PU.
rule out endocarditis.
2 to 3 minutes, Parang bhai. 7 years female Vaishali, PU of 14 days, no other associated RS, CNS or elementary system finding, non-musculoskeletal pain. Kanak bhai, you can take up this. Pain at long bones, CBC 4500, platelet 90,000, HB 8, liver
Yeah.
spleen just palpable, and in the era of dengue, patient has presented to you.
Yeah, but at the 7 years, 14 days of fever, and if there are the two-line enrollment, not only the platelets, even the hemoglobin also, and even I may say the WBC count is also to lower side, and with the musculoskeletal pain, definitely my internal level will raise for the hematologic malignancy.
So whatever the era of dengue comes, 14 days dengue fever does not last. If it lasts, it could be converted into some complication. And when you have a dengue, hemoglobin should not significantly drop unless you have an HLH-like complication. Child has a non-specific musculoskeletal pain. Platelet were 90,000 even on 14th day with hepatosplenomegaly. Child needs further evaluation, and bone marrow would be the final answer. And she had leukemia. So friends, any PUO, pyrexia of unknown origin, the role of malignancy, the diagnosis of malignancy in PUO is less than 20%, but still a very high number, and you need to be cautious about it. Drug fever needs consideration. You can't label drug fever on day 1 or 2, or you can't ignore it also. But you need to have a eosinophilia, a rash, maybe hepatosplenomegaly, borderline elevated SGPT. That will give you a clue. Inflammatory markers, a very high ESR, more than 70 to 80, should raise your eyebrow for possibility of inflammatory disorder rather than infective. Infective would have a ESR in the range of 40-50, CRP borderline, and a high ESR, always think of SOJIA. And travel history is very important, like going to the Maharashtra, Uttarakhand area, where there are certain encephalitis and rickettsial disease are also there. So my sincere thanks to all 4 panelists, Mohite sir, Kanak sir,
Thank you very
Kirit
much.
bhai and Monish sir, for a very wonderful input. I hope you all have enjoyed the last session with all main players of the team. Thank you so much.
Ketan, at the outset, I express my sincere thanks to scientific committee to give us the chance to sit here. Myself, Monish, and the Kirit. And
You're
Mohit sir
welcome. Thank you, Ketan, for an excellent session. Ketan, please lead your team to the presentation area for the presentation. I request Dr. Rakesh Desai and Dr. Bankim Jariwala to please do the honors.
I would request all the delegates to please take their seats. We'll be continuing our validity function just now. All the delegates who are leaving the hall, we are requested to stay back. The validity function will be followed by SGM. I request all the delegates to take their seats.
uncertainty for us, for all of us. We are not sure whether we'll be in a position to finish it off or it as physically. But ultimately, with the grace of God and we could achieve our dream. So this is all because of hard teamwork of all of us. And I'm really blessed to have you all as my teammates. I would like to express my gratitude, but in few words it would be difficult, but still I will try for it. First, our patron, our respected Dr. Nirmal Bhai. Nirmal Bhai is our real Bhai. You cannot think of doing any event in Surat without his guidance and his motivation. Whenever you are in stress, you just call him. His caller tune, "Main hu na," is just kafi to relieve your tension. And you again get reboosted. Thank you, Nirmal Bhai, for being our mentor and guide in everything. Please, memento, please. Hello. તૈયાર જ રાખજો ને બધાના. Our second patron, Dr. Digant Bhai, our past national president. His guidance is always there in each and every step, and he is always come out with positive answer. He's a one-man institute. He's a great link, and he was a great help for liaison between UNICEF and government. And we could achieve many more things with his help during last so many months. The concept, the project Angan was his brainchild that now we are in a position to implement in our next year as my president's action plan. I'm really thankful to him. Digan Bhai, along with other Dr. Ketan Bhai, Ketan Barorwa, Swati, and all others, we could have great marathon consulting meet of Project Angan, as well as the second workshop, Central IIB ECD workshop. Yeah, we are thankful to him for having our ECD workshop at our Surat city. Thank you, Digan. હવે યાર 5 મિનિટ તો રાહ જુઓ આજે એટલે કમિટી વાઇઝ છે I am going to our advisors Dr. Vijay Bhai, Dr. Bankim Bhai and Dr. Kamlesh. Dr. Vijay Bhai, we are really thankful to you for your guidance and for your great service as our judge for paper and poster presentation. Thank you, Vijay Bhai. I will announce that Chetan Bhai and Kanak Bhai will give the memento. They do that also. Our another advisor, Dr. Bankim Bhai, he is a friend, philosopher and guide to me. He will always come out with some such, whenever you are doing something wrong, he will always point it out. And unless he is corrected, he won't be at rest. Thank you, Bankim Bhai. Yeah. Kamlesh did Herculean task of coming out with souvenir in time. And without him, I think it was not possible. It's okay. Our organizing chairpersons, Dr. Chetan Bhai and Dr. Kanak, they are my left and right hands. And without them, I would not have thought of doing this conference. In spite of their busy in central IP elections, they allotted a lot of time for conference also and carried out all the things that we pre-decided. And their vast experience as past president also helped me a lot in carrying out so many activities. Actually, in fact, when I was calling from US, last year I was in US and we started planning from there only. When I was calling with Chetan Bhai, Bankim Bhai, Kanak, Digant or Hitesh, we were discussing many things. At the end, they were telling, Rakesh, you just stay there. You come on the day of conference, everything will be ready. And I think that would have been possible with them only. Thank you all. Thank you to all. I am thankful to our coach, organizing chairpersons, Dr. Hitesh and Dr. Vimal. Hitesh did a marvelous job as finance committee member also, and he motivated so many financial companies. And we are really thankful to him. Vimal, we know potentials of our Vimal Bhai. He is always a silent worker, and he always is a great help to our association. Vimal is here? Vimal is not there. નીલેશ હિતેશ સાથે વાત કરીએ તો છેલ્લી એક જ વાક્ય, રાકેશભાઈ ટેન્શન નહીં કરો, બધું થઈ જશે. એટલે મૂકી દેવાનો બસ. Our organizing secretaries, Dr. Manish, Prashant, Fagun and Darshan, they all are 4 pillars of the edifice on which GUJPEDICON rested. For during last so many months, I have talked a little more than my wife with all the secretaries. They did wonderful job. They have great liaison with other committees also. They have very great, tremendous capacity to work without any rest. I still wonder how they squeeze their time for doing all these activities. They are our powerhouse, and we are really thankful to them. Manish, Prashant, Fagun. And Fagun. All these are our, Prashant has a great potential of being our, Prashant has great potential of our national leader also, that we have seen. Neerav Bhai. Dr. Neerav, our treasurer. I would not have thought of doing the conference without Neerav as our treasurer. His perfect skill in accounting and auditing is the key of success to the conference. He will, within no time, he will come out with a positive balance sheet that will have smile on our face. That will give a smile on our face. Thank you, Neerav. He will come out with balance sheet, and you will have something. You will also get some. Our joint secretary, Dr. Kalpesh Dhankar is our joint secretary. He also did marvelous job as chairperson of paper and poster presentation department. His skill is amazing, and he was doing this. This was a tedious job. He carried out it very skillfully. All PGs were very happy with his arrangement. Thank you, Kalpesh Bhai. Please come on the dais. Kalpesh Bhai. Dr. Kirish Sisodia, our president, and our treasurer, president, OC member, everything. He's a omnipotent personality. He's my secretary also of Gujarat State. I congratulate him. Kirit is a troubleshooter. You say anything, and he will come out with the answer. Thank you, Kirit. Ankit, our Patient Secretary of your SPECT has also did marvelous job. We are seeing his potential for last 2 years. He did an excellent job in audiovisual department also. Thank you, Ankit. Good scientific program is always in the heart of success of any conference. And for that we achieved with Dr. Parangbai, Dr. Diganbhai, and Dr. Chetanbhai. We are really thankful to them. All delegates also have appreciated the scientific program that they prepared. Thank you to all scientific committee persons. Parangbai, please, Digan. કનકભાઈ ચેતનભાઈને તમે આપો. I request Nimalbhai to I request Nirmalbhai to give memento. Nirmalbhai, please. Nirmalbhai બધાને આપશે. આવો. The exuberance of the conference that we realized during last 2 days is because of Finance Committee, especially Dr. Hitesh, Darshan, Ketan, Ravi, Rajendra Prajapati and Renuben. Hitesh, Darshan and Ketan took the lead and they convinced so many finance companies and we could have a great show during these days. Thank you all Finance Committee members. Please. Those who are there in the audience, please come on the dais. Finance Committee, please. Yesterday's grand cultural show, Aao Jhume Gaye, was possible because of Dr. Salim, Samir, Keuri and Swati. Dr. Salim took lot of pain in carried out all the things. Actually, this time cultural program thing was ready before scientific program was ready. And Salim did marvelous job. His purpose of involving all the SPECT members is definitely served yesterday. We had lot of fun yesterday. Thank you, Salim. Thank you, and Salim and all team. Please come on the dais. I am thankful to Praful and Dr. Ankit for perfectly managing audiovisual department without any hassle. The hassle that we had in between was because of technical error, not because of their fault. The iconic success of both the workshops is the outcome of hard work of Dr. Ketan Shah, Dr. Ketan Baradwa, Santosh Yadav, and Hemanstu Tadvi. For the first time, we had not to push any OC members to sit in the workshop. And within 48 hours of opening, both the workshops were full. And people enjoyed a lot. All delegates were also happy. They said that this is for the first time that we attended radio workshop in any conference. And they also asked us to repeat it in next year also. Thank you to all the workshop committee members. Please come on the dais. Dr. Premal, along with Dr. Sumit, Sailesh and Kalpesh Bhai, They performed a very difficult job of registration, accommodation. Premal, heads off to you and your team. Premal for the first time, Premal was bit tired, but I think that was some deficiency on our part. We feel sorry for that, Premal, but next time we definitely. Sumit also did marvelous job without uttering a word with Premal. And it is really difficult to stay on the registered counter for so many hours. No, he didn't complain. To erect exhibition stalls of various sizes at various places was a real difficult job. And I am thankful to Dr. Rajendra Verma with his team of Pradeep Saran, Akshat, Dinesh and Kishore. They accompanied them, they carried out Herculean and tedious job very effectively. They dealt with all the trade persons as well as vendors very nicely and coolly. We really thankful to this trade exhibition committee. Nirmal Bhai, please. Nirmal, I request Nirmal Bhai to give memento to the committee. I was a bit reluctant. To publish souvenir in the beginning, but Kanak insisted that we should come out of it, and Kamlesh supported him. And with Kanak, Kamlesh, Fagun, Ankit, and Arun, they managed very well. Without Kamlesh and Kanak, I think this would not have been possible. We would not have, the nice souvenir is because of them only. We thank you all. We thank you them. If Fagun, Ankit, all are okay. All sessions with perfect timing were very well managed, taken care of by Parang Bhai and his team, and Parang Bhai and four beautiful young ladies and dynamic ladies, Dr. Susma, Vishaka, Nirali and Aswini. The whole team was a perfect match. Parang Bhai's wisdom and expertise and meticulousness and brain and beauty rare combination of brain and beauty of all these ladies. They did marvelous job and carried the work excellently. Nirali, please come forward for. Digan Bhai, please. છોકરીઓને બી કરી શકાય. હા એ બરાબર છે. हाँ कितने पास कितने दूर मनीष the sumptuous food that we realized during these 3 days was because of Dr. Neerav, Bankim Bhai, Ankit and Snehal. I was sure that when Ankit was in the team, I was sure that we will have definitely a nutritious and healthy food. We are thankful to our food committee. Nutritious and healthy. I am not talking about high calorie. Faculties could get entry and exit only because of Dr. Pratin, Dr. Jainul, Rohit and Ricky. They could go home with sweet memories of the conference because of this team. Jainul, at odd hours also, they did perform the job very well. We are really thankful to them. I beg pardon of all those whose name I am missing here. So we are also thankful to all the delegates who participated here in the conference to make this conference a great success. And at the end, I wish blessings of all the committee and well wishes at the start of my journey as President AOBG 2022. Thank you.
I would request Rakesh sir to present a few more mementos. Salim bhai, આવી દીધું? હા, મોમેન્ટો આપી દીધું? ડોક્ટર પરાંગ સર, મોમેન્ટો અપાઈ ગયું? ડોક્ટર અંકિત પરમાર? ડોક્ટર પ્રતિન શાહ? Dr. Ketan Shah, Dr. Snehal Desai, are they here? Okay. With this, we end our validity function. And I request everybody to come join us on the stage for the group photographs.
My dear friends, it was a very short notice, and this was a historical event which we organized when we thought that we were in dilemma whether we will be able to held it or not. And with that dilemma in mind, we arranged and we successfully completed. So, hip hip hooray for Rakesh and all team members. And of course, Kanak, Chetan bhai, Manish, and dynamic Prashant. Thanks to everyone.
Anybody else who want to share their views? Nirmal sir.
હંમેશની જેમ આ વર્ષે પણ સુરત સ્પેક્ટરે બહુ સારામાં સારું કામ કર્યું છે, સારામાં સારી કોન્ફરન્સ ઓર્ગેનાઇઝ કરી છે અને એનો એક જ જે મુખ્ય શ્રેય છે તે આપણે સૌને એટલે સુરતના જેટલા બી સ્પેક્ટના મેમ્બર છે સૌને જાય છે. છેલ્લા 2 દિવસથી બહારથી જેટલા પણ ડેલિગેટ આવ્યા એ વાત કરતા હતા અને એમ જ કહેતા હતા કે સુરતમાં જે પ્રોફેશનલિઝમ જે જોવા મળે છે છેલ્લા 15 વર્ષમાં કોન્ફરન્સીસ કરવાનું એ કોઈ જગ્યાએ જોવા મળતું નથી અને એનાથી જેટલું બધું અંદર ખુશી થાય છે, દિલ ગદગદ થઈ જાય છે. અને અમે એમ જ કહ્યું કે એક અમારી જે આખી લેડરની પેટર્ન એક એવી સેટ થઈ ગઈ છે કે દરેક કોન્ફરન્સમાં ધીમે ધીમે લોકો બહાર ઉપર ચડતા જાય છે અને નીચેથી લોકો ઉપર આવતા જાય છે. એટલે કોઈને પદનો મોહ નથી, કારણ કે ઓટોમેટિક સેટિંગ જ એવું થઈ ગયું છે કે ઈચ એન્ડ એવરી પર્સન હુ વોન્ટ્સ ટુ વર્ક દેર ઇઝ ઇનફ વર્ક હિયર ટુ કન્ટ્રીબ્યુટ અને બધા સરસ સારી રીતે કોન્ટ્રીબ્યુટ કરી રહ્યા છે. જે રીતે સુરત પીડિયાટ્રિક એસોસિએશનનો પાયો જ્યારે પણ નખાયો ત્યારથી લઈને આજ સુધી જે રીતે સ્પેક્ટ કામ કરી રહ્યું છે મને લાગે છે કે આપણા દેશમાં ઇન અવર કન્ટ્રી ઇઝ એન એક્ઝામ્પલ. અહીંયા કોઈનો કોઈ ઈગો નથી, દરેક જણ જે રીતે સારી રીતે કામ કરી રહ્યા છે દેટ ઇઝ ધ ટીમ એફર્ટ. સો બાય ઓલ બેસ્ટ વિશીસ. અને સાચું દિલથી કહું ને તો 2 દિવસ કાપસે સાહેબની ખોટ બહુ ચાલી. બહુ ખોટ ચાલી, કારણ કે જ્યારે બી કોઈ લેક્ચર બોલાય ને સાહેબ તો ઊભા જ થઈ જાય. અને we felt his absence. Somehow it was a very unfortunate thing. We paid a heavy price of this COVID, but anyway, समय आगे चलता जाता है, सब कुछ आगे चलती है. Yes, yes. We really missed him. We really missed him. So, anyway, સમય છે કોઈના હાથની વાત નથી પણ બહુ સારી રીતે આપણે બહુ સફળ આયોજન કર્યું. રાકેશ અને હોલ ટીમ. રાકેશને હું સમજી શકું છું. આઈ થિંક ઇઝ ધ મોસ્ટ પરફેક્શનિસ્ટ મેન. એવરીથિંગ બહુ પરફેક્શન સાથે કરવું. સો આઈ કુડ અન્ડરસ્ટેન્ડ વોટ સ્ટ્રેસ યુ હેવ અંડરગોન ફોર ધ હોલ યર. યસ બટ ધ હોલ ટીમ ઇટ્સ એ રિસ્પેક્ટ. અને બહુ સરસ છે. એ જ વાતનો આનંદ થાય છે અને આવનારા વર્ષો સુધી આપણે આવું સારું કામ કરી શકશું. આજે જે મને લાગે રાજેન્દ્ર વર્મા was saying કે આપણું પ્રેઝન્સ હવે બધે જ દેખાય છે. ઇવન નેશનલ લેવલ પર લગભગ 20 થી 25 જણા આપણા કોઈને કોઈ જગ્યાએ પાર્ટિસિપેટ કરે છે કોન્ફરન્સમાં. ચેતનને હમણાં જ કહેતો હતો કે સુરત એક એક્ઝામ્પલ પૂરું પાડી રહ્યું છે દરેક જગ્યાએ, નોટ ઓનલી ઇન અવર સિટી બટ એટ ધ સ્ટેટ લેવલ ઓર નેશનલ લેવલ. આઈ થિંક બહુ જ આગળ આપણે વધીશું અને વી આર ઓલરેડી કન્ટ્રીબ્યુટિંગ. દિગંત શાસ્ત્રી નેશનલ પ્રેસિડેન્ટ સુરતથી થયા. હી વોઝ ધ ફર્સ્ટ નેશનલ પ્રેસિડેન્ટ ઓફ સુરત. મને લાગે બીજા 4-5 લાઇનમાં છે. જ્યારે સમય આવશે લોકો નેશનલ પ્રેસિડેન્ટ તરીકે આવશે. ઓલ ધ બેસ્ટ. થેન્ક યુ વેરી મચ. થેન્ક યુ.
આઈ થિંક અહીંયાથી જ બોલીશું અને વધારે નહીં બોલીએ. બરાબર. હવે બોલાય? ના. So again, yes, it is a most pleasurable moment for all of us. We got good appreciation, praising words by outsiders. At the same time, બહારના લોકો ઘણીવાર ફોર્માલિટી માટે બી કહેતા હોય પણ આપણને પોતાને બી આજે એક સેટિસ્ફેક્શન છે જ. There were lot many doubts, lot many fear in all of us કારણ કે કોવિડને રિલેટેડ સિનેરિયો શું રહેશે અને એને લીધે પછી ડાયલિગેટ્સ નંબર ને પછી એ વચ્ચે ફાર્માની સ્પોન્સરશિપ. સો there were ટાઈમ એન્ડ ટાઈમ આપણી એપ્રિહેન્શન બદલાતું રહેતું હતું પણ ઓલ અવર એપ્રિહેન્શન્સ વેર નોટ પ્રૂવડ ટુ બી ટ્રુ. નેચર કો, ગોડ કો, સુપ્રીમ પાવર કો, આપણા બધાની પોઝિટિવિટી કો, ઓલ ધીસ થિંગ્સ હેઝ હેલ્પ અસ ઇન કન્ડક્ટિંગ ધ થિંગ્સ ઇન અ ગુડ વે. આપણે ફરીથી એક વખત સ્પેક્ટ એવોર્ડમાં તો જીતીએ જ છીએ પણ ઇવન એઝ અ જે બહારના લોકોએ જે એક્સપ્રેસ કર્યું સ્પેક્ટની યુનિટી, સ્પેક્ટની ટીમની એફિશિયન્સી. સો આઈ થિંક દેટ ઇઝ અ રિયલ એવોર્ડ. કારણ કે પેલા એવોર્ડમાં તો શું છે કે તમે શું લખો છો, કેવું એ કર્યું છે એના ઉપર છે. દેટ મે નોટ બી ધ ટ્રુ બટ અહીંયાની જે આપણી એક્ટિવિટી છે, આપણી જે બોડી લેંગ્વેજ જોઈ હોય, આપણને વર્ક કરતા જોયા હોય ને ત્યાર પછી એ લોકોએ આપણા માટે જે વર્ડ્સ કીધા સુરત માટે અને બધા લોકોએ કીધું, ગુજરાત બહારના લોકો, એવું બી નહોતું કે જે લોકોને ઇલેક્શન લડવાનું હતું એવા લોકોએ પ્રેઝ કર્યું. આજે ડૉક્ટર રમેશ કુમાર તો ઓલરેડી નેશનલ પ્રેસિડેન્ટ બની ચૂક્યા છે. મારે બપોરે એની જોડે હું ચેતનભાઈને અમે બેઠેલા ત્યારે વાત કરી તો એણે એ જ કીધું કે ધ સ્પેક ટીમ હેઝ ડન વન્ડરફુલ જોબ એન્ડ ઇટ ઇઝ અ એક્ઝેમ્પલરી વર્ક. સો આઈ થિંક વી શુડ કીપ ઇટ અપ એન્ડ એઝ સેડ બાય નિર્મલભાઈ કે હવે પછીની કોન્ફરન્સોમાં અહીંયાના જે 5 જણા છે, 5 કે 7 જણા છે તે લોકો એડવાઇઝરી અથવા તો પેટર્ન એ જ રોલમાં રહેશે અને વી વિલ હેવ ધ સેકન્ડ લાઇન ટેકિંગ ધ ફર્સ્ટ લાઇન એન્ડ થર્ડ લાઇન ટેકિંગ ધ સેકન્ડ લાઇન એન્ડ that is how we can develop our our generations of leaders. અને we are happy to see કે આપણા બધા જ છોકરાઓમાં છોકરીઓમાં સરસ લીડરશિપ અને સરસ qualities છે. And so the future of SPECT is very bright. There are many areas where due to various reasons we had some hitches. But I think that I will discuss one to one. Maybe today is not the right day. But again, yes, we have to improve in certain areas where we had some problems. So એ આપણે ભવિષ્યમાં ન થાય એના માટે છે. Right? So again, once again, congratulations to all the Spectians, all the team members, and 3 cheers for Spect. Hip hip, hip hip, hip hip.
થોડા આગળ આવી જાઓ બધા. સલીમભાઈ.
Good evening, friends. In the absence of Dr. Manish, due to his ill health, I am in charge secretary, and we are I request President Dr. Yogesh Parikh to conduct special general body meeting.
Good evening, friends. Respected seniors and friends, we are going to conduct the ratification of the special general body meeting. Special general body meeting held on the 10th July at the during the midterm conference at the Patan, and we have passed the resolution after the thorough correction in the old constitution, and with the help of past President Dr. Hiren Patel and his team, and members Dr. Digant Sastri, Dr. Satish Bhai, then Samir, Dr. Kirit, have gone, and President Secretary gone through the old constitution, and after the 3-4 years Mohammed task, we have done some changes in our old constitution, and we are going to make the new constitution with some careful observations. So we already discussed in the length and deliberated on and then after the 3/4 Zoom meetings also, we have made some corrections. And all the resolution passed in the last meeting, special general body meeting. So this is the ratification of the special general body meeting. So Dr. Kirit will go through some corrections after the Zoom meeting, and we will go through then passing of this.
Last SGM for Constitution Amendment was conducted on 10th of July 2021.
Hello. Hello.
Hello. So my request is that when you are reading out the minutes, I think what you briefed to the House was little bit confusing, and because this is a ratification general body meeting, so what I suggest that you just narrate the sequence of event which in which order you had done. I think the sequence here was a little bit mix up, so I know the things because I was part of everything. But for the better knowledge of the audience, it will be good that if you just narrate that when what draft the committee gave, then the draft was discussed in the EB, then it was circulated to the members sequence. Or if you wish, I can, I or Kirit can, Samir also is here.
So we are 5 persons in the meeting, which Constitution Amendment Committee. Dr. Digan Shastri, Dr. Satish Pandya sir, Dr. Samir Shah sir, Dr. Hiren Patel sir, and my Dr. Kirit Sisodia. So as a part of Constitution Amendment meeting, I request Dr. Digan Bhai to brief House about the whole the proceeding.
I will just narrate the sequence of working of the committee. So the committee had earlier, this job was assigned in 2019, but 2020 we could not do the work because of the COVID. So again in 2021 the work started. There were several rounds of Zoom meeting discussion amongst the Constitution Review Committee members, and then the existing draft, which was earlier registered with AOP, Charity Commissioner, in that draft, the suggestions were incorporated. Even there were some sentences which were rephrased. There were no changes, but sentences which were not having clear message or what exactly it means to say. So they were rephrased, and this draft was submitted to the Academy of Pediatrics Gujarat Executive Board. I think the Academy of Pediatrics Executive Board then discussed it there, and then it was circulated to all the AOPG members with the old and new, both. And then the suggestions were invited. I don't know how many suggestions you received, nil. So what I mean to say is that you should tell like this. There were no suggestions, and then the matter was discussed in the general body, special general body at Patan, and each and every line of the Constitution was read. It was not just the highlighted, suggested changes, but each and every line were read, and even there were no correction or no changes in the rule, but even the sentence which was rephrased, that was also clarified to the House. So this was the procedure, and at that time, on each suggestions, means changes which were suggested by the Constitution Review Committee, they were also discussed, and some of the agenda there were even debate also, and it was ultimately passed by the House. So I think if such clear narration is done, it creates misunderstanding, as well as it should be properly documented as a procedure also.
Thank you, Dr. Digan sir. So now I will quickly read the minutes of last SGM Constitution Amendment on 10th of July 2021 at University Convention Hall, HNGU. SGM was called for Constitution Amendment. Dr. Hiren Patel briefed all. Constitution Review Committee was formed at Udaipur GIPEDICON in December 2019. The committee was headed by Dr. Hiren Patel. Other members were Dr. Digan Shastri, Dr. Satish Pandya, Dr. Kirit Sisodia, and Dr. Samir Shah. They were done a very hard work. Lots of meeting and discussion were done, and the final draft were discussed in EC meeting, and suggestions done by EC were accepted, and the final draft was sent to each of the member of AOPG through the mail, as well as link was sent in the SMS. Till now, no objection was received. Dr. Hiren Patel requested Dr. Satish Pandya to proceed. The Dr. Satish Pandya thanked AOPG for giving him the responsibility. He also thanked Dr. Hiren Patel and other committee member for continuous help and support. Dr. Satish Pandya started reading the old version as well as the changes suggested by CRC. The post of Vice President has been added. The Ahmedabad zone converted to the capital zone, Dr. Abhay Shah and Dr. J.K. Gosai requested to keep the name of the capital zone as Ahmedabad zone only. Whether the PSSS representative will have a voting right in AOPG EC meeting or not, for how much time the PSSS representative will remain present in the EC meeting, and whether his suggestion given to the EC will be considered valid or not. Dr. Hiren Patel replied, PSSL representative cannot have voting right. His time in EC meeting will be decided by the president. Dr. Kanaksi Surma asked, what if a president-elect candidate has completed 9 years while filling from form for president-elect, as after 1 year when he become president he will complete 10 years. He said the election for the president-elect and not the president, so we should change that in constitution. Dr. Abhay suggested we should review it from the central IAP and incorporate it in our constitution. Zonal EC candidate must have completed 5 years as a AOPG member. If any EC member completed 2 terms consecutive, and then he or she must have 2-year break before he or she becomes EC member again. Maximum 3 terms are allowed. 19E, President and Vice President posts will rotate among 5 zones. Dr. Nehal Patel asked the CRC if a member is Central IAP member for a long but not a AOPG member, then he or she can become EC or not. CRC replied that by the rule, he or she must have completed the required year of AOPG member. Dr. Nehal Patel said, as Central IAP is giving share to the state and city branch from his or her Central IAP membership fee, then why cannot be he or she automatically be a member of AOPG and city branch? The Yognesh Popat asked, as Central IAP is giving rupees 2,500 to state and city branch respectively from the Central IAP membership fee, then why AOPG is collecting 2,000 rupees as a membership fee? Dr. Hiren Patel replied, Central IAP is giving contribution fee to state and local city branch, and AOPG is collecting membership fees. Dr. Som Shekhar said whether Dr. Nehal Patel should pay 2,000 rupees as a AOPG membership fees. Dr. Digan Chatri said yes, if she does not have any receipt of AOPG membership fee. Dr. Manish Mehta said any pediatrician whose name is not there in the secretary's record of AOPG member, or who does not have a receipt of AOPG membership fee or does not have any other evidence of AOPG member, must finish the formality of becoming a AOPG member. CRC accepted the suggestion done by the member. It was proposed by Dr. Rajesh Maheswari and seconded by Dr. Somsekar and passed by all. Dr. Satish Pandya thanks Dr. Abhay Shah, who had done tremendous work in making original constitution. Dr. Satish Pandya thanked Dr. Hiren Patel for doing commendable job. Dr. Yogesh Paris gave special thanks to Dr. Manish Mehta and Dr. Shamisha, who worked tirelessly for constitution review. Dr. Manish Mehta thanked all the members for active participation and valuable suggestion. He thanked Dr. Monish Shah and AOG Patan for excellent organization and providing all logistic support.
So this was the earlier SGM meetings minutes. So it is already discussed in the past also. So any correction? If no, there is no need of the correction. So yeah, formal reading. Samir bhai, any inputs from your side? Okay. So it is a office working, and we will for the especially for the election purpose and this yeah, conference purpose.
national conference માં જે લોકોનું all the past president હોય
હા હા yes. So one Samir bhai, one suggestion came from the our respected senior past presidents, like the central IP national past presidents, they are invited for the all the conferences. So we should invite all the past presidents. All the state past presidents and the state national state also no? It is in the procedure only, SOP. Yeah. But it should be a mention early. So we have to make the SOP separately. Okay. So one is the addition of the post of the vice president. Then second. તું જ બોલ દે ભાઈ સમીર તારી પાસે મોબાઈલમાં હશે અહીંયા ખાલી
પેલું જે ઈસી મેમ્બર હોય ઈસી મેમ્બર માટે પેલું 3 યર પછી બ્રેક એટલે કન્ઝેક્યુટિવ યર
વાઇસ પ્રેસિડેન્ટ
એટલે પ્રેસિડેન્ટ માટે આપણે ઇલેક્શન નથી કરતા આપણે જે આવે છે એ મેમ્બર એ વાઇસ પ્રેસિડેન્ટ એટલે સોરી પ્રેસિડેન્ટ ઇલેક્ટ માટે આવે છે એટલે પોસ્ટ જે બહાર પાડીએ એ પ્રેસિડેન્ટની ના હોય પ્રેસિડેન્ટ ઇલેક્ટની હોય એટલે આવ્યું બોલે ને શું
થઈ ગઈ
ના આપે ચોપડો અહીંયા છે
આપી દો તમે તારા મનીષભાઈ એવું કીધું મનીષભાઈ કીધું સમીરભાઈના મોબાઈલમાં છે લાસ્ટ
હલો એ હતું અને નેક્સ્ટ કે એવી રીતે રાખેલું કે કોઈ બી મુદ્દો જો આમાં ના એડ થયો હોય તો વી હેવ ટુ રિફર ધી સેન્ટ્રલ આઈએપી કોન્સ્ટિટ્યુશન એક એડ કર્યું છે
એ તો બાય ડિફોલ્ટ બધાને સેમ પેરેન્ટ ઇન્સ્ટિટ્યૂટનું લાગુ પડે છે અને ઇવન વી હેવ મેડ ધ MOU વિથ ધ સેન્ટ્રલ આઈએપી લાસ્ટ જાન્યુઆરીમાં અને એમાં ઓલરેડી ઓલ ધ સ્ટેટ બ્રાન્ચ અને ઇવન લોકલ બ્રાન્ચનું પણ એ રીતે છે સેમ કે વી હેવ ઇફ એની થિંગ ઇઝ નોટ મેન્શન ઇન ધ અવર કોન્સ્ટિટ્યુશન દેન વી હેવ ટુ ફોલો ધ સેન્ટ્રલ આઈપી કોન્સ્ટિટ્યુશન so we are going to pass this resolution and for the ratification Tushar bhai and Dr. Nehal madam. So thank you. પાટણ બંને તુષાર ભાઈ હતા બંને હતા ઇમ્પેક્ટમાં હતા ને બંને જણ So here we are means completed this ratification SGM, and thanks to all for your contribution, valuable contribution. Yeah. So Samir bhai, you have to take lead and pass this to the Manish bhai, and you both of you are assigned this job. And before the 30th December, we have to complete this task. Almost. And so thank you very much. Here we are concluding our ratification SGM. And again, thank you Samir bhai and Tushar bhai, Satish bhai, Digant bhai, Kirit bhai, and Hiren bhai, all have done the wonderful work. Thank you very much. Digant bhai, પૂરું કરીએ. આમાં શાંતિ જ હોય ને સાહેબ. હવે આપણું
Thank you, Yogesh sir, past President AOP Gujarat. Thank you. Past, sir.
31st સુધી એ પોસ્ટ રહેશે જ એમની, ભલે ઇન્સ્ટોલેશન પેલાનું થઈ ગયું.
Thank you, Rakesh bhai. Thank you, Kirit bhai. Thank you, Monish bhai.
So, દિગંતભાઈ અમે નીકળીએ એ પહેલાં જસ્ટ થેન્ક યુ વેરી મચ ફોર ધ સ્પેક ટીમ. હા એ જ અમે એ જ કહીએ છીએ દિગંતભાઈ. હા સો રાકેશભાઈ.
I am Dr. Tushar from Vadodara. Very happy that I am here in this GPACON which is organized by Spectians. અને એકચ્યુઅલી સુરત પણ બહુ ચેન્જ થઈ ગયું છે. બહુ વર્ષો પહેલાં સુરત જોયું હતું અને અત્યારે સુરત જોયું તો મજા આવી ગઈ. સુરતની સુરત બદલાઈ ગઈ છે અને સુરતીઓની સુરત પણ બદલાઈ ગઈ છે. અમને આમ સુરતીઓ માટે એવી મનમાં ઇમ્પ્રેશન હતી કે એકેડેમિક્સમાં વડોદરાવાળા આગળ છે એવું મને લાગતું હતું, પણ એકેડેમિક્સમાં પણ સુરતવાળા ઘણા આગળ છે. એટલે રિયલી અ બિગ ચેલેન્જ. ના સિરિયસલી એટલે બહુ જ મજા આવી બધી રીતે. પ્રોગ્રામનું આખું ઓર્ગેનાઇઝેશન એવરીથિંગ વોઝ વન્ડરફુલ. યસ્ટરડે ઇવનિંગ કલ્ચરલ પ્રોગ્રામ અને પરફોર્મન્સીસ બાય ધ talented pediatricians and family members of Surat. આમ ગૂઝબમ્સ થઈ જાય એવી મજા આવી ગઈ એમ. એટલે વી થોટ કે અમે અમારા એઓપીમાં એવો મેસેજ મોકલ્યો કે આપણે આવું કંઈક કરવાનું છે એમ. એટલે ઇટ્સ અ વન્ડરફુલ થિંગ અને વી રિયલી એન્જોયડ all of us. Everything was up to the mark અને thank you very much for having us here. Excellent.
સુરતનું મહેમાન ગતિ તો બહુ જ મજા આવે એવી હોય છે, પણ સુરતીમાં એવું કહેવત હતી કે એ લોકો ગાળો જ બોલ્યા રાખે, પણ આ વખતે આવી અને એટલું સંસ્કારી લાગ્યું, જેમ તુષારે કીધું કે સંસ્કારી નગરી. જસ્ટ એક જનરલ ઇમ્પ્રેશન એમ. એટલે બહુ જ મજા આવી સાયન્ટિફિકથી માંડી અને લંચ ડિનર એન્ડ કલ્ચર પ્રોગ્રામ અને ઇવન સાયન્સ બી બહુ સરસ હતું. બધા મિત્રોને મળવાની મજા આવી. હોસ્ટિંગ બહુ સરસ હતું. વી આર એપ્રિશિએટ વર્ક ઓફ ધ સ્પેક.
થેન્ક યુ. અને આવતા વર્ષે અમને આનાથી બી સારી કોન્ફરન્સ આપજો. જે કે આનાથી બી સારી કોન્ફરન્સ અમને હવે આપજો.
આશીર્વાદ જોઈએ બસ.
હવે કોને બીજા કોઈને બોલવું છે?
We will start our validity function right now. Right now. No, sir, right now. Everybody please take their seats. I will request our President AOP Gujarat and convener of GUJPEDICON 21 to come on the stage. I would request Dr. Chetan Shah sir and Dr. Kanak Surma sir to accompany Dr. Rakesh bhai. I request Dr. Nirmal sir, Dr. Digant sir. I request Dr. Nirmal sir, Dr. Digant Shastri sir. I request our co-organizing chairpersons Hitesh bhai, Vimal bhai, I request Prashant, my colleague, to join on the stage. Darshan bhai, Fagun bhai, our co-secretaries, Fagun bhai. Our treasurer, Neerav Jariwala sir. SPECT office bearers, SPECT President Kirit Bhai. Our secretary, Ankit. Ankit. Our advisors, Bankim sir, Vibisha sir. Our souvenir editor and our advisor and our advisor, Kamlesh sir. Without wasting much of time, I request our convener, Dr. Rakesh sir, to have few words for all of us.
So respected seniors and dear friends, this is a moment of great relief and satisfaction for all of us. Months of our hard work culminated into happy ending, and last laugh is ours. The recent news that from tomorrow there is 144 code at Vadodara. They have already implemented from tomorrow because of COVID, and we are fortunate that we have completed our function today.
બધાને ઉપર છે કે અહીંયા છે?
I once again thanks our photographers, Paresh Bhai, our audio-visual persons who are staying till late since tomorrow with us, Utkarsh Agency, the venue provider, Awadh Utopia, and all the other agencies who are with us and made this 2 days a memorable event. Thank you very much. Thank you all.